what not, device closure, dual chamber pacemaker, and everything we stand first. So all my staff should know the basic. Without theory, the practice of medicine is mere a matter of habit. This is my father used to write this quote everywhere. Without theory, the practice of medicine is mere a matter of habit. So we should have a excellent knowledge about everything. So that is why I selected the topics in such a way that every aspect, each and every second will be very valuable. It's definitely going to be an academic feast. And everyone, I am so happy that useful to one and all of you. Now I call upon my excellent academic, that is everywhere, wherever he is called, he will be there. And before, I wanted to come earlier than him, but today also I failed. He came earlier than me. So such is the academic interest, you'll know. So he is a man. So he is a man of knowledge, everything, discipline, everything. So you are so fortunate. You are so fortunate to get the knowledge from our dear Professor Dr. Chennai.
Nursing Home Trichy. A highly respected clinician and academician.
Okay, finish. Not waste time. So people came here to learn ECG, not about me. Aspect of his service. Sir, I wish you very peaceful, helpful, very healthy, and of course, prosperous retired life. Many people for us, for many of medical college, of TIRUNELVELI Medical College. So, the problem is, I am going to talk about the most difficult topic to start with, ECG and Echo Club of Trichy. And of course, many went away from cardiology, so they became as a gastroenterologist and neurologist. When they came to white QRS complex tachycardia, they ran from the medical college itself. They became engineers and auditors and so on. So such a difficult topic is white QRS complex. Tachycardia is a tachycardia means the heart rate is more than 100. So the heart rate is more than 100, and of course your QRS width of the tachycardia. So it's a white QRS complex tachycardia. The width is 0.12 and the heart rate is more than 100 is defined as white QRS complex tachycardia. Then we club atrial fibrillation. It could be a white QRS irregular tachycardia. Once again, I tell you, if the supraventricular rhythm is atrial fibrillation and the antegrade conduction is going through the monomorphic, by which we mean if you look at a single given lead, for example, you look at V6, all your QRS complexes are the same configuration focus. So this is called monomorphic white QRS complex tachycardia. Then if you look at this white QRS complex tachycardia, each polymorphic ventricular or polymorphic white QRS complex tachycardia. So it can be a monomorphic or polymorphic. Then the white QRS complex tachycardia has to be seen from V1. So next thing you must see is look at V1. So V1 can be a positive white QRS complex tachycardia, or V1 can be a negative white QRS complex tachycardia. That we say the V1 is positive, we say it is positive, it is RBB type. And urgent and correct decision has to be made, and it also has got a therapeutic implication that you cannot give a wrong drug to a white QRS complex tachycardia. So because of these three reasons, it's very, very important to diagnose time it is VT. Patient has got a basic cardiomyopathy like that is likely to be weak. And third is family has sudden death, it can be a long QT syndrome and so on, Brugada long QT syndrome. And drugs are producing QT interval prolongation. The patient is on that drug and the patient comes with a white QRS, it is likely to be VT. If you have hypokalemia, hypomagnesemia, the patient is coming with a white QRS, it is likely to be VT. And these two, ventricular tachycardia, the ventricular ectopic pacemaker is firing rapidly. At the same time, your sinus node is not ideal. It is continuously producing a beating of 60 to 100 per minute. But the problem is the sinus beat cannot reach the ventricle because the patient comes large way, a very large way. Sometimes the right atrium will contract against the closed tricuspid. The atrium and ventricle will contract simultaneously. So the right atrium contracts against closed tricuspid. All the right atrial pressure will be transmitted to the jugular veins and it will have an intermittent. So intermittent canal wave itself without ECG can tell you this white QRS complex tachycardia is likely to be VT even before you take an electrocardiogram. And of course other sign of AV dissociation is varying intensity of a SARSA. For example, if you auscultate the patient, if you still carry the stethoscope to your clinics, still carrying stethoscope to your clinics, still auscultating the patient and still auscultating and getting the heart sounds into your ears, then you can appreciate the varying intensity of first heart sound. So a very good clinical sign of AV dissociation. So when these things are there, it is likely to be ventricular tachycardia, wide QRS, and of course in an AV and RT, that is the atrioventricular re-entry tachycardia, it is because of that a simultaneous retrograde and antegrade conduction of the atrium and ventricle. For all beats here, the right atrium is contracting against proceedings. Because all beats is contracting proceedings are regularly occurring Cannon wave. It's called frog sign. So just Cannon wave tells you it's SVT or VT. Intermittent Cannon waves is VT. Regularly occurring Cannon waves is not only SVT. In SVT, it is atrioventricular re-entry tachycardia. Such an amount of clinical clues are there to diagnose a VT versus SVT. But please remember, hemodynamic stability or instability does not differentiate between SVT and VT. Most often we think SVT is stable and VT is unstable. The opposite things always happen. So don't depend upon hemodynamic stability to diagnose VT or SVT. Then we come to the electrocardiogram. The electrocardiogram signs, I can divide them into easy signs, not so easy signs, and difficult signs. And depending upon your standard, you can stop at whatever level you want. For example, you don't want to know not easy signs and difficult signs, you close your ears and eyes. And of course, people are a little bit advanced, can go up to difficult signs. So that's why I divided them easy signs, not so easy signs, and difficult signs. So the easy signs are only 4. So whenever the QRS width is very, very wide, whenever QRS is very wide, it is occupying more than 4 small squares. So most often it QRS. We tell you about the concordance and electrical axis, and you have to always compare whenever the patient comes with the white QRS tachycardia, always asking whether the previous ECGs are available, whether ECG during the sinus rhythm is available. That's a very, very important clue to diagnose whether it is VT or SVT. First, we look at the width of the QRS complex. Look at this white. So first of all, you know it is a tachycardia because heart rate is more than 100. Then you know it is a white QRS complex because the tachycardic QRS complex is more than 120 milliseconds. And R interval, that R, the interval between the 2 successive R waves is continuously constant throughout the ECG. So this is a white QRS regular tachycardia. Once you know that, then you have to differentiate between VT and SVT. Look at the width of the QRS complex. It is almost occupying 1 big square, but is 200 milliseconds or 0.2 seconds. So white QRS complex is likely to be ventricular tachycardia. Then we look at what is known as concordance. So concordance is otherwise known as, for example, if you look at the normal, ECG, some ECG, many times in a ventricular, especially when you look at chest leads, always they will show RS pattern. Everything will not be positive, everything will not be negative. Some ECGs are small R wave DPS, and some waves are small Q and tall R wave, like this RS pattern in concordance. Either everything is positive. If you look at V1 to V6, everything is a positive QRS complex. This cannot happen in a pre-existing bundle branch block with SVT, because in any bundle branch block, V1 and V6 cannot look the same. If a right bundle branch block, V1 is positive, terminally V6 is negative. In left bundle branch block, V1 is negative and V6 is terminally positive. So in a bundle branch, everything is positive, is called positive concordance. V1 is positive and V5, V6 is positive. Then V1, V6 look same, and you don't have that RS pattern in any of your chest leads, is likely to be a ventricular tachycardia. Very good method of saying it's a ventricular tachycardia. Sinus rhythm, it is likely to be VT, because what happened is that VPD which were happening occasionally started taking the control of the heart, and continuously the ventricular ectopy, whatever it is, what is tachycardia? It is continuous run of premature beat without intervening sinus beat. So if our configuration of VPD is exactly the same as the configuration, of the white QRS complex tachycardia, it means that VPD is running now continuously. So it is likely to be a ventricular tachycardia. And this is the most important point to say, that is the important point to say why we have to compare the patient's old ECG in sinus rhythm. Then look at the width of the QRS complex during the ventricular tachycardia, during the white QRS tachycardia and the sinus rhythm. Now in this situation, your sinus rhythm QRS complex is very wide. But during tachycardia, you look at the QRS width, it is relatively narrower than the basal bundle branch block in sinus rhythm and other bundle branch pattern in white QRS tachycardia. It cannot be SVT conducted with different bundle branch block during sinus rhythm and white QRS tachycardia. Look at this example. So during the tachycardia, white coarse tachycardia, I have an LBB pattern because V1 is negative and V5, V6 is positive. What bundle branch block I have in sinus rhythm? Sinus rhythm also I have left bundle branch block. So sinus rhythm and also during white coarse tachycardia, I have the same bundle branch block pattern with the same width of the QRS complex. Then it is likely to be SVT with the rubberancy and not ventricular tachycardia. So look at the sinus rhythm. If it is a different bundle branch block pattern, it is VT. Same bundle branch block pattern, not only that, same QRS width is likely to be SVT with bundle branch block. Then we come to, these are the EC signs. The EC signs are what? You have a very wide QRS. Then you look at the concordance. It's so easy. V1 and V6 are looking same. Then we look at the axis. If the impulse is coming up and right, it is likely to be VT. Then 3 points when you compare the sinus rhythm versus the white QRS tachycardia. Whether I have a VPD and during the tachycardia also the VPD configuration is maintained, it is VT. Then the type of bundle branch block in sinus rhythm and also during the white QRS is different, it is VT. The width of the QRS complex is less than the width of the QRS complex in sinus rhythm, it is VT. So these are the sinus EC signs. Now we come to not so EC signs. The not so EC signs are likely to be atrioventricular dissociation, capture and fusion beats, and not a typical bundle branch block pattern. Now we are going to explain you what is atrioventricular dissociation. What happens in ventricular tachycardia is a ventricular ectopic pacemaker is firing rapidly at the rate of 180 or 170 or 180. At the same time, your sinus node is not idle. It continues to produce a sinus impulse at the rate of 60 to 100 per minute. But the problem is because the faster beating ventricular rhythm, the AV conduction system is always kept at refractory period, absolute refractory period. Although there is no block in the conduction system, your sinus impulse cannot come into the ventricle because of the continuous absolute refractory period maintained by the faster beating ventricular ectopic pacemaker. So that means what happens is your atria are going to be depolarized by the sinus node and the ventricles are going to be depolarized by the ventricular ectopic pacemaker. So ventricular tachycardia, the concept is you have two pacemakers working. That is a very important thing. When you have two pacemakers working and you demonstrate in ECG two pacemakers are working, it is likely to be ventricular tachycardia, isn't it? Whereas in SVT, it's a single pacemaker, but it is going through the bundle branch block pattern. So you cannot have a two pacemaker. Left bundle branch block type of white QRS, where my V1 is going to be negative, V5, V6 is going to be positive. Then I have to concentrate on two leads. In both RBB and LBB, you have to concentrate on V1 and V6 to diagnose 1 and V6 to diagnose VT or SVT. For example, it is a SVT, VT or SVT. For example, it is a SVT. My initial R wave is very small and short, and R wave is very small and short, and my V6 will have a, this is a LBB pattern. So my initial R will have a, this is a LBB pattern. So my initial R wave is small and will not have any notch during the S wave, and I do not have any negative wave in V6. In a typical left bundle branch block, this is a SVT with a bundle branch block. I should not have any negative wave in V6. Any negative wave. Q wave should not be there in V6 because the first septal activation is occurring from right to left in left bundle branch block. So you cannot have a Q wave in left bundle branch block. So your R wave is sharp, no notch in the S segment in V1, and the V6 do not show a Q wave. It is likely to be SVT with a left bundle branch block. Whereas in do not show a Q wave, it is likely to be SVT with a left bundle branch block. Whereas in contrast, you see that my R wave is very broad. I have a contrast, you see that my R wave is very broad. I have a notch during the descent of the S wave. If we measure the onset of the R wave to the nadir of a S, it could be more than 60 to 70 milliseconds. A longer time for the impulse to go through the muscle. Here it is going through the conduction system. There is a muscle. So it takes a long time. 3 points here. My R wave width is more than 30 milliseconds. I have a look at V6. I have a Q in LBB. So if I have a Q in LBB during the white QRS tachycardia, it is likely to be VT. So this is the morphological criteria between SVT and VT. What you have to see is in V1, what are the signs? In V6, what are the signs? Now we come to the RBB type of white QRS tachycardia. I told you already, if I have a typical bundle branch block, I have a terminal R wave which is taller, RS R dash pattern in V1. RS R dash pattern where my terminal R wave is taller if it is SVT with RBB. If you look at V6, it's very, very important. In V6, always your R wave is taller than the depth of the S wave. If you have the RS ratio in V6, in a typical SVT with RBB, R wave will be taller at V1. So LBB, V1 is important. LBB type of white coarse complex in the S wave, and the distance between the beginning of the R wave to the NOS is more than 70 milliseconds. So it takes a long time for my initial depolarization to R wave is taller than the S wave, RS ratio more than 1. So this white coarse complex tachycardia, you definitely know it is likely to be SVT with a bundle branch block, because typical bundle branch block, terminal R wave is taller. In V5, V6, my RS ratio is more than 1. So it is no difficulty at all. But look at this type of white coarse complex tachycardia. What happens is, once again, I have a tall R wave in V1. So it's a RBB type of white coarse complex tachycardia. I have a monophasic R wave. I don't have a triphasic R wave. I have a monophasic single R wave. And look at V5, look at this and this. In V5 RBB type of white coarse complex tachycardia, if our V6 shows a small R wave on DPS, majority of times it is ventricular tachycardia, because it is not obeying the basic bundle branch block rule, where my R wave in V5, V6 should be taller than the depth of the S wave. So it's so easy to diagnose. So you can see that here, RBB type, hypertension, all that. So now, why it is VT? It is a RBB, V1 positive, RBB type. So what immediately you see? V5, V6. What is V5, V6? Small S wave, deep S wave, VT or SVT? VT, because my RS ratio in V5, V6 is less than 1. So immediately I know it is a ventricular tachycardia. So once again, you can see the tall R wave, RBB type, monophasic R wave. I now have triphasic R wave, but I look at V5, V6, my R wave is very small and S wave is deep. So it is likely to be SVT type, SVT. Look at this RBB type of white coarse complex tachycardia. You look at the classical RS R dash pattern in V1, triphasic pattern in V1. So you look at the triphasic pattern in V1 and look at V5, V6. What's happening? My R wave is taller than the S wave. So it is likely to be what? SVT or VT? It is likely to be SVT. So this is what you have to apply in your white coarse complex tachycardia. So a difficult ECG. So look at the difference here, but everything is negative. QRS configuration is changing, but the direction remains same. And the rate is 300 per minute. It is a very dangerous white coarse complex tachycardia, which is called atrial fibrillation. And the impulses are conducted through the antegradally through the accessory pathway, pre-excited AF. And it is a very dangerous condition where the patient can go at any time ventricular fibrillation. So same direction chest pain, you must have a definite critical occlusion of a major coronary artery. The same polymorphic VT occurring in the presence of a long QT is a torsade pointus. So here the torsion of points, some areas are upright, some areas are down, and in between you have a small QRS complexes. This cycle goes on. It is called torsion. The ribbon is downside now. In between you have a small portion of the ribbon. That's the torsade pointus. Up and down, a small QRS in between, a long QT. It is likely to be torsade pointus. In any torsade pointus in young, suspect congenital long QT syndrome. Any torsade pointus in the adult, look at the drugs he is taking, look at the electrolytes, and also the drugs he is taking. Many drugs will produce syndrome. So how to approach white QRS complex irregular tachycardia? Look at the rate, configuration, and direction of the QRS. My configuration remains same, direction remains same, and the width is remaining same. Rate is less than 200, it is AF with a pre-existing bundle branch block. I have a very fast heart rate. My configuration is changing, but direction is not changing. It is pre-excited AF. My both configuration and the direction and also the width is changing. In the presence of a normal QT, it is acute ischemia. In the presence of a long QT, it is torsade pointus. And another a very transient arrhythmia is called ventricular flutter. In ventricular flutter, what we see is a very rapid QRS complexes without well-defined T wave. That is the difference between ventricular tachycardia and ventricular flutter. In ventricular tachycardia, you will clearly see a QRS and the T wave, whereas in ventricular flutter, you will see only the QRS. So once again, it has got an equal importance and the recognition like a ventricular fibrillation. It's a question of time. We don't see flutter because it will immediately degenerate into ventricular fibrillation. And of course, the last arrhythmia. This is a last arrhythmia, LAST, this is a last arrhythmia, and majority of time we would have lost this patient. So last arrhythmia is ventricular fibrillation. It is a cardiac arrest. So T wave, a small undulating rhythm, the patient would have had a cardiac arrest, And when I ask you what is the treatment of ventricular fibrillation, many of you will say DC shock. No. Ventricular fibrillation treatment is immediate cardiac compression, cardiocerebral resuscitation. Immediately start cardiac compression, 100 compressions per minute. Ask for help, ask them to bring a defibrillator, charge and paste, and with a fraction of a second you shock, and continuously for first 3 minutes. Don't even stop a fraction of a second of these cardiac compressions. And that is a way to do for a cardiac arrest. Cardiocerebral resuscitation, not cardiopulmonary resuscitation. Don't bother about respiration, because before the arrest, the lung is full of oxygen. In contrast to your drowning and poisoning, where the oxygen is the problem. Here oxygen is not a problem. Here the circulation is the problem. So first 3 minutes, don't at all, don't have a 7 minutes. So after giving a shock, don't look at the monitor whether QRS is coming. QRS will be coming, but the pulse will not be there. But keep on compressing for first 3 minutes. Don't, then you give amiodarone, give shock, give but don't even a fraction of a second. Don't interrupt. 100 good cardiac compression, effective cardiac. You should not be giving side massage. So good cardiac compression for 300 beats per minute. And the end point of the success is when the patient beats you. Because he's got cerebral circulation restored, you will find somebody is sitting on him and pumping him. So he'll immediately beat you. So that is your success, and that is your happiness. So that is the first time in your life when somebody is beating you, you are very happy, is when your CCR is helpful. So when the patient becomes conscious, the end point of resuscitation, and not the QRS in the monitor. So that's why till the time you don't, first 3 minutes, don't. So the first treatment of ventricular fibrillation is cardiocerebral resuscitation, followed by DC shock, and not DC shock. By the time you leave the patient and go and find a DC machine in the next room, and the paste may not be there, and the pedal may not come, and the charge may not be there, by the time 3 minutes is over. So please remember that. So now we come. So this is a white QRS complex tachycardia. You diagnose by heart rate is more than 100 on the heart, and the due regular. So if it is a regular white QRS complex tachycardia, the two things I told you, VT, SVT, and the pre-excited ventricular white QRS complex tachycardia. 3 important, I told you the differences between SVT and VT and pre-excited. If it is irregular, once again 3, atrial fibrillation with a pre-excited bundle branch block, pre-excited AF, and polymorphic VT. And if you see both QRS and T wave, it can be regular or irregular. If you see only the QRS, it is ventricular flutter. If you don't see anything at all, and the patient is also seeing something, then it is a cardiac arrest, so it is a ventricular fibrillation. I think you are all like this now. I hope you are not like this now, because we told
most of the parameters, they interpret and immediately they send to the STEMI project, because we have got a group, the entire state is having a group, and every college is having a hub and spike. So they take ECG immediately. By that means we are able to lyse the patient, we reduce the mortality of STEMI. We are able to lyse the patient, we reduce the mortality of STEMI. That is success of our STEMI project, because of people like Chennappan sir, who is taking classes excellently for the paramedical stuff. We are concentrating only on the DMPGs or MDPGs, but most important time when
interval. So that is the one problem of STEMI you can miss. Are perfused by watching on the right atrial ventricular groove, supply the right ventricle, and majority of times supply the inferior wall of the ventricle. So the leads you have to see for right coronary artery is L2, L3 AVF, and also V1. So this is the area which is supplied by right coronary artery. Whereas your left-handed descending artery running on the anterior interventricular groove is going to supply entire anterior wall of the left ventricle and also the septum. Will be more than AVR elevation, telling me my injury rate is not only going up, it is of 98 to 100% with a reasonable sensitivity to diagnose all these conditions in scientific material. Then we come to the QRS is low. What does it tell you? The sinus arrhythmia. Sinus arrhythmia you expect in RC, because the sinus code in 60% is supplied by right coronary artery. Whereas in but this ECG sign tells you is aborted state, and this is called the D with very tau T wave. The absorbing is similar to the semi-tau and it's called the D with the sign. It is a STEMI equivalent. It is almost 100% immediate occlusion. So the patient should go for a cath lab. Non-ST elevation.
First 3 to 4 months, I do 30% of my procedures without stent with cardiology.
30 excellent lecture, making a big topic. Good. Any more questions?
Yeah, a few studies underway, sir, between two-stent strategy versus
Isolated.
Yes, that again is going on. Again by Anthony Colombo. As you know, the ostium of the circumflex is still regular seal of angioplasty. The reason is very, very verified. In bifurcation lesions, left main, ostial LCX. Try to get away with the provisionals and try to do a depth for the osteomyelitis. As of now, it is not correct to do a depth for a kissing balloon. Let's say you stented with extent in the left main. You cannot put another depth within the left main stent because that contains again another drug, and you don't know how much of drug is going to, because that stent, whatever be the signs or onyx or whatever, that contains another drug, isotolimus or everolimus or whatever the drug may be. You put another drug there, so we don't have evidence for that. So what you do, if you have to do, you finish off with a kiss and depth the LCX, do a final pot, out you come. Don't kiss with a depth because you don't know the amount of blood which will go into the already stented left. But I can tell you, results with ostial proximal, you think the trick is to use a long balloon. Take 20, 25, 27, there are some metronic balloons now available, 27 pre-dilatation balloons, prolonged inflation, give it 1 minute, give it 2 minutes. Prepare the bed, preconditioning, prepare it, do it once, twice, hold on for 1 minute, 2 minutes, wait. 2 things I look for, whether there's any staining or dissection. Recoil, give it a few minutes. No recoil, no stenting, you are fine. You don't need a IVS catheter or OCT. Go depth, finish off with a pot and come out. Excellent results with ostial and proximal surge. Really, I am telling you, here is an answer for us interventional cardiologists to come very close to the surgeons. Probably with BVS, I'm not sure whether you can put a BVS in the osteomolar circumflex. That's not the area where the restenosis is going to be 70 to 80%. What 2 stent strategies? Most of them come back. Whatever the strategy may be, QLAT or DK or whatever you want to call that as. None of these things are. That can be a bailout procedure. That's it. I hope I answered your question.
One more thing is, osteal LCX is a notorious place to go for restenosis. In that place, the DEB is more useful.
Exactly, so that's exactly what we're saying.
Bharajan. Yes.
For which one, sir? No, I don't get the question. For straight away depth for what, sir? Followed by?
All cases, straight away go for depth.
Can you do that? So you cannot see. This is the point I want to emphasize is that this is just a drug delivery balloon. It is not going to predilate. And you have to be very careful. Do not touch the catheter. Do not keep it in liquid or blood for a long time. Go inflate. The dwell time must be 90 seconds to 2 minutes. Keep it on, come out. But prepare the bed well. Whatever, even if it's a distal LAD, or PDA, PLB, whatever it may be. Prepare the bed well. Take a longer balloons, prolonged inflation, pre-dilatation. Take your time, take your time, take your time. Back to your basic angioplasty skills. That is the key. Once you prepare the bed well, even you can accept a 40% diameter residual stenosis, that's fine. You don't need OCT imaging or IVS for that. Then you go, take it, finish it off with 2 minutes of depth. Excellent results. Excellent results. One VVVIP of Madurai, a pediatrician's father. Same thing, long circumflex. I sent it to LMLAD. Long circumflex. I did about 2 years back. Just prox ostium and prox circ. I did a restudy. Pristine stent, pristine circ. This you cannot get with stents. No 2 stent strategy. I mean, I'm not saying provisional is equal to 2 stent or single stent. Provisional is a different strategy altogether, but provisional 2 stents come in as a bailout procedure. Provisional is not synonymous with single stent strategy.
So above nominal pressure, if you go 1 or 2 atmosphere more, is there any delivery difference? Drug delivery difference?
I don't know, Dr. Bharati. I don't have the science to say that. But what I do is I'm very, very careful in pre-dilatation. I know what exactly I'm going to do with that balloon. So if it is a 2.5, I predilate with a long 2.5, 20, 27, so that there is no dissection. No short balloons, 8-12 doesn't work. You will dissect. That is physics. You put long balloons, keep it prolonged for 1 minute down, prolonged for 1 minute down. Wait for a few minutes. No recoil, no dissection, then take your depth. There you will not see a dissection. Take longer balloons, prolonged inflation for pre-dilatation devices. Very simple trick. Very, very simple trick. Don't use short balloons, high pressure, no high pressures. See, like a diagonal. Let's say you want to do a diagonal. It's a 2.5 vessel. Just keep it there, 6 atmospheres, 8 atmospheres at 2, 1 minute down. 1 minute down. Nothing will happen. Long balloons, 20. Now, once it's open, take the depth, keep it for 2 minutes and come out. Pristine. That's the word I want to use. It grows with time. No late lumen loss. That is the difference.
Thank you, sir. We are pleased and enlightened to have the presence of our Vice Principal, sir.
Thank you. Thank you, Vivek,
Thank you, sir.
for your excellent lecture. Ravi, shall we go more? Right. We'll move on to next session.
Now I'd like to invite our speaker, sir, our chairpersons, Dr. M.S. Mahaboob Subhani, sir, Dr. Rajesh, sir, Dr. Nazar, sir, and Dr. Dhanaratnam, sir, Dr. A.K. Srinivasan, sir, Dr. Rajan, sir, and Dr. Balachandran, sir, onto the dais for felicitation. I now request our chairpersons, Dr. M.S. Mahaboob Subhani, sir, Dr. Rajesh, sir, Dr. Nazar, sir, to felicitate our esteemed speaker, Dr. Vivek Bose, sir. I now request Dr. Rajan, sir, to felicitate Dr. Rajan, sir, to felicitate our chairperson, Dr. M.S. Mahaboob Subhani, sir. I request the chairpersons to stay in the stage. I request Dr. Dhanaratnam, sir, to felicitate our chairperson, Dr. Rajesh, sir. I request Dr. A.K. Srinivasan, sir, to felicitate Dr. Nazar, sir. I now request Dr. Balachandran, sir, Professor, Department of Cardiology, to felicitate Dr. Dhanaratnam, sir, Dr. Rajan, sir, Dr. A.K. Srinivasan, sir.
அதிக இரத்த அழுத்தம் ஒரு சத்தமில்லா விருந்தாளி. உடலிடம் கேள்வி செல்வத்தை எழுப்பி மனதிடம் நிம்மதியை அளித்து இதயத்தை பொன்மணி போல் பாதுகாத்துக் கொள்ள வேண்டும் என்பதற்கிணங்க இப்பொழுது மெட்ராஸ் மருத்துவக் கல்லூரியிலிருந்து இதய நோயியல் துறை இயக்குனர் மருத்துவர் கே. கண்ணன் அவர்களை இரத்த அழுத்தம் குறித்த அறிவை நம்மிடையே மேம்படுத்த மேடைக்கு அழைக்கிறோம்.
தலைமை தாங்குபவர்கள் மருத்துவர் A.S. மோகன் அவர்கள், பேராசிரியர் மற்றும் துறை தலைவர் பொது மருத்துவம், திருநெல்வேலி மருத்துவக் கல்லூரி மருத்துவமனை. மருத்துவர் S. அழகேசன் அவர்கள், நரம்பியல் மருத்துவம், பேராசிரியர் மற்றும் துறை தலைவர் பொது மருத்துவம், திருநெல்வேலி மருத்துவக் கல்லூரி மருத்துவமனை. மருத்துவர் ரத்னகுமார் அவர்கள், பேராசிரியர் மற்றும் பொது மருத்துவம் துறை தலைவர், திருநெல்வேலி மருத்துவக் கல்லூரி மருத்துவமனை. மருத்துவர் R. பாலமுருகன் அவர்கள், மூத்த உதவி பேராசிரியர், இருதவியல் துறை, தூத்துக்குடி மருத்துவக் கல்லூரி மருத்துவமனை.
So, good morning to everyone. So, I am very glad to be a chairperson in this session. So, this CME is conducted in recognition of the work by our famous cardiologist, Dr. Ravi Edwin. He is my close friend. His father is my teacher, guide, everything. I was his student, MD. And he treated me as his one of the son. So Ravi Edwin is my brother. So he worked with me in our Department of Medicine as assistant professor. We both worked together for many years. So this CME, this topic by Dr. Kannan, so director of cardiology, very famous cardiologist. So I know him in various APA meetings. So over to Dr. Kannan sir.
Good afternoon everybody. It gives me immense pleasure to come out to Tirunelveli Medical College, where I started my medical career initially for about 3 months before moving to Chennai. I am extremely thankful to Professor Ravi Edwin for inviting me to speak in the same college where I started my medical education in 1984. So today the topic, which is a very common topic for both cardiologists, physicians, nephrologists and anybody practicing medicine, is hypertension. So we'll just have it's a bird's eye view, because the guidelines, many guidelines have come, and the most practical and most useful is going to be the European Society of Cardiology guidelines, which has come in 2024. The Indian Society of Hypertension guideline is expected in 2025 end or early 2026. And then you have the ACC guideline, which is being, every year it's being revisited. So we'll just have a brief look at where we stand with hypertension. Hypertension is basically, you have 4 major factors which play a role: genetic, behavioral, environmental and socio-economic factors, and also multiple mechanisms: renal, you have the neural, you have the vascular, and you also the hormonal. So these are the all these factors play a role in single disease. And in India is very unique, because you have a very high prevalence rates compared to many countries in the world, and there's a huge high or undiagnosed cases. So the most important step in this lecture, if you take it, is detection of hypertension, where we are grossly lacking. And among those detected, we are seeing that the patient treatment adherence is poor, and because of our faulty lifestyle of high salt diet, we are always in the receiving end of the brunt of hypertension. So if you see hypertension studies, the young age group 15 to 49 years, 45% of the individuals are only aware of the condition, which shows that, and only 8% have BP under control. So this is an alarming situation which we have got. And if you are going to achieve the NCD targets of reducing cardiovascular mortality by 25% and 25% related risk of hypertension, we need to bridge this gap of detection and management. Detection number one, management number two. So this is an NCD study, which was a very recent study, which found that this was taken at district hospital, community center, and 3 PSCs were part in every district in 18 districts in 9 states. And what they found is that what was the main contributor is the lack of manpower. We need, if you want to have a dedicated staff for measuring BP, we need to have 1% at the PSC level and 2 at the district headquarters level. So this is where we stand. There is a huge proportion of misdiagnosis. So it's basically a misdiagnosis or a missed opportunity. So Indian Society of Hypertension have been little liberal so far. Now they'll be upscaling definitely. And they have told that the optimal blood pressure here is less than 130 by 85. This has been disputed in the ASC guideline, who have come down to 10 points less. So then you have high normal, grade 1 and grade 2 hypertension. So if you see the recent comparison between the guidelines which are used in practice, we find that there is uniformity in only one thing, that is hypertension is more than 140 by 90. There's no dispute between that. If you take the ESC guideline, it doesn't tell us normal. It either says a non-elevated, elevated or hypertension. Non-elevated means a systolic less than 120 and a diastolic less than 70. Elevated means a systolic between 120 and 139 and a diastolic between 70 and 89. So why you need to know that is because in the patients with non-elevated blood pressure, there's insufficient data confirming the efficacy and safety of BP medication. So these group of patients should be managed only by lifestyle modification. And this is not based only on office BP. You have to live on home BP and ambulatory BP, because European guidelines very specific that out of office blood pressure measurements are extremely important in deciding on treatment, not only in the diagnosing, treatment, follow-up and compliance of patients. So if you take the other end of the spectrum, more than 140 by 90, cardiovascular risk is sufficiently, the benefit is very high to prevent cardiovascular risk. So these group of patients should be on pharmacotherapy. And in the group between the two, that is elevated blood pressure, you need to risk stratify these patients. You need to find out who are the high risk group who will benefit with the different pharmacotherapy, and then the other groups which will only go with the group of lifestyle modification. So this is the comparison of the different ambulatory BP, because you are got out office BP and out of office BP, home BP, daytime, ambulatory blood pressure during day and night. And what is most important is measuring the blood pressure. You must use a validated and calibrated device. That's very one. And it's very important that you must take the pulse rate in every patient in the first visit hypertension, because all the oscillometric BP apparatus that we use are not calibrated or not validated in patients with atrial fibrillation. So in that, manual recording has to be emphasized. And when you are going to, when we prefer out of office measurements should also be done, but it's not feasible or logically it's not possible, then you have to do multiple office visits in the standard format. And it's very important that you must measure BP in both the arms, and you must measure BP after 5 minutes rest, and you should also do it 1 minute and 5 minutes of standing. So this is what the Indian Society of Hypertension gives. 5, 2 and 3. 5 for wait for 5 minutes after patient's entry, measure BP in both the arms, and take 3 readings and average the last 2. So basically you have 3 settings which take the BPs. In clinical measurements, home BP and ambulatory BP. And ambulatory BP is the gold standard hypertension, because it can be used for diagnosis and individualizing hypertensive therapies. So how do you take an office BP? You have 8 steps. Measure at 5 minutes the patient sits comfortably. Use a validated device. Place a cuff at the level of the heart. 3 readings, take the average of 2. Choose further measurements. The BP difference between arms is more than 10. And measure BPs with both arms. record the heart rate, exclude arrhythmia, and assess for orthostatic hypertension. These are the 8 steps whenever a patient comes to a clinic to record your blood pressure. When you take a home BP, the common thing is use a validated device, but you should measure it in a quiet room for 5 minutes of rest. 2 readings you take and do it twice a day and record an average of all the BP readings. Anything more than 135 by 85 is considered as hypertension. Then the ambulatory BP, again validated device, 4 steps. Device records BP every 15 to 30 minutes daytime, 30 to 60 minutes at night, and at least 70% reading should be read about. Keep a diary of the status. So these are the important steps. So whenever you have a patient who comes to the office to the clinic, you have to stratify the patient. If the patient has got a non-elevated BP, you take 40 years as a consideration. If it is more than 40 years, the patient is more than 40 years, you need to screen the patient at least every once a year. If the patient is less than 40 years, you should screen once in 3 years. Whereas for a patient with hypertension, from 40 to 180, all these patients should be treated as hypertension with pharmacotherapy, whereas they are branded as hypertension. But in this group of patients, the elevated BP, 120 to 139 and 70 to 89, you look at 3 points. One, you look for high risk CVD indicators. You look at score 2 score, which is used to quantify what is the risk of 10% or more than 10%. If the score 2 is between 5 and 10, you look for risk modifiers. So first you look at high risk calculators, then you look at score 2 score of more than 10 or less than 5 to 10. And if 5 to 10 with risk modifiers, then you have to take the patients for pharmacotherapy. Otherwise, you have to go for only lifestyle measures. So whenever you say you have to go for, these are the 5 important things. High risk group, you take it. Moderate to severe CKD, established CVD, diabetes, hypertension mediated organ damage, and familial hypercholesterolemia. So in a patient who has got a with elevated blood pressure but doesn't come under hypertension, if you have either of one of these 5 factors, you have to treat with pharmacotherapy and keep the BP as close to 120 by 70 as possible. In the absence, if the 5 risk factors are not there, you calculate a score 2 score and find out if you are going to do, and score 2 OPs for the old patients, and you calculate the risk. The risk is more than 10%, then you have to give drugs. 5 to 10, you go to the next step and look at the other factors, which are the modifying factors, and then you go for the risk factor tools. For diabetic patients, you use a score 2 score. So these are the 5 indicators: established cardiovascular disease, moderate severe CKD, HMOD, diabetes, and familial hypercholesterolemia. If these 5 are there in a patient with BP of elevated blood pressure, you have to give pharmacotherapy. And then if you score 2 score is high and is 5 to 10 and you have these risk modifiers, either sex specific or shared modifiers, these group of patients also require pharmacotherapy. And you always look for hypertension mediated organ damage in all of these patients. Whenever you have an hypertension, which is a new onset or uncontrolled hypertension, or you have a resistant hypertension, or abrupt onset of hypertension, a family history of early onset, or onset of hypertension in young patients less than 30 years, or a previously controlled hypertension becoming worse, or you have a disproportionate target organ damage, or accelerated or malignant hypertension, or onset of diastolic hypertension in elderly people, or you have an unprovoked excessive hyperkalemia, you look for secondary or endocrine forms of hypertension. So of which the 3 main causes, though we say coarctation of aorta and all these things, they are all extremely rare, but there are 3 main causes: familial hyperaldosteronism, renovascular hypertension, and obstructive sleep apnea. So these are the 3 things which you have definitely roll out in secondary hypertension. So whenever you diagnose hypertension, you go through the following steps: a proper history, a physical examination, an endocrine examination, and routine lab investigations. A physical examination, you have 6 steps: anthropometry, cardiovascular, respiratory, abdominal, neurological, and fundoscopy. And then you have the common investigations: CBC, ECG, urine analysis, kidney function test. And these are the optimal tests which should be done whenever you suspect a secondary hypertension in the form of renin-aldosterone ratio in aldosteronism, or renal vascular ultrasound, or you look for the metanephrines or overlaid ambulatory polysomnography. Depending on the situation, we do for ruling out secondary hypertension. And what is important is HMOD has to be done with a proper kidney, heart and arteries should be assessed for risk stratifying these patients and how we are going to look at the management of this special category of patients. So this is the dictum which we have already discussed. We are looking at patients. Whenever you have to take 4 categories, 4 exceptions to our general rule. One is if you have an age greater than 85 years, if you have symptomatic orthostatic hypotension or moderate to severe frailty, these group of patients do not come under the strict 130-80 criteria, 130-70 criteria, because these group of patients, we like to keep the BP a slightly higher level, and 140/90 or above may also be acceptable. In all the other category of patients, we have to keep the BP as close to 120/70 as possible with therapy or with lifestyle measures. So the WHO has looked at 5 dimensions of hypertension: socioeconomic factors, therapy-specific factors, patient-specific factors, condition-specific factors, and health systems and care. This is what is going to define the hypertension management in the country. So we need to look at how we are going to approach. Are you going to have proper lifestyle or a medication, and then family as a self-care? Multidisciplinary approach will be the one which really helps control the hypertension. So lifestyle measures are overtly emphasized. What is very important is always substitute potassium, which we say low sodium and increased potassium is only the form of natural source of potassium. And exercise is very important part of the protocol. You must have moderate intensity exercise of 150 minutes per week, and along with that you should also add low or medium intensity dynamic or isometric exercise 3 days a week. Maintain a proper diet, BMI, and avoidance of alcohol. And all these 5 measures not only reduce the BP reduction but also has a very important step in cardiovascular risk reduction, because now the blood control of BP is directly correlated with the reduction of cardiovascular risk in the patient. And when you look at different forms of exercise, we are looking at not only the BP reduction but also the cardiovascular risk reduction in this group of patients. So when you have the pharmacotherapy of hypertension, you have first line drugs. You have ACARBs, dihydropyridine calcium channel blockers, diuretics, thiazide and non-thiazide diuretic. Beta blockers can be combined with any of the first line drugs in patients with compelling indications. That are compelling indications of beta blockers like angina, myocardial infarction, heart failure and heart rate control. But what is more important is always use the drugs at the appropriate time for the patient. If patients need more than pills, polypills can be used. And in greater than 140/90, combination therapy has to be used with no exceptional situations. So hypertension management in the glands, you start with lifestyle medication, monotherapy only in very select group of patients, whereas most of them it's a combination therapy, and depending on the combinations depends on what stage of hypertension, what targets we want to achieve. So this is what is a basic thing. You have to do screening for hypertension, and then you have to confirm the hypertension. Then you go for the patient-centric care, whether the patient is going for a lifestyle or going to go for drugs, depending on the risk factor, and then decide what are the targets for each and go according to a stepwise protocol of lifestyle with pharmacotherapy. So practical approach to pharmacotherapy. Initial single drug is used only in 4 groups of patients: elevated BP 120 and 135, and also for moderate frailty and symptomatic orthostatic hypertension group. Only in these group of patients single drugs are used. In all the other patients you may use a combination of drugs, and the initial combination depends on the age and what targets we are setting. And whenever your BP is not controlled with 2 drugs, you add usually a third drug is usually a diuretic, and then beta blockers can be added at any stage. And then if the BP is still not controlled, it goes upper when treatment resistance. You have to look for patient adherence is very important. Patient adherence to drugs, patient adherence to lifestyle measures before you decide whether the patient is truly resistant, where a specific therapy may be required. So as we said, general measures, moderate to severe CKD, you always have to monitor the urea creatinine electrolytes, and then objective measurements for adherence should be checked in all patients, because most important cause of the treatment resistant hypertension is non-adherence. And resistant hypertension should be treated by specialist. And then any family history of hypertension should be extensively evaluated, and proper diet should be used. Only in these group of patients, whenever you initiate therapy more than 140/90, we should be careful. One, age greater than 85 years, pre-treatment symptomatic hypertension, extremely frail, when the expectancy of life is less than 3 years, and maintain BP beyond 85 years, even if lifelong, if tolerated, as low as reasonably achievable in patients who do not tolerate aggressive lowering. If they tolerate aggressive lowering, you continue for life. And then once you are controlled, you follow at least annually. So you should have a proper monitoring of these patients. And then this is the step for management of resistant hypertension. Better to go for a specialized center. And once you find out that the patient is not responsive to the 3 drugs, you add spironolactone, and then beta blockers is the next step. And then you discuss with the patient. If the center has got a very good renal innovation strategy versus the drug therapy in the form of alpha blockers, centrally acting drugs, or potassium diuretics, or combinations of it. This combination of drugs or renal denervation therapy should be done with the discussion with the patient's family and depending on the experience of the center. So whenever you have an assessment of the patients, one, you look at the patient is whether patient is taking the medication. Then second, if the patient is taking the medicine regularly, or patient has discontinued medication. 3 steps have to be seen in order to treat. And when you have treatment in special groups, we should always remember that even pregnancy ladies, we should advocate low or moderate exercise and consult with obstetricians. An extremely frail patient should be used with caution. SGLT2 inhibitors, if eGFR greater than 20 is been advocated in patients SGLT2 to improve renal outcomes in hypertension. In valve disease, RAS blockers are preferred. Renal vascular hypertension, if it's fibromuscular hyperplasia, renal artery stenting is preferred. In atherosclerotic renal artery stenosis, if this patient has got 70 to 99% block, or 50 to 69 with post-stenotic dilatation with increased gradient across the block, now the patient has recurrent flash pulmonary edema, unexplained unilateral small size kidney with hypertension, or bilateral renal artery stenosis. These group of patients may benefit with renal vascular stenting. It's always important that if you have a patient-centered care, you should always discuss about the cardiovascular risk of the patient so the patient is compliant to therapy. Web-based interactions are being encouraged to increase motivation. And self-measurement of BP of the patient at smartphone integration is very important, and a multidisciplinary approach is important in the management of hypertension. Imaging can be done by echo or renal artery Doppler ultrasound abdomen if you suspect in specific situations. But always remember the target of blood pressure is 120 to 129 systolic and 70 to 79 diastolic or less. And only in these 4 group of patients we accept BP up to 140 systolic. So renal denervation therapy is now been encouraged in the ASC guidelines in a medium to high volume center with experienced operators, with explained discussion with the patient, and with uncontrolled hypertension with 3 or more drugs and no contraindications. So this is all the steps should be fulfilled before you pick a patient or advise a patient renal artery denervation. So gestation hypertension, I'll just touch few points. Initial therapy if greater than 140/90. Chronic hypertension pregnancy greater than 140, you do it. And gestation hypertension plus chronic hypertension, do not lower diastolic blood pressure less than 80. And in cases of severe hypertension, you can use parenteral drugs. Diabetic patients with medication we should give a lifestyle therapy, lifestyle trial, medication trial for 3 months. And once initiated, keep the BP at 120/129. So in heart failure, 4 pillars to be used, and SGLT2 inhibitors can be used in preserved ejection fraction as well. So it's in patients with resistant hypertension, we already discussed. In stroke, it's very important to know intracerebral hemorrhage, immediate lowering of systolic BP, a target of 140 to 160 within 6 hours, prevents hematoma expansion and gives good functional outcome. In ischemic stroke, BP lowering may be initiated only prior to discharge. In acute ischemic stroke, So you always lower BP less than 180 by 105 the first 24 hours if patient is planned for thrombolysis or mechanical thrombectomy. But if not eligible or not planned for mechanical thrombectomy, careful lowering by 15% the first 24 hours is advocated. So the 10 commandments of the ESCR, you have to classify the BP, you confirm the diagnosis, do a proper risk assessment, elevated BP with low cardiovascular risk, lifestyle. Elevated BP with high cardiovascular risk, lifestyle with medication. Hypertension, lifestyle with medication. So lifestyle measures to be followed. What are the targets? What is resistant hypertension? And the multidisciplinary approach is what is required in the management of hypertension. Thank you, sir.
Thank you, Professor Dr. Kannan, for your wonderful lecture. Now the topic is open for discussion. I think we can have one or two questions.
Spironolactone, one of the major effects gynecomastia. Thank you, sir.
Thank you for your session, sir. We feel privileged in welcoming our beloved Dean Ma'am, Dr. Revati Balan, to this auspicious occasion. We welcome you, ma'am.
We request the chairpersons, Dr. A.S. Mohan sir, Dr. S. Alagasan sir, Dr. Ratnakumar sir, Dr. R. Balamogan sir, to felicitate the speaker, Dr. Kannan sir. We request the chairpersons, Dr. A.S. Mohan sir, Dr. S. Alagasan sir, Dr. Ratnakumar sir, and Dr. R. Balamurugan sir, to felicitate the speaker, Dr. K. Kannan sir.
We request Dr. Rajan sir to felicitate our chairperson, Dr. A.S. Mohan sir.
Now we request Dr. A.K. Srinivasan sir to felicitate Dr. Alagasan sir. We request Dr. Danaratnam sir to felicitate Dr. Ratnakumar sir. We feel privileged to welcome our medical superintendent, sir. We welcome you, sir. முத்திக்கனியே என் முத்தமிழே, தித்திக்கும் தெள்ளமுதாய் இனிக்கும் தேனமுதே. தாயே என் தமிழே, உன்னை புகழ்ந்து வணங்கி நாங்கள் இந்நிகழ்வை தொடங்குகிறோம். தமிழ்தாய் வாழ்த்து. அனைவரையும் எழுந்து நிற்குமாறு தாழ்மையுடன் கேட்டுக்கொள்கிறோம்.
We invite our beloved Dean to occupy the dais, and along with our medical superintendent, our vice principal, and professor of cardiology, Dr. Ravi Edwin, sir. So now for Tamil Thai Varthu, everyone please stand up.
ஒவ்வொரு ஒளிக்கதிரிலும் நம்பிக்கை வளர ஞானத்தின் பாதையில் நாம் செல்வோம் உயர உயர. குத்துவிளக்கு ஏற்றி ஒளி ஞானத்தை வழங்கிட மதிப்பிற்குரியவர்களை அழைக்கிறோம். We kindly request our respected Dean Ma'am, VP Sir, MS Sir, Dr. Ravi Edwin Sir and the staffs representing the Cardio Department to light the lamp.
We invite Dr. Kandasamy Sir, Professor and Head, Department of Gastroenterology.
I invite Dr. Saravanan Sir, Deputy Medical Superintendent, TIRUNELVELI Medical College, onto the dais. Sir, please.
We kindly request a respected Dean Ma'am to light the lamp. ஒவ்வொரு ஒளிக்கதிரிலும் நம்பிக்கை வளர, ஞானத்தின் பாதையில் நாம் செல்வோம் உயர உயர. குத்துவிளக்கு ஏற்றி ஒளி ஞானத்தை வழங்கிட நம் முதல்வர் ரேவதி பாலன் அம்மா அவர்களையும் விபி சார் எம்எஸ் சார் அவர்களையும் தாழ்மையுடன் அழைக்கிறோம்.
முகமது ரஃபி சார் அவர்களை ஒளியேற்ற நாம் அழைக்கிறோம். டாக்டர் ஐரன் மேம் அவர்களை விளக்கேற்ற அழைக்கிறோம்.
கடமை, கண்ணியம், கட்டுப்பாடு இவை அனைத்தும் ஓரிடத்தில் வீறு கொண்ட கம்பீர நடையாய் நாம் வியந்து சிலர் பயந்து இந்த அழகான ராஜ்யத்தை கட்டமைத்த நம் அம்மா முதல்வர் ரேவதி பாலன் அவர்களை வாழ்த்துரை வழங்க மேடைக்கு அழைக்கிறோம்.
Good afternoon, one and all. First of all, I thank the Lord Almighty who has made this wonderful conference possible. Respected Dean Ma'am, Vice Principal, MS, and my senior friends, my teachers, and my dear colleagues and students. It gives me a greatest pleasure to welcome our dynamic Dean Ma'am, who has been our great support, constantly encouraging me since she has become Dean. I know Dean Ma'am for the past 41 years, since 1984, 4 decades. She has made our cath lab a truly 24/7, allowing us to do primary at any odd time. Thanks, dear ma'am. And what not, congenital heart disease, more than 100 ASD device closures and PDA device closures we have done in our government setup. So that was also made possible by our Dean ma'am. We ranked first in the 18 medical colleges. Ma'am, you encouraged me to have this Cardio Summit conference. So this is the first kind of conference in our South Tamil Nadu. Actually, we planned this conference with my dear colleagues. Actually, we wanted to space this conference as a many topics for students and everything. But my assistants told, why can't we have a cardio summit? So, because I have five pillars, my assistants, and a great pillar, my dear associate professor, Professor Balachandar. So, my great assistants, pillars behind me are first Vishwa, just okay, the great brain in our department. Then comes Selva, a loving man. The third, Mani. Where is Mani? Okay, yeah. So then comes Thiru. Where is Thiru? Yeah. Then come our Anto. So these are my pillars behind me, and our Professor Balachandar. Yeah. So with these people only we built, and we are here. Every day we used to perform 15 procedures, and throughout the night, even yesterday we did a dual chamber pacemaker, because yesterday was a government setup, and we used to do all kinds of procedure. We don't mind whether it is a Pongal or New Year or anything. So in government setup, we do all kinds of procedures, because that is made possible by my sister, Professor Dr. Revati Balan. So she is the women behind all this success. Then comes our assistants told, why can't it be a cardio summit? We'll start from this year, sir, annual conference. So let it be a cardio summit. So I invited all my dear batchmates, because 6 of my batchmates are cardiologists, starting from Professor Arul. Professor Arul is then I started my career from Madurai Medical College, and Arul, you all know, he was here and he got promoted as a director of cardiology, and he retired 3 months back as a director of cardiology. So he was a full support with our department, and he is now here. So thank you, Dr. Arul. And then 5 cardiologists in our batch, because I joined MBBS in 1982 in Madurai Medical College. So I thank all my batchmates, starting from Dr. Vivek Bose. He just left. He gave a nice talk on drug coating balloon, and he is a main man in Apollo. And right from the starting of Apollo, he has been there. Then our classmate and senior cardiologist of Triplum, director of cardiac lab, is Dr. Lakshmana Das. So within 1 minute, he said yes. And so I am so happy my classmate is here. Then is my dear friend, Dr. Bharati Dasan. He is a director, Manipal Heart Institute, Salem. So he is going to give a topic of left main. Then my classmate, Dr. Bala. Dr. Bala is a professor and HOD, and he comes in as an examiner here, and he has been there for Madurai Medical College for a long time. He is a HOD. And he used to do lot of PTMCs in pregnancies and everything. He ranks the topper in the PTMC. So he is going to give topic in PTMC. Then comes my dear friend Dr. Kannan. So he is a director of cardiology now in Madras Medical College. So he is an Institute of Cardiology, Madras Medical College. Then my dear friend Dr. Neelambujan has come all the way. He is a director of Cath Lab, Tuticorin, Dr. Arul Raj's son-in-law. So he is there, and he will be giving a nice interventional topic, that is a primary angioplasty versus pharmacoinvasive angioplasty. Then our so many friends have come from so many places, and certain Meenakshi Mission Hospital, Dr. Selvamani also is going to come, and many cardiologists from different places, and mainly my brother, Professor Dr. Justin Paul. Professor Justin Paul is a professor of cardiology, and he is a son of soil here. He is 3 years junior to me, and he's, I learnt DM cardiology notes from him, and I got DM cardiology selected because of his notes. So thanks to Dr. Justin Paul, and he has come all the way to give topic of cardio-obstetrics. So that is a main topic running around here now, and he is going at giving a talk about cardio-obstetrics. Next is Dr. Prabhakar Dorairaj, and I know Prabhakar Dorairaj from 1980 because his father was a DIG in our area in 1980. So when he was doing 10th standard, his brother and myself were classmates. Dr. Chandrasekhar, he is a renowned ophthalmologist in Coimbatore, and Dr. Prabhakar is a 1 year senior to me in DM, and he is an excellent academician, and he is come all the way to give topic of lipid guidelines, and he is a main authority cardiologist in Apollo Heart Center, that is First Med Apollo. So with this so many people around, we formulated the topics, and we are having an excellent academic feast now. So then I thank all my friends and well-wishers, my teachers, and then my gold medal winners. This year, actually we never had DM cardiology in South. After Madurai Medical College, we never had. So we wanted to have a DM cardiology, and with the help of God Almighty, we had DM cardiology 3 years back. And this is the 4th year we are running DM cardiology, and 3 batches have gone, and we are going to give gold medal to all the toppers in right from the start of the DM cardiology course. We are going to give and honor them, and just to encourage our PGs to get the seat. That is the main motive around here. So with this agenda, I invite our respected, dynamic, and powerful Dean, Professor Dr. Revati Balan, to give her speech. Thank you, one and all.
Good morning to everyone gathering here. First of all, I must congratulate my elder brother, my senior, Dr. Ravi Edwin sir, for the greatest opportunity given to me. So, imagine, this is the down south of TIRUNELVELI. He is the leader. He is the man behind all the works done in our hospital, making this cardiology summit as a ever memorable 58-year-old medical college, and he is well known for his dynamic work. So first of all, I congratulate my elder brother, senior of this institution. Congratulate on behalf of my institution, behalf of my government of Tamil Nadu. I admire his works. And again, I must congratulate my friends who are all man behind his Dr. Selva, Manigandan, Balachandar, and my respected Rafiq sir, and all the medicine department. And all other PGs also. In this adjourn, I also congratulate my teacher professors who are all teach the medicine, especially Dr. Velu sir and Rajan sir and AK sir also. So, Dr. Ravi Edwin sir is my senior, and only one point I want to submit to the audience. My father is a DSP of this prestigious Palayangottai, and sir, father also, Dr. Ravi Edwin, Edwin sir, father, Edwin sir, he is also known for my father, and one fine morning, my father died of myocardial infarction. So we lost my father. After I joined as a dean in this institution, my simple and humble request to my brother, எப்பொழுதுமே நம்ம கார்டியாலஜி டிபார்ட்மெண்ட் 24/7 ஒர்க் பண்ணணும். நான் எங்களை மாதிரி அப்பா இல்லாத குழந்தைகளுக்கெல்லாம் நீங்கள் வாழ்வு கொடுக்கணும். எப்பொழுதுமே எங்களுடைய கார்டியாலஜி டீம் 24/7 தமிழ்நாட்டிலே நாங்கள் தான் ஒர்க் பண்ணிகிட்ருக்கோம் 24/7. ஸோ அந்த அளவுக்கு என்னுடைய ஒரு தங்கையா என்னுடைய பேச்சுக்கு மதிப்பு கொடுத்து சார் வந்து உணர்வுபூர்வமாக சொல்கிறேன், எங்கள் அண்ணா வந்து இந்த கிரேட் ஹேண்ட்ஸால் எத்தனையோ பேருக்கு உயிர் கொடுத்துருக்காரு. இந்த டவுன் சவுத்தில் யாரும் செய்யாத செயலை என்னுடைய அண்ணாவாக இருந்து என்னுடைய சொல்லுக்காக அவர் இன்ன வரைக்கும் செஞ்சிட்ருக்கார். அவர் ரிட்டையர்ட் ஆகிறது வந்து எனக்கு ரொம்ப ஒரு மனசு கஷ்டம். ஏன்னா அவர் வந்து என்னை விட 2 years சீனியர். நாங்கள் ரேகிங் அப்பெல்லாம் எங்கள் அப்பா சொல்லிவிட்ட ஒரு ப்ரொடெக்டிவ் என்னை காப்பாற்றின ஒரு பர்சன் அவரும் ரஃபிக் சார் தான். அதை நான் கண்டிப்பாக சொல்லணும். அப்போ வந்து என் பேர் ரேவதின்றதுனால ஒரு படம் பாரதிராஜா படம் வந்துருந்துச்சு. அப்போ எல்லோரும் என்னை கேலி பண்ணுவாங்க. அப்போ கூட என்னை இவங்க 2 பேர் தான் காப்பாற்றி கொஞ்சம் கிளாஸுக்கெலாம் கூப்பிட்டு போவாங்க. அதையும் நான் டீனாக வந்து இந்த ஸ்டேஜில் சொல்லாமல் போனால் சார்கிட்ட நான் சொல்கிறதுக்கு எனக்கு ஒரு ஸ்டேஜ் கிடைக்காது. ஸோ அந்தளவுக்கு என்னை ப்ரொடெக்ட் பண்ணி என்னுடைய கரியர் எல்லாத்துக்குமே அவங்க ஒரு அண்ணாவாக வழிகாட்டியிருந்தாங்க. அதுக்கும் தாண்டி எப்போ மீட்டிங் எல்லா மெடிக்கல் காலேஜ் மீட்டிங்கும் எங்களுடைய சங்குமணி சார் கண்டக்ட் பண்ணுறப்பையும் அண்ணாவை கூட்டி பக்கத்தில் உட்கார வச்சுக்கிருவேன். எந்த கொஸ்டினுமே இருக்காது. ஏன்னா ஆல்வேஸ் வி ஆர் தி லீடிங் ஒர்க் டன் இன் அவர் கார்டியாலஜி டிபார்ட்மெண்ட் 36 மெடிக்கல் காலேஜ்லேயும் நாங்கள் தான் ஃபஸ்ட்டாக இன்ன வரைக்கும் தேர்ந்துட்டுருக்கோம். ஸோ கார்டியாலஜி ஸ்டாண்ட்ஸ் இன் தி ஃபஸ்ட் பிளேஸ். அதையும் தாண்டி சொல்லப்போனால் இந்த எங்களுடைய திருநெல்வேலி டிஸ்ட்ரிக்டில் ஹப் அண்ட் ஸ்போக் 9 GHலேருந்து பிஹெச்சிலிருந்தும் ஹப் அண்ட் ஸ்போக் மாடலில் எங்களுக்கு கேஸ் ரெஃபர் பண்ணிகிட்டே இருப்பாங்க. நாங்கள் தட் இஸ் ஒரு 1-2 months முன்னால் கூட ஒரு ஸ்கூல் கேர்ள், ஒரு 12 years படிக்கிற ஸ்கூல் கேர்ளை கூட மிட் நைட்டு ஒர்க் பண்ணி அந்த கேர்ளுக்குள்ள உயிரை கூட கொடுக்குற அளவுக்கு இருந்தது வந்து பெரிய செய்தியாக வந்துச்சு. எப்பொழுதுமே எங்களது மாவட்ட ஆட்சித்தலைவராலையும் பொதுமக்களாலையும் எல்லோராலையும் போற்றப்படுகின்ற மிகப்பெரிய டிபார்ட்மெண்ட்டாக எங்களுடைய கார்டியாலஜி டிபார்ட்மெண்ட் நடந்துகிட்ருக்கு. அதுக்கப்புறம் சொல்லப்போனால் என்னுடைய ஆன்காலஜி, நியூராலஜி, மெடிக்கல் கேஸ்ட்ரோஎன்ட்ராலஜி, தென் இந்த மாதிரி டிபார்ட்மெண்ட்ஸ்லாம் என்றைக்குமே எவர் நம்பர் 1 தமிழ்நாட்டிலே திகழ்கிறது என்ற நல்ல செய்தி உங்களுக்கு நான் சொல்லிக்கொள்ள விரும்புகிறேன். அதற்கு அடுத்தாற்போல் நாங்கள் வந்து தமிழ்நாட்டிலே உறுப்பு தானத்தில் ஃபஸ்ட்டு இருக்கிறோம். அதுக்காக நாங்கள் வந்து ஒரு 2 months முன்னால் எங்களுடைய மாண்புமிகு மக்கள் நல்வாழ்வுத்துறை அமைச்சர்களால் 3வது இடத்துல இருந்தோம். ஆனால் நேற்று ஸ்டாண்டர்ட் படி இந்த சதர்ன் மோஸ்ட் பார்ட் ஆஃப் தமிழ்நாட்டில் இருக்கிற திருநெல்வேலி மெடிக்கல் காலேஜ் 58 year மெடிக்கல் காலேஜ் வந்து உறுப்பு தானத்தில் சென்னையை விட நாங்கள் தான் ஸ்டாண்டிங் ஃபஸ்ட். ஸோ அதுக்கு என்னுடன் உழைக்கின்ற என் கூட இருந்து ஒர்க் பண்ணுற என்னுடைய ஆல் மை லவபிள் ப்ரொஃபஸர்ஸ், பிஜிஸ், செவிலியர்கள் அனைத்து பெருமக்களுக்கும் இந்த சமிட்டில் நான் நன்றி சொல்ல விரும்புகிறேன். எங்களுடைய டேட்டா படி பார்க்க போனால் எங்களுடைய அச்சீவ்மெண்ட்ஸ் வந்து 2 cath labs, not in any place in Tamil government. We are the only person having two cath labs. So the service rendered to the public, poorest of the poor, is highest in our Tirunelveli district. So 12,000 procedures நாங்கள் பண்ணியிருக்கோம். ரெண்டாவது வந்து கேசஸ் டெய்லி about 15 procedures பண்ணுறோம். இந்த பெட் ஸ்ட்ரென்த் வந்து 100 beds இருக்குது. ICU 20 beds வச்சுருக்கோம். ஸோ இந்த அளவுக்கு தமிழக அரசால் சிறப்பான இன்ஃப்ராஸ்ட்ரக்சரோட நாங்களெல்லாம் செயல்படுகிறோம். எங்களுக்கு உறுதுணையாக இருக்கின்ற மை ஃப்ரெண்ட், என்னுடைய ஜூனியர் டாக்டர் ஜஸ்டின் பால் அவர்களுக்கும் இந்த அன்பான சமயத்தில் என்னுடைய பாராட்டுகளையும் விஷயத்தையும் தெரிவிக்கின்றோம். மேலும் இன்ஸ்டியூட் ஆஃப் கார்டியாலஜியிலிருந்து வந்திருக்கின்ற சிறப்பான மருத்துவர் டாக்டர் கண்ணன் சார் அவர்களுக்கும், மை சீனியர் டாக்டர் அருள் சார், இங்கு அமர்ந்திருக்கின்ற பெருமை மிகுந்த கார்டியாலஜிஸ்ட் அவர்களுக்கும் என் சார்பாகவும் என்னுடைய தமிழக அரசின் சார்பாகவும் எங்களது 58 வருடம் மெடிக்கல் காலேஜ், அதையும் தாண்டி 60 வருஷத்தை நாங்கள் நோக்கி போய் கொண்டிருக்கிறோம். இதற்கெல்லாம் காரணமாக இருந்த என்னுடைய ஹெச்ஓடி சார், மோகன் சார், அழகேசன் சார் எல்லாருக்குமே இந்த தருணத்தில், மேலும் சங்கரங்கோயில் அந்த மாதிரி பெரிஃபர்லேருந்து வந்திருக்கின்ற ஃபிசிஷியன் மை ஃப்ரெண்ட் எல்லாருக்குமே இந்த தருணத்தில் ஒரு கார்டியாலஜி சம்மிட்டில் கேலக்ஸி ஆஃப் ஃபிசிஷியன்ஸை வி ஆர் சீயிங். ஸோ வி ஆர் ஆல் அப்ரிஷியேட்டிங் யுவர் கிரேட் ஒர்க்ஸ். உங்களுடைய கிரேட் ஹேண்ட்ஸால் இன்னும் பல உயிர்கள், புவரஸ்ட் ஆஃப் தி புவர் இந்தியன்னே சொல்லணும், அந்த அளவுக்கு உங்களுடைய சேவை என்றைக்கும் தொடரணும் என்று என்னுடைய அன்பான வாழ்த்துக்களை சமர்ப்பித்து, என்னுடைய எல்டர் பிரதர், என்னுடைய அண்ணி டாக்டர் ரவி எட்வின் சாரும் அவங்களும் இன்னும் நீடூடி வாழணும், பல்லாண்டு பல்லாயிரம் ஆண்டு பல கோடி நூறாயிரம் மல்லாண்ட தினத்தோல் மணிவண்ணா மாதிரி என்றும் சேர்ந்திருந்து நீண்ட நெடிய வாழ்க்கை வாழ வேண்டும் என்று மனமாற வாழ்த்தி விடைபெறுகிறேன். நன்றி, வணக்கம்.
நன்றி அம்மா. நம் கல்லூரி முதல்வர் அம்மா ரேவதி பாலன் அவர்களுக்கு வாழ்த்து மடல் வழங்கி கௌரவிக்க டாக்டர் ரவி எட்வின் ஐயா அவர்களை அழைக்கிறோம். We request Dr. Ravi Edwin sir to felicitate our Vice Principal sir. Now we request Associate Professor Dr. Balachandar sir to felicitate our Medical Superintendent sir. Now we request Associate Professor Dr. Balachandar sir to felicitate our Medical Superintendent Dr. Balasubramanian sir. We request Associate Professor Dr. Balachandar sir to felicitate our Deputy Medical Superintendents Dr. Kandasamy sir and Dr. Balasubramanian. Now we request our HOD sir to felicitate our Vice Principal sir. Now we request Dr. Ravi Edwin sir to felicitate our Vice Principal sir. Now we request Associate Professor Dr. Balachandar sir to felicitate Dr. Saravanan sir.
We are proud to announce the recipients of the Professor J.M. Ravi Edwin TVMC Alumni Endowment Gold Medal in Cardiology. This prestigious award recognizes outstanding academic performance and clinical excellence in the field of cardiology. Now I invite Dr. Mohan Sir, retired professor and head of Department General Medicine, TVMCH, and President of Associations of Physicians of India, TIRUNELVELI branch, to share a few words with us.
So, good morning to everyone. I am very glad to participate in this function, retirement of CME in the eve of retirement of Professor Ravi Edwin. On behalf of Alumni Association of Interventional Medical College, we are having 23 endowment gold medal in various subjects. So it will be given every year during the college function or alumni day every year. So this year, our retiring Professor Dr. Ravi Edwin, so he wanted to establish a endowment award. So in his name, and the cardiology PG, who is a topper in every year. So every year it will be given. So this year he want to give this occasion. So we thank Professor Ravi Edwin for his great gesture. So once again, thank you all dignitaries on the stage and the off the stage. Thank you.
We request our beloved Dean Ma'am and Dr. Irene Ma'am, Professor in Chief, Departmental Surgery, to felicitate the winners. Dr. I. Ibena Jesni Ma'am, MDDM, for securing the first rank. Dr. I. For the first batch of cardiology. Congratulations, ma'am. Dr. G. Narayan Sir, MD/DM, second batch of cardiology, 2020 batch. Congratulations, sir. Then Dr. R. Sahaya Francis Akinston Sir, MD/DM from 2021 batch. Congratulations, sir.
We thank all the dignitaries on the dais.
I'm
As we
Professor
reach the-
Balachandar, to come here to give vote of thanks.
As we reach the end of today's sessions, it is time to acknowledge the efforts behind the academic success. I now invite Dr. C. Balachandran, Associate Professor, Department of Cardiology, Tvmch, to deliver the vote of thanks.
அனைவருக்கும் இனிய காலை வணக்கம். இந்த விழாவை சிறப்பிக்க வந்திருக்கும் முதல்வர் திருமதி ரேவதி பாலன் அவர்களுக்கு மிகுந்த நன்றியை தெரிவித்துக் கொள்கிறோம். மேடத்தை பார்க்கும் போதெல்லாம் எனக்கு ஒரு குரல் தான் நான் வரும். சொல்வந்தான் சோர்விலான் அஞ்சான் இவனை இகழ் வெள்ளல் யாருக்கும் அரிதுங்கிற குரல் தான் நான் வரும். ரொம்ப திறமையான நிர்வாகம் பண்ணுறவங்க. ஏன் சொல்வந்தான்னு சொல்கிறோம்னா, நான் ஒரு தடவை மேடத்தை போய் பார்க்க போனேன். திடீர்னு ஒரு பிஜி ஷார்ட்டேஜ் வந்தது. ஒரு மேடத்தை போய் பார்க்க போனேன். மேடம் சொன்ன வார்த்தை வாட்செல்லாம் உட்காரு. நான் கோபத்தோடு போயிருக்கேன். வாட்செல்லாம் உட்காரிச்சிடலாம். சஃபிக்கு இந்த போலி எடுத்துக்கொடு, டீ எடுத்துக்கொடு. இதுலேயே நான் ரொம்ப ஆஃப் ஆகி போனேன். இது வரைக்கும் எந்த டீனை நீ வாட்செல்லாம் உட்காரிச்சலாம் எங்கள் அம்மா கூட சொல்கிறது கிடையாது. எங்கள் அம்மா எனக்கு கொடுத்ததெல்லாம் காலில் சூடு போடுவாங்க சேட்டை பண்ணுறதுக்கு. இந்த மாதிரி தான் நான் பரிசு வாங்கியிருக்கேன்னு தவிர வந்தோடனே வாட்செல்லாம் உட்காரிச்செல்லாம் சொல்லி யாருமே சொல்ல. ஒரு வேலையாளுக்கே இந்த மரியாதைனா வீட்டுக்காரர் எஜமான் ஐயா பாலன் சாருக்கு எவ்வளோ மரியாதை இருக்குன்னு பாருங்கள். எனக்கெல்லாம் ஒரே ஒரு வேலை தான் வீட்டில். இடிதாங்கி கம்பிக்கு என்ன வேலையோ அது வேலை தான் எனக்கு இன்றைக்கு வரைக்கும் நடந்துக்கிட்டே இருக்குது. அவ்வளோ திறமையானவங்க மேலே சொல் பேச்சில் எல்லாமே. யாரையும் கடிந்த சொற்களுக்கு கடிந்தோலவே மாட்டார்கள். எல்லாருமே ஒரு அன்பான சொல், ஒரு ஆதரவான சொல்லாதான் மேடம் பேச்சிருக்கும். ஏன் சோர்விலான்னு சொல்கிறோம்னா, ஒரு தடவை முதல் ஒரு விசிட்டிங் வந்தாங்க. நான் வாட்ஸ்அப் அவ்வளோவா பார்க்க மாட்டேன். சாயங்காலம் 6:30 மணிக்கு மேடம் எனக்கு ஒரு போஸ்டிங், ஒரு வாட்ஸ்அப்பில் ஒரு மெசேஜ் அனுப்பிச்சிருந்தாங்க. இப்படி நாளைக்கு முதல்வர் ஐயா வர்றாங்க, யாருனாச்சும் ஒரு 2 கார்டியாலஜி போஸ்டிங் போகணுன்னு சொல்லி 6:30 மணிக்கு அனுப்பிச்சிருக்காங்க. நான் நைட்டு 12:30 மணிக்கு வீட்டில் வாட்ஸ்அப்பை பார்க்கேன். மேடம் வாட்ஸ்அப் மெசேஜ் இருக்குது. உடனே நான் சரி மேடம் சொல்லிட்டு மெசேஜ் போட்டேன். மேடம் உடனே ரியாக்ட் பண்ணி தேங்க்ஸ்ன்னு சொல்லி போட்டுவிட்டாங்க. அவ்வளோ தூரம் இரவு பகல் பார்க்காம நாங்கள் 24/7 சொல்கிறத விட மேடம் எப்போவுமே இரவு பகல் பார்க்காம உழைக்கிறதுல ரொம்ப ஒரு திறமையானவங்க. 3வது அஞ்சான், எதுக்கும் அஞ்ச மாட்டாங்க. இது நாங்கள் காலேஜ் டேஸ்லேருந்தே நான் பார்க்குறேன். நான் 85 இங்கே சேர்ந்தேன். அப்போ எப்போவுமே காலேஜில் சேர்ந்த உடனே ட்ரீம் கேர்ள் இருக்கும், ரோல் மாடல் இருப்பாங்க. இது இங்கிலீஷில் சொன்னால் நல்லா இருக்காது. ஒரு கனவு கண்ணி இருப்பாங்க. இதுதான் ஒரு அருமையான வார்த்தை தமிழில். ஒரு லட்சிய நாயகி ஒருத்தர் இருப்பாங்க. கனவு கண்ணி இப்போ கனவு பாட்டி ஆகிட்டாங்க. அதனால் அவங்கள பற்றி நான் இப்போ பேசுகிறதுக்கு விருப்பப்படலை. இங்கே இருக்கும் அன்பர்களுக்கு ஒரு பொதுவான வேண்டுகோள், யாரும் தயவுசெய்து வெளியில் அந்த கனவு கண்ணியின் பெயர் என்ன அப்படின்னு சொல்லிட்டு எல்லாரும் கேட்குறதுக்கு ஆசைப்படுவீங்க. தயவுசெய்து அந்த மாதிரி கேட்காதீங்க. நான் சொல்கிறதுக்கு விருப்பப்படவும் இல்லை. 2வது லட்சியம், அங்கே ரோல் மாடல்னால் அது ரேவதி மேடம் தான். ஏன் ரோல் மாடல்னு சொல்கிறோம்னா, நாங்களாம் 85 உள்ள இருந்தப்போ அதுக்கு முந்தின பேட்சில் கோர்ட்டில் கேஸ் போட்டிருந்தாங்க. ஒரு 20 பேர் கோர்ட்டில் கேஸ் போட்டிருந்தாங்க. கவர்மெண்ட்டு அந்த காலத்தில் கவர்மெண்ட்டை எதிர்த்து கேஸ் போட்டதுன்னா அவ்வளோதான், சோழி முடிஞ்சு போச்சுன்னு அர்த்தம். இவங்க துணிச்சலாக கவர்மெண்ட்டை எதிர்த்து கேஸ் போட்டிருந்தாங்க. என்னைக்கு உதவி முதல்வராக இருக்கீங்க, அடுத்த வருஷம் கண்டிப்பாக முதல்வர் ஆயிடுவீங்க. ஏன் இதை சொல்கிறேன்னு சொல்லி நீங்கள் நினைக்கலாம். சங்குமணி சார் ரிட்டையர்ட் ஆனவுடனே அடுத்து டீன் மேடம் டிஎம்ஏ ஆடுவாங்க. அடுத்து நம்ம சுரேஷ் சார் கண்டிப்பாக முதல்வர் பதவி ஏற்க வேண்டிய கட்டாயத்தில் இருக்கிறாங்க. இங்கே அடுத்து பார்த்தீங்கன்னா, அந்த காலத்தில் பேர் வைக்கும்போதே அம்மாமார்களுக்குனா பிள்ளைகள் என்ன தான் வருவான், இப்படி தான் இருப்பான் அப்படின்னு சொல்லிட்டு பேர் வைப்பாங்க போல். எனக்கு பாலச்சந்திரன் பேர் வச்சாங்க. விநாயகருங்கிற பேருக்கு மறுபேர் பாலச்சந்திரன் சொல்லி சொன்னாங்க. உருவமும் அப்படி தான் இருக்குது, செயலும் அப்படி தான் இருக்குது. பட் நம்ம டெப்டி சூப்பரண்ட் பார்த்திங்கன்னா 3 பேருக்கு ஒரு ஒற்றுமை இருக்குது. பாருங்கள், பாலசுப்ரமணியன், கந்தசாமி, சரவணன் 3 பேருக்கு ஒரு ஒற்றுமை பார்த்திங்கன்னா எல்லாமே முருகக்கடவுள் பெயர் அவங்களுக்கு. ஏன்னா அவங்க அழகென்ற சொல்லுக்கு முருகான பாடல் இருக்குது. அந்த மாதிரி ஒரு அழகாக இருக்கிறவங்க, டைனமிக்காக வேலை செய்கிறவங்க. நமக்கு பேரை பார்த்திங்கன்னா ஆணை முகத்தனை, பானை வைத்தனைன்னு சொல்லி நமக்கு பேர் வச்சுருக்கேன். நம்ம அந்த மாதிரி நிலைமையில தான் நம்ம நடந்துக்கிறோம். அவங்க 3 பேர் சுறுசுறுப்பாக நடந்துகிட்டு இருக்காங்க. என்னாலும் இந்த இலக்கண விதிகளுக்கு அம்மா எனக்கு வைத்த பேருக்கு இலக்கண விதிகளுக்கு புறம்பாக நான் ஒரு செயலை சேர்ந்தேன். அதாவது என்ன செயல்னா, கல்யாணம் பண்ணேன். அதனோட பலன், இந்த இலக்கண விதிகளுக்கு புறம்பாக கல்யாணம் பண்ணதுனால அந்த பலனை இன்னைக்கு வரைக்கும் நான் அனுப்பிச்சிட்டு இருக்கேன். அதே மாதிரி தான் பார்த்தீங்கன்னா, இந்த 3 டெப்யூட்டி சூப்பரண்ட்ஸுக்கும் பேர் பார்த்தீங்கன்னா முருகப்பெருமான் பேர் இருக்குது. ஆனால் எல்லாருக்கும் ஒரே ஒரு தடவை தான் கல்யாணம் நடந்திருக்கு. அவங்க வீட்டில் என்னென்னு நமக்கு தெரியல. அது அந்த இலக்கண விதிகளுக்கு புறம்பாக நடந்ததுனால எதுவும் நடக்குதா என்னன்னு தெரியல. அடுத்த வீட்டு பேச்சு நமக்கு தேவையில்லை. அவங்க இந்த விழாவுக்கு தலைமையேற்க வந்ததுனால அவங்களையும் வரவேற்கிறேன். விழாவின் கதாநாயகன் டாக்டர் ரவி எட்வின் சார், பல சாதனைகளை சரித்திரங்களையும் படித்து விட்டு இந்த யுகத்துக்கு, இந்த கலியுகத்துக்கே இந்த வரலாற்று நாயகன் வந்து ரவி ட்வின்ஸ் தான் கார்டியாலஜி. நானும் ரேவதி மேடத்தை எத்தனை தடவை கேட்டு பார்த்தேன், மேடம் அட்லீஸ்ட் நான் ரிட்டையர்ட் ஆகிற வரைக்கும் அவங்கள இங்கே வச்சுருங்க, அதுக்கப்புறம் நான் ரிட்டையர்ட் ஆகிட்டு போனதுக்கப்புறம் எனக்கு பிரச்சனை இல்லை அப்படின்னு சொல்லிட்டு ரவி ட்வின்ஸ் சார் பல சாதனைகளை புரிஞ்சிருக்கிறாங்க. இந்த சாதனைகள் இனி வரும் கார்டியாலஜிஸ்ட்னால யாருனாலையும் மாற்றவே முடியாது. இது வந்து தீர்க்கமாக ஒரே ஒரு தடவை எழுதப்படக்கூடிய விதி. இது வந்து ரவி ட்வின்ஸ் சார் செஞ்ச பெரிய சாதனை. அந்த காலத்தில் ஒரு கதை சொல்லுவாங்க, செத்தும் கொடுத்தான் சீதக்காதின்னு சொல்லிட்டு. பார்த்தீங்கன்னா சீதக்காதி புலவர் வந்து ஒரு தடவை இறந்து வந்து சமாதிக்கு போயிட்டாங்களா. அப்போ வந்து ஒரு வறுமையான புலவர் அவரை தேடி வரும்போது சீதக்காதி புலவரை பார்க்க வந்து, அதுக்குள்ளே உங்கள்கிட்ட நீங்கள் இறந்து போயிட்டீங்களே, உங்கள்கிட்டருந்து நான் பணம் பெறணும் தான் வந்து அப்படின்னோடனே சமாதியிலேருந்து கை நீண்டு மோதிரத்தை நீட்டுறாரு அப்படின்னு சொல்லி சொல்கிறதா ஒரு வரலாறு உண்டு. எல்லோரும் கவர்மெண்ட் சர்வீஸ் விட்டு எப்படா ஓடலாம், என்னைக்கிடா ரிட்டையர்மெண்ட் டே வரும் அப்படின்னு தான் நினச்சிட்டு இருப்பான். பட் ரவி ட்வின்ஸ் சார் வந்து அந்த ரிட்டையர்ட் ஆகிற சமயத்துலேயும் ஸ்டூடெண்ட்ஸுக்கெல்லாம் எதனால் செய்யணும்னு சொல்லிட்டு ஒரு கோல்டு மெடல் என்டோமெண்ட் அவார்டு வச்சாங்க. நல்லது மேடம், எவ்வளவோ கெஞ்சி பார்த்தேன், கதறி பார்த்தேன், உங்கள்கிட்ட ஒரு பலனும் இல்லை. அட்லீஸ்ட் என்னோடய கடைசி வேண்டுகோள் ரவி ட்வின்ஸ் சாருக்காக, அட்லீஸ்ட் இந்த PMSSY செகண்ட் பிளாக்கை ரவி ட்வின் பிளாக் ஆஃப் கார்டியாலஜின்னு கண்டிப்பாக நீங்கள் மாற்றியே தரணும் எங்களுக்கு. அது அவங்களுக்கு செய்கிற ஒரு பெரிய ஒரு நம்ம நன்றி கடனுக்கு வந்து ஒரு இதாக இருக்கும்.
Thank you for the greatest word of my friend, my junior. இது வந்து நானும் பேச முடியல ஓப்பனாக அஸ் அ டீனா, ஆனால் அவர் பேசிட்டார். எனக்கும் வந்து எப்பொழுதுமே எப்படி சொல்ல, இது எதுவும் நினச்சிக்கிற கூடாது யாரும். எனக்கு எங்கள் அப்பா ஒரு கடவுள் மாதிரி, அவங்களுக்கு அவங்க அப்பா ஒரு பெரிய ஒரு ஜெயிண்ட். என்னுடைய பாலனுக்கு டீச்சர் அவர். சாருக்கு நல்லா தெரிஞ்சு சிரிச்சுட்டே முன்னால் உட்காந்துட்ருக்காரு. ஸோ அவ்வளோ ஒரு பெரிய ஜெயிண்ட்டு. இந்த திருநெல்வேலி வந்து அந்த மாதிரி ஒரு டீச்சரை வந்து நாங்கள் பார்த்துருக்கோம். எங்களுடைய ரிட் பேட்சில் அனாட்டமி, ஃபிசியாலஜி, பயோகெமிஸ்ட்ரி மூணுமே பயங்கரமான ஜெயிண்டில் தான் நாங்கள் கல்வி கற்றுருக்கோம். என்னுடைய ஸ்டூடெண்ட்ஸுக்கு அந்த டியூ டு ஏஜ்னால் அந்த மாதிரி ஜெயிண்டெல்லாம் அவங்க பார்க்கறதுக்கு முடியலை. ஆனால் நான் நினச்சிட்டே இருந்தேன், நானும் எங்களுடைய வந்துட்டு சீனியர்ஸ்ட்டை கவர்மெண்ட்டை கேட்டு அவங்க அப்பாவுடைய பேரை வைக்கிறதுக்கு அளவுக்கு நாங்கள் வயசு இல்லாட்டாலும் அட்லீஸ்ட் என்னுடைய அவர் வந்து எப்படி சொல்லணும்னு தெரியல, இவரை மாதிரி இனி ஒரு கார்டியாலஜிஸ்ட்டு இந்த திருநெல்வேலி மண்ணே பார்க்காது. தாமிரபரணி தண்ணியிலே எழுத முடியாது. அந்த அளவு எதுக்குன்னா, எப்போ சொன்னாலும் ரேதிமா நான் போயிடறேன்ப்பா, அதாவது திறந்துட வேண்டியதான். சொர்க்க வாசலை விட அவ்வளோ அளவு பலனு எல்லாமே இந்த திருநெல்வேலி மண் அவரால் அடைஞ்சிருக்கு. எத்தனையோ உயிர், கவுண்ட்லெஸ் உயிர் அவர் கையால், அவருடைய பொற்கரங்கள்னு கூட சொல்ல முடியாது, வைரக்கரங்களால் உயிர் பெற்றிருக்கு. இதை மாதிரி இதில் இனிமே எங்களுடைய 50 வருஷத்துக்கு இந்த மண்ணில் யாரும் பிறக்க போகிறதும் கிடையாது. இவளை சாதிப்பையும் எங்கள் திருநெல்வேலி மெடிக்கல் காலேஜ் வந்து பார்க்க முடியாது. ஸோ என்னுடைய ஃப்ரெண்டு, என்னுடைய கோயில்பட்டி மண்ணுக்காக சார் பேரை என்னுடைய ஃப்ரெண்ட்ஸுக்காக வைக்கிறதுக்கு நான் கண்டிப்பாக ட்ரை பண்ணுறேன். தேங்க்யூ. என்ன
வேண்டுகோளை ஏற்று உத்தரவு வழங்க காத்திருக்கும் திருமதி ரேவதி பாலன் அவர்களுக்கு எனது நன்றியை தெரிவித்துக் கொள்கிறேன். அடுத்ததாக பேச்சாளர்கள், அனைத்து பேச்சாளர்களும் நட்சத்திர பேச்சாளர்கள் தான். ஒரு பின் ட்ராப் சைலன்ஸ் ஒரு ஆடியன்ஸை உருவாக்க முடியும்னா ஒரு நட்சத்திர பேச்சாளர்களால் தான் முடியும். எங்களுக்கு தெரியாத நிறைய விஷயங்களை எங்களோட ஷேர் பண்ண வந்திருக்கும் நட்சத்திர பேச்சாளர்கள் அனைவருக்கும் எனது நன்றியை தெரிவித்துக் கொள்கிறேன். பார்வையாளர்கள், தகுந்த பார்வையாளர்கள், எந்தவித சத்தம் கிடையாது, கூச்சல் கிடையாது, குழப்பம் கிடையாது, மைக்கு தூக்கறியில், பேப்பர் கிளியலை, சட்டை கிளியில் ஒன்றுமே ஆகலை. எல்லாரும் அவ்வளோ டீசன்ஸ் வந்து பார்வையாளர்கள், ரொம்ப நல்ல பார்வையாளர். விழாவுக்கு ரொம்ப அருமையாக ஒத்துழைப்பு கொடுக்குறீங்க. அருமையான ஒளிவு ஏற்படுத்தி கொடுத்த மைக் செட்காரங்களுக்கும், இந்த விழா இனிதே நடைபெற உதவிய ஃபார்மசி கம்பெனிகளுக்கும், மீண்டும் எனதுடன் பணியாற்றும் எல்லா மருத்துவ பணியாளர்களும், இந்த ப்ரோக்ராமு சார் கொண்டு வந்த திட்டங்கள் எல்லாத்தையும் செயல்படுவதற்கு எங்களுக்கு உறுதியாக இருந்த எல்லா எங்கள் கார்டியாலஜி டிபார்ட்மெண்ட் பணியாளர்கள் அனைவருக்கும் எனது நன்றியை தெரிவித்து விடைபெறுகிறேன். நன்றி.
Thank you, sir, for a heartwarming and a memorable vote of thanks. Now let us all rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Army. Silva.
quality of a person who leads any department should have. So I always see this quality in him, and beyond a great teacher also. This I witnessed when he took last integrated class 2 weeks back for undergraduates. Approach to aortic valve disease with the case discussion in 200 lecture hall. Sir told that I want to take a class for undergraduate. So after the class, all the undergraduates gave the feedback that it was an excellent and very interactive session which we never had. Like that they told, because sir went inside he walked inside the classroom and interacted with person. Arun Murli knows well. Such a great personality, and also women behind a man's success. Irene madam also. Both were down to earth, and we were the students of father of Ravi Edwin sir, Dr. Edwin sir, known for his preach like teaching. So as a person, preach in the church, he used to speak. இப்போ கூட ரஃபிக் சார் உட்காந்துருக்கும்போது சொன்னார், இப்போ ரவிட்வின் சாரை பார்க்கும்போது அப்படியே அவங்க அப்பாவை பார்த்த மாதிரியே இருக்குது அப்படின்னு. ஸோ ஐ ஆல்சோ இன்வைட் ரஃபிக் சார் டு ஸ்பீக் a few words.
He is my classmate, he is my partner. He teaches. The final year examல வந்து எனக்கு வந்து TOF சொல்லி கொடுத்தாரு. நான் அவரை ஒரு ரூமில் இருந்தோம்.
சின்ன ஊசிமா
எம்டியில் வந்து நான் எம்டி பண்ணும்போது இஸ் டீச்சராக இருந்தார். ஈவன் நவ் இஸ் எ டீச்சர். இஸ் ஃபாதர் இஸ் மை சீஃப் மை
சியாம் கொஞ்சம் அப்பனிங்க.
எக்ஸலன்ட்
டு டாக்டர் ரவிச்சந்திரன் எட்வின் சார்.
So actually, our postgraduates are blessed to have a teacher like Ravi Edwin sir. He taught a lot of lesson to them and trained them in cardiology to a great extent. On behalf of the postgraduates of general medicine, we present a small memento.
Thank you, sir.
We now step into a session that addresses a core pillar of cardiovascular prevention, new lipid guidelines and newer therapies. Our speaker is Dr. Prabhakar Dorairaj from Apollo Hospitals, Chennai. He brings not just...
Good morning to all. We are all first and second batch of DM cardiology students. We would like to facilitate our beloved HOD sir as a token of love to express our gratitude.
I would like to invite the chairpersons for the session, Dr. Sulaiman, Senior Consultant Physician, Tengasi, Dr. S. Pothiraju, sir, Ravi Hospital, Sankaran Koil.
Somebody has to pull out these chairs.
And also Dr. Arunachalam, sir, Aruna Cardiac Care, Tirunelveli. Onto the dais.
Can somebody pull out these chairs, please? This is going to block the... Yeah, I think, can we get started, please? Yeah. First of all, thanks to Ravi Edwin for inviting me to Tirunelveli. I am also alma mater of Tirunelveli. I studied in St. Xavier's Palangote long ago. I seriously don't remember how long ago. It's that long. I'm pretty old. So what I shall be trying to do after all this hullabaloo that has happened, all the things that have happened, is try to keep you occupied over the next about 15 minutes on some new lipid guidelines, newer lipid treatments. It's going to be a very difficult topic to cover because I have an audience of undergraduates, postgraduates, professors and retired professors. So first of all, I have a question for you. Let us see who is going to identify the person you know in this picture. Can you identify at least one person in this picture? I'll ask Irene to find out where is her husband first. Ravi is here. Ravi is here. I ask Ravi to... There is one more other retired professor also here from cardiology. If you identify this person, it's easy. That is Arul. The person next to Arul is actually my brother. He is Dr. Chandrasekhar from Coimbatore. So where is Ravi Edwin? I tried asking my brother. He said it's difficult because Ravi always hides. Actually, Ravi is hiding here. The person hiding here is Ravi. Ravi, correct? Hopefully that is correct. Okay, fine. When we talk about lipids, what we always say is this: when we think we know, we cease to learn. This is exactly the concept of lipids. We all of us treat lipids based on what your lab reports give, which is entirely wrong. So to make it a little more lively and make you understand simply, I made it into a case study. Now this is what happens. Most of the time you have a patient coming to your clinic with a value like this. He comes here as a 45-year-old doctor, most difficult persons to treat. Master health checkup, father had a PCI at 60 years of age. You think family history is positive? Father had a PCI. Ravi, everybody is worried. What my answer is simple. Don't worry about LDL cholesterol much. LDL cholesterol today has got a very simple response. If it is low, the prognosis is bad. If it goes very high, it actually becomes dysfunctional HDL. There is a sweet spot between 40 and 70. If it goes beyond 70, it is actually going to harm you. So today we don't talk much about LDL, HDL cholesterol, which we call as the good cholesterol. The bad cholesterol we all know is LDL, about which we'll be talking. Cholesterol, why is it not important HDL? Because when you measure HDL cholesterol, it just shows the level in the blood.
It does not show whether it is going to produce a reverse cholesterol transport and reduce the plaque volume. So it is not really mentioned. So today when you look at a lipid profile, it is really not that important to talk about HDL cholesterol. Now this patient is like Sachin Tendulkar. Sachin Tendulkar here bowls. I put a cricket picture. I didn't want to put something from the IPL. I'm a big fan of Sachin Tendulkar. He bowls a googly to the father of googlies, who is Shane Warne, and makes him clean bowl. So what happens in this? This patient also bowled a googly, and he says, I did a CT scan, my calcium score is 100. How do you interpret a calcium score? These are very practical points you're never going to read in books. I've changed a different topic. So calcium score is very important because if your calcium is there in the coronary arteries, it is a marker for atherosclerosis. 0 is fine. Anything more than 0 is abnormal. So if you have a calcium score of 100, it has a lot of implications. 0 to 100 is a plus minus value that you have to remember in practice. The next important thing is calcium score is not valid in smokers, diabetics, and family history of premature atherosclerosis. Our patient did not have a calcium score, did not have a family history of premature atherosclerosis. So in these three conditions, you actually don't look at the calcium score, straight away start them on primary prevention. So what is the current status of calcium score? There is no point in doing calcium score too early. Youngsters, younger people will never have a calcium, so don't look at it. Similarly, too old, it's too late. Anybody who is already on a statin will have a calcium that is going to be high. How calcium changes the plaque is what I will show you next. Too often, don't repeat it too often. If your calcium is between 0 and 100, probably you can repeat it once in about 5 years. Otherwise, don't bother about calcium score. Now, what does statin do to a block? The normal problem, what we say is when there is a block like this in the baseline, you see that there is going to be something like this. Not working. This is better. So this is going to be a normal plaque. So what happens? This is the lumen. The white one is the lumen. Over time, if you're not taking statin, the lumen gets narrowed by the plaque. The dark one is the calcium. But if you take statins, what happens is the statin increases the calcium. The calcium score will actually increase, which is actually protective because the fibroatheromatous plaque which produces the ACS is reduced. But look at the lumen, it is not narrowed. Look at this. In a statin naive patient, the lumen narrows. So it's important to understand. Anybody who is already taking a statin, calcium will increase. So don't bother about looking at the calcium later. Recently, there is also a paper justifying aspirin for anybody who's got a calcium score more than 100. This is something that practically you must remember. Because in primary prevention, we say don't give aspirin. But if your calcium score is more than 100, there is some justification. The next case I'll give you is a very practical case. Most of the patients are coronary artery disease. It's a cardiology department summit. So if you look at it, here is a patient who has had a PCI 3 months ago, takes rosuvastatin 20, and his LDL cholesterol is 69, and the HDL cholesterol is 35. Are you happy? Are you happy with the 69 of LDL cholesterol in these group of patients? What do the guidelines say? Now this is what all the guidelines say. We will focus on only two aspects. In primary prevention, most of the guidelines have said don't have an LDL more than 100. How many of you know your lipid profile? I'm sure 50% don't know their lipid profile. If you have not done, you are supposed to look at your lipid profile at the age of 18. 18 plus, if you don't know your lipid profile, you are not fit to be in MBBS. Please remember, you have to start looking at your lipid profile very early. So we look at only two subsets here, the diabetics and the ASCVD patients. Most of the guidelines, except the Americans, they have also boiled down to 55 now. Stock between 50 and 55 LDL cholesterol. Our patient at 69, obviously not treated properly. The other important thing is if you look at the diabetic guidelines, most of the recent guidelines have clearly said diabetics cannot have an LDL more than 70 milligrams. The biggest problem with diabetes is most of the diabetologists look at their lipid profile reports. Reports quote ATP3 of 2002, which says 100 is optimal, and they are all happy with 100. Because of all of you, Ravi Edwin has got a roaring practice in Tirunelveli because you don't treat the lipids, they get coronary artery disease and come to Tirunelveli Medical College, and your dean will praise you for all the things that you have done. This is what is happening here. So you have to be a little careful here. So let us introspect. Having said all these guidelines, how good are we? You must always introspect and see what happens. Now this is the ICMR INDIAB study quoted very often. In diabetic patients, they looked at a simple LDL of 100 and found out LDL control is only in 41. Now this itself is wrong. Why is it wrong? Because we are talking about 100, only 41% of diabetics are achieving. But if you look at 70, it is going to be 20% or 10%. So we are actually treating diabetics badly, and because of that, there is a rampant coronary artery disease. Now how do cardiologists fare? The Lipid Association of India, of which I am a part of, we did a live care survey of about 10,000 patients, And when we looked at a target LDL of 70, which is American guideline, only 50% in secondary prevention achieved this target. What about the LAI target of 50? Only 23% achieved target. So even among cardiologists, we are poor. We don't give you adequate statins. So we're not treating our patients adequately here. Now, what is special about India? Why do I keep talking about India? India, there is always a very good news. The good news is that Indians have an LDL cholesterol which is 10 milligrams lesser than the Western population. It's good for us, right? So we should have lesser coronary artery disease. But unfortunately, that is not translating into clinical practice. We developed MI 10 years earlier. With a 10 milligram less cholesterol, we get it 10 years earlier. And nearly 50% of CAD deaths happen in patients who are less than 50 years of age. So we have a very high incidence of coronary artery disease at a lower LDL cholesterol. That is the reason why we say in India we should have our Indian guidelines and we should be very strict about lowering cholesterol. The Lipid Association of India, of which I am a part of, we give an LDL cholesterol of less than 100 for primary prevention. Diabetics 70 milligram. Any atherosclerotic cardiovascular disease 50. If it is going to be recurrent atherosclerosis 30. And there is these vasculopaths who have polyvascular disease with 2-3 angioplasties, CABGs, redo CABGs. You can bring it down to even 10 to 15 to 20 milligrams. I will show you one slide on that later. So what happens here? Are you happy with this? No. So we have to step up our medication. 20 milligram rosuvastatin is actually wrong. Probably we'll have to step up it. The next question I have you is, are you happy with these values? How many of you look at how the LDL cholesterol is done? Most of the time, LDL cholesterol is calculated from one equation. This is for undergraduate students. What is the equation in which they calculate LDL cholesterol? The Friedewald equation, right? Now, what happens in Friedewald equation calculation is that this is actually direct LDL. Friedewald equation calculation, if you look at it, this is a paper that I published with about 30,000 patients data on direct LDL cholesterol. You see when the LDL levels are low, there is a 41% underestimation of LDL cholesterol. Now what happens is, you think the value is 70, it is not 70, it is going to be much higher than that. So you get a falsely low value in patients with coronary artery disease. So you have to go ahead and do a direct LDL cholesterol. This is direct enzymatic method, the much superior method, which I think you should be aware of. Most of the less than 50s are actually not less than 50. So you have to be clear about that also. There is one more cause where coronary artery disease rises. Remember I told you getting the LDL cholesterol lower. This is a Pacman AMI study where they looked at patients with an LDL of less than 24 and patients with an LDL average of 74. Now, when they compared these two, they found out there is a significant regression of the atheroma volume, plaque burden and the fibrous cap thickness increase, which makes the plaque stable. So there is enough justification by studies to show that the LDL cholesterol has to be 24 milligrams in patients post myocardial infarction also. I think we should remember lower the better is very, very important. And there is one doctor who always comes and tells you, you're on 40 milligrams of rosuvastatin, it is too high a dose. How many of you do that? Most of the time when they go to the primary care physician, the value says optimal is 100. They half the time reduce the dose of LDL cholesterol. So how do you think we should scale down the LDL? Please don't do that. Post PCA patients, this is one study which showed if you reduce the intensity of statins, there is a higher incidence of poor outcome, higher incidence of MACE. So when the patient has got a lower value of even 25, 30, don't bother, patient is fine. Please continue statins. Never ever reduce the dose of statins for these group of patients. Now, whenever we start treating, we always treat with statins. There are three important points to remember when you treat cholesterol. Longer the better, don't reduce the dose. Lower the better, whatever the tolerated dose accepted, earlier the better. The earlier the better means there is something called plaque age. Suppose you're 40 years of age, your LDL cholesterol is 150. You're not on medication. 150 into 40. 40 years, 150 milligrams. It is going to be 6,000. So your plaque age is 6,000. At 5,000, coronary artery disease starts. At 7,000, most probably it manifests. So you're very nearly over the hill. So when you want to convince a patient who is younger, you show him his cholesterol, calculate his plaque age, and tell him how close he is to a problem. Definitely it will convince your patient to take statins. It's a very practical point for you. This is a very vague patient that I got. This is a 17-year-old girl who came to me actually when she was 14. Look at these xanthomas here. Size of the xanthoma in her back. Something like about 6-7 centimeter size xanthomas she had. When she came to me first, she had an LDL cholesterol of 512. LDL, I'm not talking about total cholesterol, 512. So this lady had a very high cholesterol and their target is going to be 100 milligrams for all these patients. So how did I treat? I started them slowly on lifestyle modifications straight away. Small dose of statin, started putting it up and went up to 40 milligram, added azitimib, then added bempedoic acid, still didn't work. At this point, her LDL was still 256, not working in these group of patients. So what do you do for these subgroup of patients? There is always these patients who don't achieve targets. So what are the reasons why you don't achieve targets? The most important factor is inter-individual variability. Not all patients respond to statins the same way. Then there is this question of compliance. Patients read WhatsApp message says you will get diabetes, you will get muscle pain, everything, they don't take it, and poor compliance thanks to these effects. The last one is the physician's inertia. That we will talk about, that is probably the reason. This is something you should understand. All patients don't respond to statins the same way. When you give 80 milligrams of atorvastatin or a 40 milligram rosuvastatin, you're supposed to achieve 50% reduction, which is not achieved in 42% in atorvastatin and 26% in rosuvastatin. So rosuvastatin gives lesser inter-individual variability. So probably 40 milligram rosuvastatin for all these patients, and probably add ezetimibe for most of the secondary prevention. The actual incidence of statin-associated muscle effects. You go to an orthopedician with any joint pain, he will tell you are taking statins and stop the statins. We have seen several times happen. It's not actually true. The actual, by definition, the incidence of statin-associated muscle side effects is at only 7%. And how does it happen? This is something you have to remember. Bilateral, symmetrical, proximal muscle pain or myalgia involvement within the first 12 weeks. So you start a statin, 1 year later he gets muscle pain, is not statin. Within the first 12 weeks or increasing the dose, that is statin-associated muscle side effects. We have seen this. What we are going to be looking at is how to tackle these patients. Now, if you have understood this slide, you have understood entire lipidology. I have never understood this slide. All the multiple mechanisms by which you can reduce your LDL cholesterol. We will go for a very simple mechanism, which is probably taught by these two Nobel Prize winners, Brown and Goldstein. What did they say? They found out the LDL receptor. LDL receptor removes LDL from the blood. How does it work? It's on the hepatic cell. So what happens in the liver? You reduce the amount of cholesterol inside the B is the consensus. Remember 3 values of apolipoprotein B. One is going to be the 100, 2 is going to be the 70, and third is going to be the 50, 60. So only 3 values of ApoB. I'll show you that later. We have also done some lipid calculators since a lot of short of time. I will skip all that. This is my last slide. So when you decode a lipid profile, when somebody comes to you with a lipid profile, always look at the triglycerides first. The reason is, if the triglycerides are more than 500, he's going to have pancreatitis. You have to bring it down fast. Next, look at LDL cholesterol, primary prevention 100, diabetics 70, atherosclerotic cardiovascular disease 50, recurrent disease 30. ApoB for them is going to be 90, 70 and 60. Corresponding ApoB. And target a non-HDL cholesterol, we will not go too much into that. So start treating these patients with most of the drugs all the time. I think I'll skip this story which I normally tell you. Thank you very much for the patient listening. Thank you.
Thank you, sir, for that crisp session.
Story is very simple. When a guy goes to see an elephant, he goes to the circus, and he's a reporter. He goes to the circus in New York, and he sees the lions, the tigers. He has never seen any animal in New York. And finally, he goes inside and goes towards the end of the circus and finds out there is an elephant, and the elephant is tied to a simple rope. He gets really scared and says, "What happens if the elephant runs away in New York? A lot of people are going to die." He says, "Don't worry, sir. Nothing will happen." He said, "Why nothing happens?" When the elephant was small, we used to tie it to the same rope. So whenever the elephant sees this rope, the elephant starts thinking it can't pull it. Though it's become very strong, it is not understood it is strong. This is exactly the mentality of all the doctors that treat cholesterol. You don't treat them adequately. You think that what we thought those days, 100 is going to be good, this is fine. No, you have to change with the times. That is the story, ma'am.
Thank you, sir, for the crisp session. Now I request Dr. S. Pothiraju, Dr. Suleiman, and Dr. Arunachalam to come on to the dais for felicitation. I request our chairpersons, Dr. S. Pothiraju, sir, Dr. Suleiman, and Dr. Arunachalam, sir, to felicitate our speaker. Thank you, sir. We now move into a next.
Before today, please, at least those who are seniors, you would have definitely heard, please raise your hands. So, to roughly get an idea, about 5 to 10% of the audience have heard this word. Now imagine what kind of work that, it is very important for us, for me to know who I am talking to. That is the reason why I asked this question. Thank you for answering. So I will talk to you what exactly is cardio-obstetrics and why do we need that, and where are we in the cardio-obstetric care, and how do we develop a cardio-obstetric care in the state, in the country, and the rest of the world, of course, world is taking care of. To define that, cardio-obstetric care is a comprehensive care given to a pregnant woman with heart disease, manned by a cardiologist, obstetrician, obstetric anesthetist, neonatologist, in the basic sense. And what do? They take care of the girl child with the heart disease before marriage and before pregnancy. They talk to them, counsel them, they take them through the pregnancy, through the labor and delivery, after postpartum, 4th trimester, and long-term care. The entire gambit of care has to be manned by a big team. This is called the cardio-obstetric team. To illustrate that, I'll just give one story. A young lady who was dreaming to be a mom, a 22 years old primey who had a mitral valve replacement at the age of 18. She was 14 weeks pregnant at the first antenatal visit in one of the hospitals in Tamil Nadu. I will not name what exactly it was. She was counseled for medical termination of pregnancy by the obstetricians, a primey, and he was counseled to continue pregnancy. The cardiologists, they were in different places, and there was no discussion, no coordination. And the anticoagulants were stopped, heparin was given, MTP was done. In the first post-operative day, she had shortness of breath class 4, and she developed a prosthetic valve thrombosis. She was thrombolized and maternal death. Imagine a young girl who wanted to be a mother for the first time in her life, ending up with the death of 2 lives. This is not an isolated event. If you look at the obstetricians or the cardiologists handing over, they'll tell you stories and stories like this. Why is this happening? Now tell me, I'll talk to you about another person. She had at 8 years, she had a right hemiplegia, was found to have a mitral stenosis and left ICA occlusion. She had this is not an imaginary story, this is a real patient. I took care of this patient. At the age of 8, she had a balloon mitral valvotomy. She again restenosed at 12, attempted balloon mitral, failed. At the 13 years, she had a mitral valve replacement and she was on warfarin high dose. At 16 years, she had contractures in the right limb thanks to this seizures, and then she developed seizures and dystonia. She was on Botox injections. She had cervical lymphadenopathy. On Levipil, ATT was started. Breakthrough seizures. At 26 years, she married with the full disclosure and stopped drug for seizures because she didn't have seizures for 3 years. Now this girl became pregnant, and one of her relative who is a young doctor, started on low molecular heparin. She developed left subclavian artery thrombosis, and she has now come. Now for this girl, you think a single obstetrician will be able to manage the patient, or a single cardiologist will be able to manage the patient? What would be the right kind of advice? We get more and more patients like this where we really need a team approach, where we have to work shoulder to shoulder, supporting one another, and this kind of patients are increasing in number, and this is where we need the case of cardio-obstetrics. Now what do you look at the patient wants to be a mother, and when they tell that, you have a heart disease, why did you become pregnant? You should not have become pregnant. Often this kind of advice is given. She's afraid of death and complications, and as soon as they know that there is a heart disease, the in-laws and the husbands, there is always an issue. Sikali ponna ketti vechitanga, yamati ketti vechitanga. All these kind of things, and so much of marital conflict. She does not even know whom to talk to or whom to say. There is high incidence of domestic violence in women with heart disease going through pregnancy, and no non-supportive care. Now what about the doctors? What happens if the patient dies? If you look at the maternal death audit, the way it is going on in some places, I will not name which places, there is more of a harassing obstetric care. So many of the obstetricians are really fearing this kind of reviews, multiple reviews by multiple systems, and as if trying to put the blame on the obstetricians. What happens? So, patient who has all these going through. To help these patients, we really need to work together and join this area. This was what I told you. It's a small study. I have not published it because I had not taken consent for collecting this data, just to share with you. So much of, we need to understand the patients. Now, the next aspect I'm going to talk to you is that another reason why we need this care. If you look at UK, the number one cause of maternal death is heart disease. If you look at US, the number one cause of maternal death is heart disease. And this is if you can, and so what you can see that there is something called obstetric transition. As the healthcare improves, what happens is the causes of maternal death like infection, sepsis, bleeding are all taken care of because obstetricians are doing a wonderful work. And this direct causes are being taken care of and indirect causes start going up, of which heart disease is going to be the leading cause of maternal death. In the developing nations also, unlike already it is the number one cause of maternal death in developed nations. In India also. So is it true, I just to show you, what is happening here in Sri Lanka, when the maternal mortality ratio is low, you find that the proportion of heart disease causing maternal death is very high. Whereas in Pakistan or Morocco, where the MMR is high, you see only 4 or 5% of all maternal deaths are due to heart disease. Whereas in other countries, there's almost 1/4 of every maternal death in Sri Lanka is due to heart disease. What about Tamil Nadu? Thanks to the data from NHM, we could collect the data for the last 10 years. You find that of MMR of 90 in 2012, the cardiac contribution is 4.6. Whereas with the MMR of 52, which has come down so much, the cardiac contribution is 9.6. In 10 years, it is doubled proportions. In the years to come, we are going to have 25% maternal, all maternal deaths, 1/4 of every maternal death or 1/3 of every maternal death will be due to heart disease. So unless we focus on developing this, concept and developing the infrastructure, we really don't know. Why number of cases are increasing? Now pediatric cardiology is increasing. I think I saw Dr. BRJ here. Now, people like BRJ Kannan and other my good friends, pediatric cardiologists, what they do is they diagnose the heart disease so early and they treat the congenital heart diseases. And otherwise, who would have died by 5 years, 10 years, these girls now live for 17 years, 18 years, 19 years, dream of becoming a mother, and more of them are becoming pregnant and they come into difficulties. Or, late pregnancy, the pregnancy at 30 years they get pregnant, 35 years, 36 years, and all cardiovascular risk factors. There's multiple reasons. This is one aspect. The second aspect I want to show you is that this is an analysis from California. 68% of every single mother who died, the death could have been prevented by an altered care pathway. Imagine what could have been the status in India. We don't have a data like this. So with this background, we started the study, the single largest study, single center study in the world. 1,005 pregnant women, 1,029 pregnancies. We found that 1.9% maternal mortality was there and 15.2% was the complication rate. We also found that patients with the prosthetic heart valves, patients with pulmonary hypertension, LV dysfunction had the highest maternal mortality. If you look at the prosthetic heart valve, 8.6% is the maternal mortality rate. And current pregnancy diagnosis, the reason what we found was, we found our own cells, the lack of coordination, lack of uniform protocol. If they come to me, I treat one way. If they come to A, another treatment pathway. If they go to B, another treatment pathway. Lack of uniformity. And we found high proportion of remediable causes of maternal mortality, particularly in the prosthetic heart valves. So this is another data. What we have the data is, if you look at the 3 largest database in the world, what you find is majority of them are congenital heart diseases, whereas in India, it is the valvular heart diseases. And you find our maternal death rates are high, our complication rates are high. So this was the outcome we found, our evaluation there. So lack of coordination, lack of awareness among the society, lack of awareness among the system of care. So how do we care for this one? Another missing ingredient is that if you look at the confidential inquiry in maternal death pattern started the embrace pattern in UK in 1950s. It is so confidential and very systematic that every single case is evaluated. What are the remediable causes? What are the common things? So how can we improve the system? Rather than, we don't have this, now. Only Kerala is doing at this point of time a confidential inquiry into maternal deaths. We need to start across every state. Guidelines do we have? This is the largest 2018 guidelines or AGOG practice guidelines. If you look at that, not a single reference from India in any of these guidelines. And we are using these Western guidelines for our management. So we really need to work on that. If we had another publication and showed that the patients who had a preconception counseling, they had a better outcome. But we also found that the appropriateness of preconception counseling needs a lot of fine tuning. So there is a lot of need for education of our own people. So with this, we started the Tamil Nadu Pregnancy and Heart Disease Registry, where TIRUNELVELI Medical College and the entire cardiology and the obstetrics team are an integral part of one of the 29 centers. We looked at the feasibility of developing a cardio-obstetric care process. 23 public hospitals and 6 private tertiary care centers, when we formed a cardio-obstetric group, a WhatsApp group in all these hospitals, and we recommended them that you discuss among each other and you discuss the case and work on that. Now, we had administrative support from NHM, and I was able to travel to most of the places and have an orientation meeting to all these places. But by the time COVID came, so we had to do a lot of online counseling, and ICMR funded this for the data collection part. So this is some of the key messages of the orientation were only 2 things. We found anticoagulation was suboptimal, so we focused on anticoagulation management of prosthetic heart valves, and we also focused on the need of a combined discussion-based work, not individual-based work. It has to be a cardio-obstetric group. These are the 2 focuses, and we collected the data. Now, what we have is right now from all these centers, as you can see, that TIRUNELVELI has enrolled more than 100 patients out of the 283 patients. So, we have right now 2,863 patients. Right now, this is the largest single nation study in the world. We are yet to publish this. We presented this last year in the European Society of Cardiology Congress here. Now, here also we found half of them were diagnosed for the first time during pregnancy. And I will show you here, you find that the prosthetic valve deaths have significantly come down to 2. So there is a very important, happiness, joy for us. And I'll look at the death rate focus for you, as you can see that the outcome. I'll focus on death rate here. You look at that, I've marked green because prosthetic valve was not associated with the death this time, unlike our earlier study, because there was a focused training on prosthetic valve. This only shows that and training our infrastructure really improves outcomes. And the second thing is mitral stenosis became an important predictor of adverse outcome and death, unlike the earlier study, because at MMC, we were routinely doing antenatal balloon mitral valvotomy, whereas of the 29 centers, only 2 or 3 centers were doing antenatal balloon mitral valvotomy. So the lesson, public health lesson is that we, particularly in areas where rheumatic heart disease is prevalent, we need to empower the systems of care to provide antenatal balloon mitral valvotomy and also to support the system to ensure that things go on well. So these are the 2 things that we really worked on, and I think the same thing. So what we, we also compared our what we called as intervention was the cardio-obstetric group formation. So we compared the Madras Medical College registry with the Tamil Nadu registry. We found that maternal mortality rate had come down, maternal adverse event rate has come down. But look at the last one, the prosthetic valve mortality, from 9.4 to 2.9 and outcome rate from 34 to 18.6. So this was a significant achievement of the coordinated effort of all the obstetricians and the cardiologists working together. And we concluded that though valvular heart diseases predominate, congenital heart diseases are fast catching up. So we need to empower our system to handle them, how to handle congenital heart diseases going through pregnancy, complex congenital heart diseases particularly. And in current pregnancy diagnosis is common. And these are the predictors of maternal death, which I already told you. Late pregnancy assessment, we really need to catch them young. Catch them in the right time, even before pregnancy. That is the time we can prepare the patient to face the delivery, optimize the medical care, optimize the surgical care, and that will be good. And adverse effects, maternal prosthetic heart valve, there is. So this was our, our conclusion, what we presented to the British Medical Journal. Southeast Asia had an award, so somebody invited us to join. So we presented this, and there was a big competition, but we really didn't know that it was such a big, credible thing. Ultimately, God's grace and thanks to the good work of all the obstetricians, the cardiacs across the center, we were adjusted the best maternal child health team of South Asia. This kind of work was, the thanks to all the people. So what we really need to do is that, this is a very ideal cardio-obstetric team, but then this may not be possible in every setup. So what we can do is at least, wherever we are taking care of high-risk deliveries, we need to work together to form at least a small team like this. And I presented how to develop a cardio-obstetric care in India, published in Indian Heart Journal last year. We have to have a team-based care and coordinated care, and it is a continuous care from preconception all the way to delivery, post-conception, post-delivery, and long-term follow-up, because cardiovascular risk in these women, the adverse pregnancy outcomes are very, very high. It's often a forgotten risk factor. And we need to train the system of care. So these are the areas where the team has to work together. Whether it's a preconception, what is during delivery and post-conception and labor and delivery, all these areas we need to work together. And how we have to develop, we need to have fellowships in cardio-obstetrics. We need to have training and lecture and curriculum. All these things we need to develop. So we are doing something called Cardio-obstetrics Masterclass. These are some of the 6 classes that we have conducted as of now. And these are available in the YouTube channel. So what we did was, all those cases which we found were associated with a high risk of death, we presented one such case, called all these experts in this area and made them discuss, and we have a presentation like this. We also have a group like this called Cardio-obstetrics India, where all complex high risk patients are shared, and experts across the country and also in the world, they share their inputs on how to handle. So the only recommendation is, de-identify the patients. Don't put the name or age. Just share name or the address. Just share the details and present. A lot of inputs every week. At least 2 complex cases are shared, and so many lives are saved. So these kind of things we really need to work on. And now we have ventured into a larger dream called National Pregnancy and Cardiac Disease Study of India, where ICMR has funded us almost 8 crores for 4 years, 56 centers across the country. If you look at that, the data will be representative of the entire country. Our dream will be like, we need to prepare a protocol for managing pregnant with the heart disease and test whether it is efficacious in a cluster randomization study. And if the protocol is efficacious, we'll be presenting it to the Government of India, and it will become the Government of India protocol. Such a work, it's a very difficult work, but then with the support of all the cardiacs and obstetricians and God's grace, I'm sure things will be going on well. As of now, we have already enrolled more than 2,000 patients in this study. So take home thoughts, I think, 1 more minute I have. Maternal death due to pregnancy is decreasing across the world in India, but yet to achieve the target MMR. We have not reached the target MMR as a country. Those our state has achieved. And heart disease will be the single largest cause of maternal mortality in India. Maternal deaths due to heart disease are often preventable. And the missing ingredients, good quality Indian data, thankfully some data is coming, Indian guidelines, Indian risk stratification tools, coordinated team approach, good administrative support, research support, and public awareness. These are some of the areas we need to focus on improving this. And what do? More research and more publications, joint grand rounds. We can have a cardiology and obstetric grand rounds when a patient is admitted here. All the chiefs of the cardiology here and the obstetrics here can go for a rounds, and there can be a discussion. A case can be discussed here. We need to develop the curriculums and fellowships and mandatory teaching hours on cardio-obstetric care in both OBG as well as in obstetric anesthesia and also in the cardiology. And collaborative sessions, we are trying to work out. Last 2 years we had 1 hour sessions on cardio-obstetrics in Cardiological Society of India Conference and Indian College of Cardiology as well. So thank you very much for this wonderful opportunity, and we dedicated women who really taught us in their distress, delivery and death. Thank you so much for this opportunity.
That was a brilliantly delivered session, sir. Thank you, sir, for simplifying such a complex topic and giving us an idea on how to approach cardiac obstetrics. Now, I would like to request the chairpersons for this session, Dr. Arul sir, Dr. Srinivasan sir, Dr. Sheba ma'am and Dr. Sujata ma'am to felicitate Dr. Justin Paul sir. Sirs, ma'ams, please. Thank you, ma'am. Thank you, sir. Now, I would like to call Dr. Selva Kumaran, Assistant Professor, Department of Cardiology, to felicitate our chairpersons. Sir, please.
And I thank Ravi Annan for this opportunity, and because I could really see my teachers and get blessed by them, Mahakrishnan sir, Velu sir and all that, it is such a joy to be blessed by them.
Thank you, sir. Up next, just before our lunch break, we shift gears for a high-energy academic face-off, a debate that explores a critical and often discussed dilemma in acute cardiac care. What is the ideal timing for stenting in acute myocardial infarction? Opening the debate and presenting the case for acute myocardial infarction, lies now and stent later, I would like to request Dr. K. Lakshmana Das sir, Director Cardiac Catheterization Lab, Madras Medical Mission, Chennai, to come on to the dais. Sir, please.
Good afternoon. Friends, I know that I am standing in between you and your lunch because I have to catch the flight. They allowed me to present this. Thanks for Bharati. Ravi, this was a wonderful and a very great feeling to meet all our friends here, and I enjoy this. And I will just quickly finish it up. This is a pet topic of my boss, Ajit Mulashari, and I am just representing his thought process actually. This is a heart muscle is it is a time is heart muscle. If you patient developed a MI and then you waited long enough, the patient will lose a lot of muscle and then mortality is going to be very high. You got a yearly intervention, you got a lot of things. Cardiac mortality is decreased very much. But by the time 2 hours, 120 minutes, the mortality will, benefit will go down. So you have to act very aggressively. So most of the time, we know that primary PCI is the way we treat the patient. I'm a physician, cardiac physician, where we treat the cardiac patients when come to the emergency room with heart attack. We take them to the cath lab and we do the angiogram and we treat the infarct-related artery. If it is an anterior wall MI, we treat the LAD. If it is a lateral, it may be a circumflex, or inferior wall, it may be a RCA. We open up the blood pipe and we sometimes treat the other arteries or we may not treat. So it is important to open up the infarct-related artery so that the cardiac benefit, mortality will go down as early as possible. So when the patient comes, from the door to needle time, the door to needle time should be within 120 minutes. In fact, total ischemic time, patient onset of symptoms to the patient benefit, balloon time should be 120 minutes to have the maximum benefit for the patient to recovery. Over years, you can see that this is a data collected from the Interventional Council data. Over the period, the number of primary interventions are increasing, but it is not more than 15% of the total interventions. It is almost stagnant. What happened to the 85% of these patients? What they had? There is a problem. So there are so many problems are in our country. Patients are not able to reach the hospital in time. They don't have that. They don't understand whether they have got a heart attack. They go with that concept that they have got some stomach upset. There are so many things are there preventing them from reaching the hospital. Second, financial burden. When they reach the hospital, how much they are going to be charged. That also produces a mind block for them to reach out to the hospital. So all these problems are there. So there is a delay in reaching the hospital and further delay in organizing the hospital to get the primary PCI. So ultimately they will not get the benefit. So that is the concept of pharmacoinvasive, making them eligible to undergo the PCI, so that we increases the window of opportunity for that the patients will get the benefit of this intervention for this all these patients. So pharmacoinvasive is basically thrombolize first. Thrombolize first, and after the period of 3 to 24 hours, you take the patient to the cath lab and do the procedure. And if they are eligible, and then go ahead and then put the stent to keep the artery open. That's the concept of the pharmacoinvasive. So this is the concept of step AMI. Step AMI is to prove this concept. There was a study conducted, multicentric concept. Basically what we have done is, there is a comparison whether to assess the safety of this process, like thrombolize first and then assess that outcome. There's a complications and how the patients benefited. All this to be assessed. That's why we created this trial called STEP AMI. These are the centers that participated in that. We have got Dr. Ajit was the lead in Madras Medical Mission, Thomas Alexander from OY, and Vikram, this is from Karnataka, and Kerala, Dr. Bogalayan, my teacher, and Salomani, my student. All these people were participated in this. There were two groups. One is a primary PCI, another one is a connective place was taken as the lytic choice, because streptokinase is not a thrombus specific. So connective place was selected as a lytic agent, and this was the findings we were found out. The composite of death, reinfarction, repeat revascularization were actually identified. Secondary endpoint was a TIMI major bleeding. And you can see that this is a group where you got a patient, primary PCI group, that is 155, and patients who had a lysis followed by PCI. The distribution of all the factors are almost similar. But if you see that closely, the lytic patients, when the patient went to the process of, when they reach the cath lab, you can see that most of the arteries are open and then flowing. And second is the thrombus burden is very low in the lytic patients. Third, some of the patients need not have that even stenting, basically because it is all light. Most of them were thrombus and they were lysed by the thrombolytics and they did not need anything at all. So this is what happened. Failed thrombolysis was noticed in 4 patients. So you should keep that in mind. There may be an element of failed thrombolysis where they have to taken up for the procedure immediately. So these are the final data, and you can see that even TIMI flow means how well that artery is perfused subsequent to the intervention. That is much better in the patients even before taking up for the procedure in the lytic group. That's why it may be a good concept to have if there is a delay in the primary PCI, it is better to lyse and then take the patients. Safety endpoints, there were small increase in the bleeding in the cases of these patients who underwent a pharmacoinvasive than the primary PCI. That is naturally understandable but these numbers can be reduced, particularly access related bleeding, like femoral or more bleeders. So you can make them to go for the radial procedures so that this also access related bleeding also can be brought down in these patient groups. So this was presented, the protocol had been published in the BMJ and subsequent 2-year follow-up also published in the International Indian Heart Journal, where you can have the follow-up, these cardiogenic heart failure, or it is a death, or the efficacy endpoint, death or reinfarction, both are statistically similar in both groups. So we concluded in the STEP AMI, pharmacoinvasive strategy is safe and associated with comparable clinical outcomes with the primary PCI at 1 or 2 years. Patient in pharmacoinvasive arm had lower thrombus burden and better TIMI flow and no increase in, moderately increased bleeding risk actually. But in our study, it was not much actually. Pharmacoinvasive strategy is associated with more than 80% of them are infarct-related artery was patent by the time they were going for the procedure. Pharmacoinvasive strategy may successfully alleviate the logistic or geographical barriers like reaching the primary hospital, it is facilitated. You can thrombolize in a hospital, and then nearby hospital you can refer the patients quickly for the further interventions. So these are possibility are brought out in the STEP AMI. So with this concept, it was further brought to the bigger level project. There is a Tamil Nadu STEMI project. Dr. Justin Ball also was one of the investigator in this trial, where these patients, thrombolytic patients as well as pharmacoinvasive, there are two groups, and this is again the protocol for that program. There were hub centers as well as spoke centers. Hub centers are the place where they do the primary PCIs as well as patients who are referred from the spokes. They are taken up for the intervention. There was a pre-implementation stage and then post-implementation stage. They enrolled about 1,522 post-implementation and 898 pre. This is a mortality in the all hospitals as well as the spoke hospitals. I will skip this and then just I will go through this one. If there is a patient, if there is no treatment, the mortality is just to focus on the blue line alone. This is a patient's death is about 10%. Mortality is 10%. If the patient is having a fibrinolysis alone, then also the mortality is just 9%. 9%, there is only reduction by 1%. But when the patient is going for the pharmacoinvasive or primary PCI, you can see that there is a gross reduction in the mortality. So the mortality benefit is basically if you leave the patient alone, there is a very high mortality. If the patients after thrombolysis also, if they let them be on the medical management, then also there is going to be a high mortality. You have to necessarily change the patient for the pharmacoinvasive or primary PCI should be the option for this patient. So you should understand that simple thrombolysis is not going to help your patient. You can see that the mortality is very high. So this is one of the pharmacoinvasive strategy that they have, the camera investigators, they have recruited around close to some 800 patients, and then they concluded that ST segment elevation macular infarction patients receiving the pharmacoinvasive is comparable for the primary PCA. That's what the conclusion they have come across. And also the safety and efficacy of the pharmacoinvasive strategy, actually again that is concluded that the same group, it is in the same trial, they have concluded that it is almost pharmacoinvasive is equivalent to that of the primary PCI. Only thing is choice of reperfusion. You should understand that there is a real delay in sending the patient for the procedure. This is about the talking about the we are talking about the reperfusion in some meta-analysis involving various strategies. Various strategy means primary PCI, facilitated PCI. Facilitated PCI means the patient will go for the procedure within 2 hours of the thrombolysis. And of course, pharmacoinvasive, that is 3 to 24 hours. So this is around 18 trials are involved. Only one thing I want to just highlight that there is an increased bleeding in facilitated PCI and pharmacoinvasive than the primary PCI. And stroke also higher in the case of pharmacoinvasive and facilitated PCI. And you can see that facilitated PCI, that means within 2 hours if you take, you can see that major bleeding is about 77%. So it is very high. So that's why there should be a 3 to 24 hours. You should not be taking the patient for early PCI less than 2 hours or 3 hours unless the patient has got a failed thrombolysis manifested by the recurrent VT or persistently elevated ST. You should not take the patient immediately. You should wait at least for 3 to 24 hours. Time window is the period. You have to intervene, and then only the benefit will be much better. Primary PCI, always major bleeding and stroke will be much less. That's why we prefer the primary PCI. So this is what I have told about. Basically, you have to take care of these patients. Pharmacoinvasives, outcome is better. The thing is mortality, cardiac wise it is better. But the patient will have a more complication in the form of a bleeding tendency and then stroke. So this is again, we are talking about the same thing. past AMI program, they have talked about the substantial portion of the patient's primary PCI. You should understand that the patient had a primary PCI. Thus, they referred for a primary PCI, but the total ischemic time was very high because there was a delay in identifying the symptoms and the patient being referred, and then only the patient is being taken up for the primary PCI. Ultimately, it has gone beyond the 120 minutes. That is a problem. So, you may increase these patients eligible for PCI by doing the pharmacoinvasive. So, this is what I was talking about, primary PCI, and the 120 minutes time limit is basically it may be crossed by the time you understand the patient had a MI and then need immediate attention. So, these are the two trials, STEAM2 trial. This is basically giving the half dose of the tenecteplase for elderly patient, more than 60-year-old. They had a half the dose because there is a bleeding tendency had been noticed in the previous trials. They thought by reducing the dosage of the tenecteplase, they may reduce the bleeding episodes. Of course, there was some reduction, but basically there was, I will just skip the slide and then I will go to the important concept. There are two important things important. One is all these patients, there is a failure to achieve or reclosure is there around 30%. All these patients in the stream 1 and 2 trials, the patients the vessel was not opening even by the tenecteplase. Second is patient may have an increased bleeding and then stroke. These two problems are definitely has to be addressed when you are thinking about the pharmacoinvasive. How we are going to improve the outcome? Pharmacoinvasive. Probably further reducing the dose of will help. We don't know. When we add some of the medication, whether there is a latest antiplatelets, if we add to that, whether it will increase the bleeding or not, and what window period will be the optimal window period for the pharmacoinvasive, we don't know. All these things has to be thought before venturing into the pharmacoinvasive. So after going through all these things, the pharmacoinvasive PCI had been given a guideline 2A. Of course, primary PCI is the class 1A guideline advice, but pharmacoinvasive is 2A, where the primary PCI is not possible, the patient should go for a pharmacoinvasive. So I will conclude there that this is a pharmacoinvasive strategy is as good as primary PCI, at least in low risk population. Like a cardiogenic patient or very elderly, complicated, it may not be a great strategy, where primary PCI will be the best option. Widens the time window for the coronary angiography and angioplasty. Logistically easier to accomplish, especially during the off hours. Night, if the doctors may not be available, he has to travel for the primary PCI. Then thrombolize first, and then third to 24 hours, you can always do the primary PCI, do the PCI. So it is an ideal strategy in India, since transportation times sometimes it may take long. Cath labs are located in the urban areas mostly, but that is changing. Even TIRUNELVELI, I think it is already some 20 labs may be there. Primary PCI is superior for high risk AMI or patients who can undergo primary PCI within 120 minutes of first medical contact. So it is important to understand that pharmacoinvasive is a way of managing our MI patients, make them eligible for PCI so that their outcome will be better and mortality benefit will be better. Thank you very much.
Thank you, sir. Countering that with the argument for always stent first is Dr. T. Neelambujan from Sudarshan Arul Raj Hospital, Tuticorin. A seasoned interventionalist known for his hands-on expertise and bold clinical perspectives. We would like to also invite the chairpersons of this session, Dr. Madhu Shankar sir, Senior Consultant Cardiologist, TVMCH, Dr. Badusha sir, Consultant Cardiologist, Jabak, Clinic Tirunelveli, Dr. S. Pothiraju sir and Dr. S. Chandar sir. Shri Sudarshan Hospital, Tirunelveli.
Respected senior colleagues, respected chairpersons, and my dear friends, a warm good afternoon to all of you. I think this is a IPL season and I'm put in a very tight corner, like asking a batsman to hit 7 runs in the last ball, because we are waiting for the lunch. With due respects to Dr. Lakshmana Das sir, who I adore as a teacher, let me put forth my argument in favor of stenting in cases of acute myocardial infarction. See, if a patient comes with acute chest pain and ECG shows extensive interval MI, what are the reperfusion strategies we have at present? The patient presents to a general practitioner or a physician. This particular patient might be thrombolized. But standalone thrombolysis is not the final treatment these days, because most of these patients get referred for a angiography within the time span of 3 to 24 hours. And if there is a particular lesion, they get addressed for that lesion. And this we call it as a pharmacoinvasive line of management, which sir addressed in great detail. If the same patient presents to a primary PCI center with an aggressive interventionalist, he might be taken up for a primary PCI and the artery will be reperfused. So the decision to treat depends on the place where the patient presents. That is also an important thing which makes the decision. And reperfusion therapy is time bound. Sir told that the time is myocardium, because as the time comes down, that is, the benefit also comes down. When the patient is treated within the time frame of 3 to 6 hours, we get the maximum myocardial salvage and the mortality benefit. But when the patient, you can see that when the patient is treated in the time frame after 12 hours, the mortality rate goes up and the myocardial salvage rate also comes down. So the earlier is always better. So time also decides the reperfusion therapy. So what are the criteria we need to look into to decide on the reperfusion therapy today? It is time which is important. When the patient presents early, within 3 hours, there's not much of difference between the thrombolysis and the primary PCA. Whereas when the patient presents late, say after 12 hours, absolutely there is no role for thrombolysis. This patient has to be taken up for a primary PCA. And the time required for the patient to be transported to a PCA center is also important. Other factors which needs to be considered when deciding the treatment for a thrombolysis and PCA are the availability of a skilled PCA laboratory in your vicinity, and patient preference for the treatment also we need to look into, and any contraindication for thrombolysis, these patients directly go for a primary PCA. So these are the guidelines. This is the American College of Cardiology recent guidelines, 2025. It says that in a patient with acute myocardial infarction, of course when they have
oval shaped and triangulated, and the size is large, even more than 5 millimeter. The atherosclerosis extends to the lateral side, and the angle is about 70 to 80%. LCX supplies more than 10% of myocardium in more than 95% of the patient, where we cannot afford to lose that vessel. The side branch occlusion is not acceptable, and step down of diameter from left main to LAD and L6 is large, even sharp, and 10% of patient will have trifurcations. And the dilatation of the stents, the currently available stents, will not be possible because of its large diameter. So what's the answer? So for almost 30 years, surgeons were ruling the dynamics. The study published in 1970, the CABG was the treatment of choice compared to medical safety. With the recent advances of arterial grafts and post-operative care, that has become addictive. And when I was doing my fellowship in 2002, there used to be a board outside the cardiac cath lab telling that left main disease, inform the surgeon. Immediately the surgeon will come, they'll take over, and at the end they'll operate. That was the thing. So, but angioplasty has improved a lot. Angioplasty, after improvement, 1978, a father of interest procedural rate of left main stenting. So that time, slowly surgeons woke up and they started asking, where is the evidence? Why you are coming to our territory? Tell me the evidence. So these are advances in the IVS and OCT, adjunctive pharmacotherapy like ticagrelor and prostacyclin, arterial stenting, bifurcation and trifurcation stenting, and drug-eluting balloons have made wonderful changes. So to answer this, there needs to be trials which will reflect the current techniques and devices. To answer this question, that came syntax trial. It's a large trial comparing taxus stent versus CABG surgery. 1,800 patients were randomized, either left main or severe triple vessel disease. They were given a taxus stent or a CABG arm. They were divided into 3 arms depending upon the syntax score. Less than 22, 20
earlier result was because of lipid cartilage and revascularization. Study is separate. If you take that the syntax score is more than 33, the repeat revascularization was very high, and the death rate was entirely almost 10% differences there. So, cardiologists thought that this is not very time being, we can give it to surgeons, and they will concentrate in other area. Coming to the 23 to 33, still there is 6% difference in death rate, but revascularization was almost 13%. That made the difference. So we thought that we can decrease the revascularization rate by some other method so that we can take this death rate. Whereas the less than 22, both the things were almost same. In the death rate, again revascularization was high. So revascularization has made a lot of difference. We cardiologists thought that some other method will decrease the revascularization and we can be par with the CAP. Here comes a 10 years follow-up of syntax, where the mortality alone, if you take, the less than 22 almost same, whereas advantage is there for 22, 32. So there was a mortality benefit was documented 10 years. So we have better strength that reduce the cardiac vessel revascularizations. There comes next study called Excel study, where we change the stent from access to neural Zyme stent. 950 patients were taken in the PCA arm, 950 patients were taken in the CMC arm. They were studied for 5 years, and inclusion criteria were same. They have included IMS and FFR. 3 years follow-up was PCA versus CMEG, death stroke MI, almost comparable. And death rate may increase because of non-cardiac deaths in PCA. You can see that almost comparable. At 5 years, there is some difference of 2 to 3%. And it is concluded that treatment of patient with LMCAD with low or intermediate syntax score with cobalt protein everolimus stents was comparable, and it is fewer adverse events at 30 days comparable with CAD. So considered acceptable or even preferred revascularization modality for selected patients. Decision should be made after a heart team approach, taking into account each patient's individual circumstances and preferences. Then comes the Noble study. Noble study showed there is a wider difference between the PCA and the CABG arm. The pre-compared trial is a South Korean trial that showed comparable outcome to the CABG and PCA. So now with the 5-year data of syntax, Excel, pre-compared and Noble, that is almost comparable except for the Noble, the Excel. Everything almost comparable. So we have evidence to go in for left main intervention by way of stenting. PCA has not early advantages. like it does in this fewer peri-procedural complications, more rapid recovery, whereas CABG has got late advantages. It's more durable, fewer adverse events beyond 1 year. But no significant major differences in long-term survival and base between PCA and CABG. So, 2018 recommendation is class 1A, status score of less than 22. 23 to 32, class 2A. 22 ESC guidelines also the same. ACC guidelines, high anatomical complexity, set for CABG. Low anatomic complexity, set for PTCA, class 2A. So, to conclude, left main disease is not surgical disease anymore. So, our patients who had a left main osteoproximal tight lesion. After this, the patient he underwent angioplasty with a good result. The patient was discharged comfortably. This is the final result. Left main lumen is preserved, and you can see that all these changes reverted. Another patient is a 48-year-old gentleman who was presented with non-existing elevation MI, non-renal function, non-diabetic and non-smoker. You can see that there is a distal left main lesion and the ostial circumference mild pinching, mild narrowing, and LAD segment has got tight lesions. So we proceeded with the angioplasty of LAD and the left main. So LAD is centered, left main is centered. Carefully, there is significant pinching of LCX and the patient started developing chest pain. So we crossed again, dilated the balloon. And extended. This is the final result. The next patient is a 48-year-old gentleman who had left heart angiogram, taken up for angiogram. You can again see that there is a tight osteoproximal lesion. RCA is normal. While we were discussing the family about the treatment modalities, patient arrested. So immediately intubated, temporary pacing was done. The last thing is LCX again change to LAD and patients are very well. One more patient, 60-year-old gentleman, had complete heart block and anticoagulant, cardiac shock and ventilation. Severe renal dysfunction. Angiogram totally occluded left brain. Temporarily followed by wiring. Lady are completing the stented. This is the final result. Another patient is a type 2 diabetic. This is an antiviral MI. There is a distal left vein, LAD and LAD. Osteal disease, wired, centered with a mini crush technique. This is the final result. So to conclude my talk, with the extensive non-left vein disease, CABG is preferable. If left vein with low anatomical complexity, PCH may be preferred. If multiple comorbidities, PCH may be strongly preferred. I thank you for giving the opportunity.
Thank you, sir. We now request the panelists, Dr. Madhushankar sir and Dr. B.R.J. Kannan sir, to felicitate our speaker, Dr. R. Bharatidasan sir.
Or for CABG. Some of them can be managed by transcatheter interventions also. It's actually a balanced view.
See, cardiac surgeons are not angry that we are not getting left main referred. In 2 years in Kulasegaram, I have done 621 cases of CABG. In that, nearly 150 are left main. The affordability issue, the left main stenting, the complexity involved are all very, very difficult to explain. And in the current setup, we do off pump and nearly less than 1% mortality. We are not God, we don't make everybody alive, but nearly less than 1% mortality. Anyhow, thank you for this opportunity. I am here to pass few more words with about Edwin. He was here in Tirunelveli Medical College when I was doing PG joint MBBS. From that, his father and he has served a century of service to this medical college, and he needs a lot of appreciation. I especially came for this.
expertise in catheter-based interventions and commitment to pediatric cardiac care.
You're not announcing the chairpersons?
Chairing the session are the two distinguished experts, Dr. Balaganesh Kamaraj Sir, Pediatric and Fetal Interventional Cardiologist, TIRUNELVELI, and Dr. Balasubramanian Sir.
Yeah, okay. So thank you. Thank you very much for inviting me to this forum. I'm going to give a bird's eye view. What do we do in congenital heart disease? So transcatheter interventions, actually they have revolutionized the management of congenital heart disease. What exactly you mean by transcatheter intervention? If there is any flow through some abnormal connection or communication, close it. Okay, that is one intervention. If there is a reduced flow due to stenosis or blockage, open it. So the interventions can be divided into those interventions which open up the abnormal closures, like pulmonary stenosis, aortic stenosis, mitral stenosis, coagulation of aorta, branch PA stenosis, stenosed grafts and conduits. Here they have blocked abnormally and we are opening up. These are one set of interventions. Here we use bulbs and stents. There are another set of interventions where we close the abnormal opens. So transcatheter interventions are basically if something is closed abnormally, open it up. If something is open abnormally, just close it up. So the closure interventions are atrial septal defect, ventricular septal defect, beta ductus arteriosus, aortopulmonary window, pulmonary fistula, coronary fistula, aortopulmonary coloris. All these can be closed. Now here we used various nitinol-based devices. Only with the advent of these nitinol-based devices, the transcatheter interventions of congenital heart disease has picked up. Before that, there have been umpteen attempts, but they were all failures, and hence the predominantly till late 1990s or till say early 1990s, most of the congenital heart disease was managed by surgical methods only. Okay, we have others advanced other techniques also. Now, if you see here, this is basically AP view of the heart. This catheter has come from descending aorta, arch, and then I am injecting there. What you see is the aortic valve. The aortic valve is forming a dome. The aortic valve is forming a dome here. If you observe here, it says there is severe aortic stenosis. You can watch here closely. Aortic valve is forming a dome. It is not opening closely. It's usually a bicuspid aortic valve, and the basal pressure gradient was 76 millimeters of mercury. So what do we do now? So you cross using a straight wire. Okay. Once a straight wire goes into the left ventricle, now the wire has gone into the left ventricle. You swap with a longer wire and then take the balloon across. Okay. And once you dilate the balloon, you can see a waist coming up in the middle. It is at this waist point the aortic valve was there, and this way basically opens up the valve forcefully. It forcefully opens up the valve. The size of the balloon is the same as the size of the aortic annulus. We generally won't cross the size of the aortic annulus. What do I mean by this? Suppose if I measure the aortic annulus as 8 millimeter or 10 millimeter, I take the balloon same 8 or 10 millimeter, not go more than that, because we don't want to injure the aortic annulus. We don't want to cause significant aortic regurgitation. In the process of opening up the valve, I should not damage the valve and cause aortic regurgitation. So this is aortic stenosis. So post balloon aortic valvotomy, can you see here? The pressure gradient fell to 16. Earlier the pressure gradient was 75 millimeters of mercury. Generally we follow up for every 6 months. Many will need repeat interventions later. Please remember, bicuspid aortic valve intervention is not a one-time intervention. Many will need re-intervention later, and then even some will need aortic valve replacement subsequently. So this is aortic valve intervention. Now this is pulmonary valve. Here we have shown the heart in the lateral view. As you know, the pulmonary artery traverses anterior-posteriorly. Okay, when the main pulmonary artery comes from the right ventricle, from the right ventricle, the main pulmonary artery traverses anterior-posteriorly and descends its left pulmonary artery. The right pulmonary artery comes to the left to right direction. So if you, in the AP view, you will not be able to image the main pulmonary artery well. So we are going to the lateral view. In the lateral view, this is the right ventricle, and here the doming valve is the pulmonary valve. Okay, same thing. So here we will cross the same wire, we take the exchange wire and take the balloon across and dilate. Now see here, the basal pressure gradient was 103 millimeters of mercury, and then we are taking the balloon there, and then we are trying to dilate, and you can see here is actual waist. The another portion which you got below the actual waist was the infundibular area, and after dilatation the gradient again comes down. Now here the pulmonary annulus is generally larger than aortic annulus, and the pulmonary valve is much more pliable than aortic valve. So many times when you take the balloon and dilate, the valve will simply expand. It won't crack. It won't, the commissures will not open. And hence, we generally take 100 or 120% of the size of the annulus. It's not like the rupture, the complication of rupture at pulmonary valve is very less. So we are allowed, at times even we take 140%, very rarely take the balloon size and do the pulmonary valvotomy. And unfortunately, the gradient most of the time comes down to very less. See the next one. The follow-up at 6 months and 1 year, see the next line, more than 90% will not need repeat intervention. Whereas in aortic valve, I said more than 90% will need a repeat intervention. In pulmonary valve, more than 90% will not need a repeat intervention. So this is pure pulmonary stenosis, pure aortic stenosis. Now let's come to a tetralogy of Fallot. Tetralogy of Fallot is a surgical domain, but in order to stabilize a child, we do have interventions in the newborn itself. But here is an adult. It's an adult with a tetralogy of Fallot. The injection is made in the right ventricle. The catheter has come from IVC. The injection is made in the right ventricle. As you know, there is a large ventricular septal defect and there is aortic override. You see, that's one of the important component of tetralogy of Fallot. There is a large VST and there is aortic override. So when you inject into the right ventricle, you are expected to see aorta filling and pulmonary artery also filling. Here, where is the pulmonary artery? See, when the right ventricle is filling, only aorta is filling. Pulmonary artery is not at all seen. So actually, it is called acquired pulmonary atresia. There is a severe pulmonary stenosis. The right ventricular infiltration hypertrophy has occurred. Fibrosis has occurred. Pulmonary valve, unless pulmonary valve is calcified and is not opening, you are not seeing any pulmonary artery. This patient presented with a saturation 55%, 17-year-old boy or something like that. But I do know, echo-wise I have seen something like pulmonary valve, though there was no flow. I do know that this is going to be a pulmonary artery. Okay. So what I have done, I have crossed the pulmonary valve and then opening up the valve using the same balloon pulmonary valvotomy. See that? This is a palliative balloon pulmonary valvotomy. And after I do this, now if I inject, see, I am able to see the whole pulmonary. Can you see the pulmonary artery here? So this pulmonary artery was not seen earlier. This right and left pulmonary artery was not seen earlier. Now because I have done the balloon pulmonary valvotomy, I have allowed the right ventricular blood to enter into the pulmonary artery and the saturation improved to 75 to 80% on table. He became very stabilized. When he came, his saturation was 55%, hemoglobin was 24. See, there is a notion that whenever the hemoglobin more than 20, you should do phlebotomy and all. There is no role for phlebotomy in hypoxia situations. If you don't remove the hypoxia, if you do the phlebotomy with the aim of reducing the hyperviscosity syndrome, you cannot get the PCV down to less than 20. The PCV will become 24 in another 1 week's time. So it's not recommended. Rather, you should treat the cause of hypoxia. Here you have treated the cause of hypoxia. It was acquired pulmonary atresia. We have opened up the valve, allowed the pulmonary flow to occur, and subsequently patient improved and the hemoglobin came to 19. Now he becomes a better candidate for a surgery. Had we sent him directly for surgery, he would have had a much higher risk because of hyperviscosity, because of very high hemoglobin. Now he becomes a much better candidate for surgery. Now, this is another important, one of the very common interventions done in adults. This is called coarctation of aorta. This is an AP view, this is a lateral view. You can see that the catheter itself is occluding the lumen. Hardly any blood comes from descending aorta to the, descending post subclavian part of the descending aorta to the rest of the descending aorta. This is the AP view and this is the lateral view. So we do have interventions. Sometimes we do only balloon. In adults, many times we end up doing stenting also. Now here is the stent. You can see the stent here. Okay. These are the two dots of the balloon. Within the balloon there is a stent. I am injecting from below and hence my contrast is only reaching up to the point of coarctation. And then I am deploying the stent. Once I deploy the stent forcefully, it opens up the lumen perfectly. As you can see here, it is taking the near normal flow and the gradient came down significantly. These individuals who are generally hypertensive, the need for hypertension drugs will come down. At times we can totally take away the antihypertensive medications also. They simply need follow-up. Majority, more than 90% will not need reintervention. This kind of stenting procedures. A small percentage will develop aneurysm, small percentage can develop restenosis and things like that, but majority will not need any reintervention. So this coarctation. Patent rectus artery disease, we all know, is relatively one of the common, but the most common congenital heart disease seen in adults is, what is the most common congenital heart disease seen in adults? It's ASD, it's not PDA, it's not VSD. In children, if you ask, what is the most common congenital heart disease seen in children, it's VSD, but in adults it is ASD. PDA is not that common, okay. So practically all PDAs are amenable for transcatheter closure, even in premature children. However, murmurless or echo ducts should be left alone. There is no advantage. So which kind of PDA have higher incidence of infected endocarditis? Small PDA, moderate PDA, large PDA? It is moderate to large PDA. It's not small PDA. The incidence of infective endocarditis is higher in moderate to large PDAs, not small PDAs. It is the reverse of VSD. In VSD, large VSD doesn't have the risk of infective endocarditis. It's a moderate to small VSDs will have higher risk of infective endocarditis. Okay, so infective endocarditis prophylaxis has to be given for small VSDs. But a small PDA hardly develops any infective endocarditis, and hence, unless there is a murmur, unless it is clinically relevant, there is no point in chasing and closing. Okay, so this is one of the small PDAs you can see here. The catheters come from descending aorta into the right ventricle through the PDA, and it is into the aorta. And here was the PDA. Now I am injecting a coil, and it's a very simple technique, hardly takes less than 10 minutes. This was small PDA for coil closure. More than 2 to 3 millimeter PDA, we generally go for device closure. Now comes the most important atrial septal defect, which is the most common intervention done by adult interventional cardiologists also. So here this is the SVC, this is the IVC. Now here I have a central opening, which is called ostium secundum opening. This is left atrium. So what do? We take a catheter from below, come to the RA, cross the AST, take the catheter into the left atrium also, and then bring the sheath there and then deploy this device. So this device has two components, one left atrial disc component and right atrial disc component. These two discs will hold on either side of the defect. Not that we are exactly placing a round kind of one plate and just closing the AST hole. Surgeons do that. Surgeons take exactly the same shape of the ASD, they either the pericardium or whatever the diaphragm patch, and suture there. So they have one layer. They have one layer of artificial membrane or their own patient's own pericardium closing the ASD, surgeons. But we have two layers of disc. One disc is on the left side and another disc is on the right side. See here, I am coming from above, this catheter is coming from SVC. When it scratches the intra-atrial septum, it just slips into the ASD and goes into the left upper pulmonary. Not it goes, I am just pushing. Okay. So the catheter, when it comes from SVC, falls into the ASD and I am pushing it to the left upper pulmonary vein, and we are taking the sheath across. And then through the same thing I am bringing the device. You can observe that I am bringing one disc initially that's sitting in the left atrial side of the ASD, and bringing another disc that is sitting on the right atrial disc of the ASD. You can see again, you can watch again, it's coming again. You can see here the left atrial disc is coming out. Now here, and then I am releasing the right atrial disc also. And once I confirm everything using the echo, and I am releasing, and it is taking its good course. Okay. So these are the techniques to follow for the moderate size ASD or ASD with good trims. At times ASD can be very large. What we will do, we will deploy one disc in the left pulmonary vein and then deploy the RV disc also, RA disc also. And after some time that disc will come and close the ASD. So this is the technique where we use for those ASDs with thin rim or very large ASDs. Like in this example also, like I am partially deploying to the left upper pulmonary vein purposefully, so that the disc remains there. I am deploying the right RV disc, RA disc. Once I deploy the RA disc, the LA disc comes and automatically falls and closes the defect. This is atrial septal defect, moderate size or large defect. Even a 35, 38, 40 millimeter large ASD can be closed, provided there are enough rims all around. Okay. Now, these large defects are seen only in older individuals. In another 10-15 years time, you won't see any adults having large ASDs, because nowadays there's excellent school programs that are going on. Even a small murmur is being brought to the notice of the cardiologist or the general physician. Echoes are being done, and most of these ASDs are getting close in the childhood itself. So in another 15-20 years later, very rarely you see adults with ASD. Okay. So this is ventricular septal defect. We have 4 types of ventricular septal defects. One is perimembranous ventricular septal defect, one is inlet defect, one is outlet defect or subpulmonic VSD, okay. Another one is muscular defect. Of the 4, the muscular defect most of the time closes spontaneously. Very few will need surgery or interventions. All of the 4 defects, the one which closes more commonly is muscular defect. Inlet VSD and subpulmonic VSD, inlet VSD and subpulmonic VSD are in the surgical domain. There is no way we can do transcatheter management of inlet VSD and subpulmonic VSD. So we have transcatheter management for either muscular VSD or perimembranous VSD. As I said, muscular VSD most of the time closes spontaneously. Very few are left for us to close. So most common VSD that is being targeted for transcatheter closure as of now is perimembranous VSD. Now this is a perimembranous VSD. As you can see here, the catheter, this is in the left ventricle. Here is the aorta. Below the aorta is the VSD, and through the VSD you can see the right ventricular filling. Okay. And if you see the reports, you can see the echo report mentioning a subaortic VSD, isn't it? So this is older term, but we use as perimembranous VSD here. The left ventricle injection is showing the flow through the VSD into the right ventricle. And then we have done the AV loop formation. What do you mean by AV loop formation is that, basically this catheter has come from descending aorta, gone into the ascending aorta. Through the ventricular septal defect, I have come to right ventricle. Through the right ventricle, I have come to RA, then RV, and into the IVC. So we have this wire which has been taken from the aorta, gone through the VSD, come to the right side and come out through the right femoral vein. So it's called atrioventricular loop. Once you form the atrioventricular loop, we are taking the catheter into the hole, and then I am deploying the device. You can see the device sitting there. I am injecting and checking the position of the device. In this situation, the device is not in right place. My echo also showed the device is not in right place. So I further pull up the device, take a proper position, and then release. After releasing, this is the angiogram. See that? Now the device is completely occluding the VSD. And now that the same 15 ml was injected. Earlier when I injected 15 ml into the left ventricle, you were not seeing the left ventricle very well because many of the contrast was escaping into the right ventricle. Now here, there is no contrast escaping into the right ventricle. You are seeing the entire left ventricle very densely filled. Okay. So this is another perimembranous VSD, as you can see here. It's a relatively small VSD. What I showed earlier was a moderately large VSD. Here's a relatively small VSD. We have another method called retrograde method where we cross from the same thing. We cross into the right ventricle, but we won't do a AV loop. We deploy the device from the aortic catheter itself. So we are deploying here the device from the aortic catheter itself. After checking the position, okay, and then we have deployed the device, and this is the result. So first example, what I showed was a moderate to large perimembranous VSD, where we had done the AV loop and we had closed the VSD through the venous side. We have taken the device from the venous side. Now here we have crossed the VSD from the arterial side and deployed the device from the arterial side itself. So this is another way of closing the thing. And after we do that, you can see that the device is very close to the aortic valve. Perimembranous, by definition, the hole. How do you define a perimembranous VSD? It is a VSD which is formed by aortic annulus on one side, tricuspid annulus on the other side. Okay. So when you put in the device, tricuspid valve generally doesn't get compromised, but many times aortic annulus and aortic valve can get compromised. So how do you check on table? We do aortogram and see that aortic valve is not compromised and there is no aortic regurgitation. Okay. I told you that muscular VSD, and this is one example of where this muscular VSD, you can see the conical muscular VSD here, and then the muscular VSD has been closed with the device. Okay. So these are the common interventions done in congenital heart diseases. I purposefully avoided the complex interventions which we do. If I start talking about them, you may forget the very common interventions. And again, I purposefully avoided the neonatal interventions, which are very interesting and technically much more challenging. So I thought I'll stop with this so that you all will go with the idea of what we do with the common congenital interventions. Thank you very much.
Thank you, sir, for the enlightening session. Now I would like to request our chairpersons of the session, Dr. Balaganesh Kamaraj, Pediatric and Fetal Interventional Cardiologist, and Dr. Balasubramaniam, sir, HOD of Department of Cardiology, Madurai Medical College, and Thiruloga Chandran, sir, to come on to the dais for felicitation.
Sir, B.R. Jaganan sir, he is not attached with any medical college, but we used to call him as Professor B.R. Jaganan because he used to teach us to our students and to us, and whenever there is any complex congenital heart disease we want to intervene, we invite him for guiding us, and he has guided us for so many years. So we call him as Professor B.R. Jaganan. Thanks.
I request our chairpersons to felicitate our speaker. I request Dr. Thiruloga Chandran sir to felicitate Dr. Balaganesh Kamaraj sir and Dr. Balasubramanian sir.
Thank
கற்றது கைமண் அளவு கல்லாதது உலகளவு என்ற ஔவையின் கூற்றிற்கிணங்க கால்சியம் பதிந்த இருதய குருதி நாளங்கள் சீரமைப்பின் தற்போதைய அணுகுமுறை கரண்ட் அப்ரோச் டு கால்சிஃபைட் கொரோனரிஸை பற்றி கற்றுத்தேர்வோம். இன்று நம்மளுடன் மதுரை மீனாட்சி மிஷனிலிருந்து மூத்த ஆலோசகர் இருதய நிபுணர் மருத்துவர் செல்வமணி அவர்கள் வருகை தந்துள்ளார். பன்முக திறமை கொண்ட இவரை மேடைக்கு தாழ்மையுடன் அழைக்கிறோம். Chairing this session would be Dr. Bharatidasan sir and Dr. Balachandran sir.
Good afternoon, everybody. I thank the organizers and Ravi sir for calling me here, and it's always a pleasure being here, that too with Dr. Ravi. With his superb service for all these years, we have been very familiar, and I think he has done a great service for this society and for the fraternity. And at this outset, I'm really privileged to be with you here, sir. And with these few words, and I was told that there are a lot of PGs here who would like to listen to basically what we do for calcified coronary arteries. And I'll just go to the talk with this. And basically, what you should do is basically in imaging. So today, I have been requested to talk more on imaging, but more than that, along with imaging, I'll tell you how practically we approach a calcified lesion. See, on an angiogram, you are all familiar. There is an opacity, what you see. When you see calcium, even before you inject the dye, then probably you are identifying a calcium on an angiogram. But in an OCT as well as probably an IVUS, these are the two major modalities of imaging that we have. So what happens is, this is how a calcium looks on an OCT. That means the lesion calcium is a low attenuation. That means light actually passes and you can actually see the entire structure of calcium with OCT. So this is how calcium looks on OCT. This part is a fibrous part that you are seeing in an OCT here. And lipid, if at all you want to see the lipid, it is going to be very dark, which will not concentrate much. Today we are concentrating on calcium. So this is how a calcium looks. So in an IVUS, calcium looks like this. See, as ultrasound cannot pass through the calcium. So what it produces is, it produces a shadow behind this, and you see a bright structure like this, and after that you cannot see anything behind it. So, but look at this in OCT, you can see the behind, or you can see the entire calcium structure. So this is the exact difference between an IVUS and an OCT, but both are excellent tools for identification, and there are certain advantages and disadvantages here. See, actually, if the calcium looks like this in an IVUS, you can clearly see the thickness of calcium in the OCT, which you cannot make out on the IVUS. IVUS, we cannot make out the thickness of calcium, but OCT clearly tells you the thickness. And basically, for example, look at this. If our calcium is not very thick, and here the calcium is very thick, both images look same on an IVUS. But here on OCT, look at this. This is a very thin calcium, but here it's a thick calcium. So that is the advantage of OCT over an IVUS here in a calcified lesion. And of course, there is one more thing. What we should know about calcium is a calcific nodule. Nodule is projection into the lumen from the calcific plate here. So on an IVUS, calcific nodule looks like this. It's a projection. On an OCT, it looks like this. And many times you might have, this is actually the calcific nodule projecting from the calcific plate. Sometimes you can get confused with a red thrombus to an probably a calcific nodule. Red thrombus also can resemble, but only thing is, usually calcific nodule, when you see that, the base of the vessel will also have calcium. That is one point to differentiate. And probably red thrombus is seen in an acute MI. Probably you pass a balloon, it might disappear. So there are some differentiating points. And then with this, what I would like to say is, we have different type of scoring for both IVUS as well as OCT. which we will go through later if at all there is a time. Previously we used to call it as rule of 5, but today we have rule of 3s also in OCT. And today our main aim is how do you treat calcified lesion optimally without creating complications. That is optimal and safe management. That is what is our approach going to be. So now there are few conditions like for treating a calcific lesion, we have so many algorithms. Like for example, whenever there is a calcified lesion, there are two possibilities you can have. Whether, first of all, after wiring, whether the balloon or the microcatheter can it cross or not. If it crosses, we have different options. Once the balloon crosses, probably you do an imaging with OCT or IVUS, and then you take a decision depending on what type of calcium you see on imaging. For example, if the score of calcium is very high, that is if the arc is more than 180, thickness is more than 5 and the length is more than 5, probably you need some extra devices. Like generally we use non-compliant balloon for angioplasty balloon dilatation, but here we tend to use additional balloons like probably scoring balloon or a cutting balloon, or today we have an intravascular lithotripsy balloon. So that is the approach here. But with this, the main problem is before that, if your balloon itself is not going, then there is a big problem here. So you cannot just use common technology like what balloon in a case where in spite of wiring your balloon is not going. So for such cases we have other atherectomy devices which I will show you in definitely other series of cases. One specific thing you all should remember is NC balloon is a very important balloon in all angioplasties. And only thing is when you are using an NC balloon, many times if it is a superficial calcium, like as already told, you cannot probably may not be in a position to track this balloon where we tend to use atherectomy devices. And how this NC balloon works is usually it doesn't have much effect on the calcium, especially if it is eccentric. Usually it cuts the shoulder of the calcium where the normal vessel is there and it produces some lumen expansion. And probably if it is a very thick calcium, according to Akasaka and Nakamura, they have said that if the thickness is more than 500, generally NC balloon may not be sufficient. And of course, we have seen that in circumferential calcium, NC balloon can be useful in many cases. But whatever devices you use, finally to treat the calcium, NC balloon is the last device to expand your stents adequately. So NC balloon is very, very important, and probably that is not the only thing that we have. And whenever you say calcium, and angiographically it is difficult to say, but you should say whether it is a deep calcium, a nodular calcium or a superficial calcium. Superficial calcium means it is an intimal calcium where probably it creates problem in taking your devices through. Deep calcium is probably very deep. You need some devices which has pressure or effect in the deeper tissue. So that is what is very important in deciding which modality of treatment you are going to use. And nodular calcium is, which I already showed you, a projection into the lumen. And we'll just see a case here. For example, a case where you cannot cross the balloon or a microcatheter. So this is a case who was severely calcium. So angiographically, when you see here, if you see an opacity like this, even before the dye comes, then probably you are seeing this on both sides of the vessel. And looking at this, we generally say it is a severely calcified lesion on an angiogram. But just looking at the angiogram, you cannot make out where is the calcium. Many times, just an adventitial calcium, that is calcification of the adventitium, also can give you the same picture on an image. And probably to decide whether you need an atherectomy or not may not be so adequate. So if at all it permits, imaging is an ideal tool to decide or to decide in what you want to do in calcified lesions. So this lesion is a severely calcified lesion. See, I am trying to take the balloon there. So when I am taking the balloon here, look at this guiding, it is just backing out. And I am just trying to push the balloon, it is not going. So what happens is actually there is a lesion, a calcium here, which is not allowing the balloon to cross. So in such cases, what do we have? We generally today, in a balloon non-dilatable lesions, two options or three options we have. Traditionally, we have been using rotablation. So in this case also, what I did is, after that I tried to take a microcatheter. So this is the microcatheter going there. See, microcatheter is also not crossing that point here. It is getting stuck there. So what I have done is, you can't take any balloon or treat this lesion. Next option is an atherectomy device. So I keep the microcatheter tip here up till whatever points the microcatheter goes, and then I have exchanged it to a rota wire. So rota I have just crossed there, and then once the rota is crossed, this is the rotablation that I have done here. And once you do a rota, what happens is the calcium thickness comes down, lumen improves, then it is very easy to track the whatever devices you have. And of course this patient had a slow flow after rota, which we will not discuss much because that's not the point of interest today. And after that, this patient was put on IABP due to slow flow, and then left main stenting was done with OCT guidance, which I will show you a bit later. And similarly today, so the case which I showed you is almost around 8 years old, and now whatever case we have like this is, for example, it has a case here where there is a significant LAD as well as a circumflex lesion here, and you see here similarly the balloon is not crossing here, and even the microcatheter is not crossing at this point here. I am just trying to push the microcatheter beyond this point, so it is not crossing there. So in such cases, again what you do today, what I have done is I have changed it to a Viper wire. Viper wire is a wire which we use it in orbital atherectomy. So this is what I have done is, then this is the orbital atherectomy being done there. So what I have done is, with a rotation of 80,000 speed here, slowly cross the lesion with orbital atherectomy. And once you cross this, then of course the story is very, very, very clear. At 80,000 we do, and then if the vessel size is more than 3.5, we go with 1,20,000 revolution in the orbital atherectomy. So after orbital atherectomy, or whatever, even if rota, you do imaging, so you will see that why this patient, we could not cross the microcatheter itself, because it was a very severe calcific nodule as well as a concentric calcium. And after orbital atherectomy, what has happened is, you can look at the OCT here. So this is, there is something like a shaving, what we call as the sanding effect. Orbital atherectomy has sanded this lesion, and then you see this area, and with this sanding, what has happened is the lumen is increased and thickness of calcium has come down, and with this we can track any balloon now. See, after that I have just tracked the balloon and then deployed the stent, and this is post angioplasty. The entire stent expansion is very good. And very important point with calcified lesion is, if you leave an underexpanded stent, chances of restenosis is very high, and at the same time stent thrombosis is also high. So before you take a stent in any calcified lesion, make sure that there is an excellent lumen gain, and probably you take 1:1 sized balloon, you dilate the entire lesion and see whether there is any waste or the balloon is expanding properly. That is one way if you don't have an imaging. But if you have an OCT, it is better, or IVUS, you can confirm that the lumen is well expanded and then deploy the stent there. And the same patient had again the same microcatheter non-crossable lesion in the circumflex also. So this was also treated in the similar way, which I will just jump and go to the next case due to probably the in view of time. And circumflex was also treated. And today what we have is, we use another modality in balloon and wire not crossable lesion is lacing. So look at this case here. This is an 88 years old lady who she had triple vessel disease and severe significant lesion here. So you look at this RCA, it is a severe calcified lesion here, and then very critical lesion and unstable angina. So in this patient, what I have done is, we have used lacing here. So laser, we have different terminology, what we call it as fluency and rate. So initially we started with a lower fluency. The first term indicates the fluency. Fluency means the amount of energy you deliver. And the next term, this represents the rate, at what rate per minute it is delivering that energy. So 40-40 was the initial, and then gradually what I have done is, see, this is the lacing catheter that you are seeing. It is something like a thrombectomy catheter. It looks an angio, but it's a laser which is getting delivered there. So once you lace it, and we can increase the energy to 60-60, and we can lace it with blood, or lace it with saline, or lace it with contrast. So each has different energy, and then probably this is how we treated the 60-80 with blood, and then probably this is the OCT images, which is very, very important. It will not only that you are just doing this procedure, it will give you an understanding how we have done it, so that it is going to improve your next thinking. When you get a similar case the next time, unless you do imaging, you will not understand what you are doing there. So what this laser has created here is, see, it has expanded the lumen to such a good extent, and you can make out significant fractures also here, and there was some significant nodules also which was laced, and it was expanded very well. And after this preparation, as usual, I have just put a stent there, and the stent is, this is the stenting, and after expanding, so look at this, a severely calcified disease, and that too a long lesion, and with just lacing, with expansion, excellent expansion. And normally, even if you do atherectomy, or if you use cutting balloon, whatever it is, you will not get such expansion in such type of calcified lesion. Here, after lacing, I have not used any cutting balloon or NC balloon, this scoring balloon, plain NC balloon was used. What happens is, when the vessel is laced, the entire tissue becomes softer, and it makes the stent to expand very easily, and utility of very hard balloons are definitely reduced when you use lacing. So this is for the lacing today. And coming, this is the post-lacing DS deployment, and this was the first result, and then this was immediately after lacing, even without ballooning. It was looking like this, and this is the first final stenting after lacing here, after DS. Then next comes the next important scenario. One is, you cross the balloon, but if you are unable to dilate with the balloon, even if you put a OPN balloon or a very high pressure balloon, you dilate, still the lesion is not opening. So what are you going to do there? So two important scenarios. One is, balloon and microcatheter non-crossable lesion is very important. Unless you do atherectomies like laser atherectomy or orbital or rota, you cannot treat that case. And similarly, a case where instead of putting balloon, if it is not yielding, what can you do there? So for that also, atherectomies are very, very useful. So this case here, he was actually, I had something like an anterior wall MI. He was attempted outside in some hospital where they had some difficulty, so they referred to me. And I did an angiogram, it is looking like that. So it is actually, you can feel that it is like a thrombus, and ECG having changes in the LAD territory. You think probably this is a thrombus there, an anterior wall MI. But actually what happened is, once we put the balloon and started dilating, the balloon is not yielding at all. Actually we tried to put all high pressure balloons and just trying to open it, it is not opening. So what to do in such cases is, again the same three things that you can do is, we try to take all the balloons, and this is the angiogram with which we were left. So I did a rotablation. So this is probably, again as I told you some 4-5 years back, rota with 1.5 bar, and with rotablation the lumen improved, and after rotablation you put a balloon there, and I did a OCT. You see the OCT, it will tell you why the balloon was not yielding. See, when you see there is a significant concentric calcium in the OCT. So to be quick, I'll show you a still image. So there is a tight concentric calcium, what we call it as napkin ring calcium. So this type of calcium is one where balloon does not yield properly. So what happens when you do rota, probably it is reducing the thickness of calcium, or because of the heat generated, there is some change in the texture of the calcium. Then you put a balloon, then the balloon expands. So this patient, after that, you see that balloon expanded very well. And then as usual, after that, we have stented. And with stenting, with a very good result there, with TIMI3 flow with excellent expansion. And similarly, today, this is a recent case here, probably some 3-4 months back. Again, an anterior wall MI, a ST elevation MI, and you look at the angiogram here, very tight lesion there, and then you see that it's almost TIMI2 flow there in the LAD. And then what we have done, try to put a balloon is not expanding at all. Significant waste there. So today it was an acute MI with slow flow, balloon not expanding. This is a very worst scenario. Probably laser is one of the best treatment for such cases. You take laser, a balloon non-expandable with a thrombus, you will have very safe thing. You can treat both thrombus as well as calcium without producing slow flow. That's an advantage. But this case, what we did is, we left it on that day. The next day morning, again we took him for the procedure. I have used orbital atherectomy here with different speeds, and then with excellent stent expansions, we have an excellent result here. And I think my time is running out, but it was an excellent, if you don't mind, if I can extend it for 5 minutes, I'll show you other, I can, no? Yeah. So this is the orbital that you are seeing, that it is an excellent result with orbital there. And moreover, one more thing is what I would like to show you here, where nothing works. For example, in a vessel where there is probably a under-expanded stent. And one more point you should remember is, how do you select what you are going to use in which patient? Basically, you will have to look at the vessel size, tortuosity and bends. If it is a severely tortuous, and then probably vessel size more than 2.3, all these devices are very useful in vessel more than 2.5. In a vessel less than 2.5, better don't use any atherectomy including laser. And probably look at the distal vessel caliber. Although the lesion is in proximal with calcified, if the distal vessel is diffusely diseased, thin vessel, if you use orbital or rota, very high chances you will get slow flow. So in such cases, use laser. And probably if in the presence of thrombus, either you cannot use rota as well as orbital. It's a problem. So you go for laser. Look at the LV function. If the EF is very low, again rota is high risk, orbital is also risky. So EF 25% and less is almost a near contraindication for both rota as well as orbital. And of course, if it's a single vessel serving all the coronaries, probably you should not do rota in such cases. So keeping all this in mind, if there is, for example, somebody has attempted, he has already created a dissection, and again using a rota in this dissected vessel is a problem. So you look at all the scenarios and then decide which device you are going to use. And coming to other last 2-3 points which I would like to say is, as and one more point is, what we should know, many people, they think how laser works in a calcified lesion. So we all believe that intravascular lithotripsy works in calcium. Similarly, laser also produces something called as cavitatory bubbles. So this is how it looks here. And the energy produced, for example, intravascular lithotripsy, the amount of energy produced is 50 atmospheres. And with laser, if you give with saline, the atmosphere pressure which produced is around 25 atmospheres. With blood, it is 50. And if you give it with contrast, it is 120 atmospheres. So it has an excellent effect, something like an IVL, where you can treat the entire length of the vessel and produce very good results. That is an advantage with this. And very important, some more point as learners, like for example, PGs who are interested in knowing this, how to avoid complication in a severely calcified lesion. See, for that, we should always know the distribution of calcium. You cannot just take a decision and say that I will get a good result without producing perforation. For that, what you should do is, when you do an imaging, you will get 5 scenarios in a calcified disease. What are those 5 scenarios means? You can have an eccentric calcium here, but just opposite to that calcium, there will be a normal vessel. That means the media is normal. So in such cases, even if you get slightly an under expansion, results are slightly inferior, don't try to chase this vessel to produce excellent result, because you will have a perforation just opposite to the calcium. I have examples for all the cases, all type of scenarios, but due to time, probably if possible I'll show you. And you will get a nodular calcium, something like if it is just opposite to probably a fibrotic lesion, or if it is just opposite to the calcified lesion or a deep calcium. Very important is the first scenario where you should be very, very careful. I'll show you this interesting case here. Look at this circumflex. It was balloon dilated, looking a very simple circumflex lesion. When you do an OCT here, actually what we are seeing is, see, there is a calcific nodule just at the circumflex here, and you just look at the vessel opposite to the, see, this is a calcific nodule, look opposite to that, which is looking completely normal. So there is a calcific nodule just opposite to this, it is very, very, very normal vessel. So we stented that, and we thought we will take an 1:1 balloon and expand very well. See, what happens, you see, is the moment you do that, see, it is a perforation here. So anyhow, the perforation we try to control with balloon expansion. It stopped and again reoccurred, so I had to put a whatever it is a covered stent. And on imaging, this is how a covered stent looked like. It looks like something like a eclipse, where bright thing behind that you cannot see anything. It's a covered stent OCT run, which we will skip faster. And similarly, look at this case here. There is a nodule. When there is a nodule here, you look at the opposite segment here. So if it is normal, don't try to chase this lesion. So what you can do is, even if it is slightly an underexpanded stent there, see, after stenting, it is not allowing the stent to expand, and probably you can accept this underexpansion or malapposition, whichever is there. And if the lumen area is adequate, don't try to chase it. You come out, you will be saved from perforation. So this point you remember. And in other scenarios, for example, if there is a nodular calcium opposite to deep calcium, and we will just skip all these cases, you can go ahead and chase with 1:1. And if it is a circumferential calcium, it is 360-degree calcium, means probably you can go with 1:1 vessel size, and then you can dilate it adequately. And in many lesions, for example, a case like this, where you look at this, so even it is green here, a vessel where you look at this significantly long lesion where there is calcium which is present there. What you can see there is a calcium from ear to ear, and angiographically you will not know where what is there. So you can do an OCT and you can co-register. For example, at this section, see, whatever mark I have put is, at this mark, this is the thickness of calcium. At this mark, this is the thickness of calcium. So you can mark the thickness of calcium at different level. And the area where there is a very thick calcium, probably you give more shocks with IVL, or you give more laser treatment at that spot. You can decide how to treat with this case here. And I think we got an excellent result with this. And I think one point, in whatever way you have in the calcium distribution, if the opposite area, if it is normal, better avoid chasing that lesion. Even mild underexpansion is okay, or slightly undersize the balloon and treat. In all other possibilities, like especially if it is a concentric calcium, You can use 1:1 balloon size, and you can get an excellent almost 100% stent expansion. So I think I'll stop here, and before stopping, one more scenario what we have is, if somebody comes with instant restenosis and you have a stent which is not expanding at all, something like this, he comes 2 years after angioplasty with ISR, and you put a balloon and you try to dilate this ISR. If nothing is expanding, see here, in spite of balloon dilatation, nothing is expanding. Not stuck. Okay. So if nothing is working, again here, when you do an imaging, you will know that there is significant calcium behind the stent. For example, in a ISR case here, if there is a calcium behind the stent, if you are unable to open this calcium with your routine balloon dilatation, what options do we have is, probably many people have tried IVL, but IVL also may not be very useful in such cases. Yeah. Yeah, it is not coming. I can understand that. அது ஏன் வரல பாரு, இங்கே வருது. Full screen வரட்டுமா? One last CD மட்டும். Yeah, it is come. See, if there is a calcium just behind the stent, what happens is you cannot expand the balloon stent with routine balloon dilatation. Here what we have done is, there was significant calcium behind the stent there. So I have used lacing in that case here. And after lacing, what you can demonstrate is, see, this is, I am going fast, the stent which is under expanded because he had calcium all around the stent there. So it was not allowing, so he had under expansion, he has come back with restenosis. We tried with balloon, it is not expanding at all. But after lacing, you see here, there is significant fracture even behind the stent. So you can make out that there is, here, sorry. Yeah. So you can see that this is the stent here. After lacing, there is a calcium fracture behind the stent also. Here it is fully under expanded stent because of the calcium. And this is the post-stenting after lacing and balloon dilatation, an excellent expansion. So these are some scenarios where you cannot use routine NC balloon. Probably in such scenarios, you need this extra atherectomy devices like orbital, laser, as well as rotablation. And of course, NC balloon is always a must. In selected cases, probably when you are not using this devices, when your thickness of calcium is less than 500 or just around 500, you can use NC balloon, this scoring balloons, and cutting balloons might be useful. Otherwise, it is always better use these devices to get excellent stent expansion. I think with this I'll stop here. Thank you so much.
Thank you for the knowledgeable session, sir. We now request the chairpersons, Dr. Bhadithasan sir and Dr. Balachandran sir, to felicitate the speaker, Dr. Selvamani sir.
ஆராய்ச்சி என்பது முடிவற்ற உண்மை தேடல். ஒவ்வொரு கேள்வியும் ஒரு கண்டுபிடிப்பை தோற்றுவிக்கிறது. ஒவ்வொரு கண்டுபிடிப்பும் 1000 புதிய கேள்விகளை எழுப்புகிறது. இப்பொழுது நாம் இதய அறுவை சிகிச்சை தொடர்பான மருந்துசார் அல்லாத ஆராய்ச்சி, அதாவது நான் கிளினிக்கல் ரிசர்ச் இன் கார்டியாக் சர்ஜரியை பற்றி தெரிந்து கொள்ளும் நேரம் வந்தடைந்தது. சென்னை வெங்கடேஸ்வரா மருத்துவமனையிலிருந்து ஆலோசகர் மற்றும் இதய அறுவை சிகிச்சை நிபுணர் மருத்துவர் என் மதுசங்கர் அவர்கள் சிற்றுரையாற்ற இருக்கிறார். அவரை மேடைக்கு தாழ்மையுடன் அழைக்கிறோம்.
We are really privileged to have him, who was once the best outgoing student of TVMC. Over to you, sir.
See, it's a great honor and privilege to be here. Basically, because I am from this medical college. I joined here in '84 and finished in '87. Just quickly 10 slides about research in cardiac surgery. The research in cardiac surgery mainly consists of clinical data collection and going on research. We have done few large animal experiments. This is non-clinical research in cardiac surgery. I will show you one of the experiments what we have done. Non-performing research is an injustice done to our next generation. So if you are careful, if you are carrying your next generation, you should do research. This is Dr. John Walton Lillihai. I met him in 1994. He has done the first open heart surgery in the world, even before the discovery of heart-lung machine. That is the cardiopulmonary bypass heart-lung machine. He connected the mother and child with the femoral artery and femoral vein by a pipe tube, and then operated on the child and produced successful results. So we did the first heart transplant in 1995, and we did the first heart and lung transplant in the year 2000 in Madras Medical Mission, and our team performed the first lung transplant in the country in year 2010. So heart transplantation basically consists of orthotopic heart transplant, where the heart is excised and you keep the heart in the same place. Heterotopic heart transplant consists of take out the heart and keep the heart in the chest as an additional heart. See, two hearts are there. Whereas you can keep the heart in the abdomen also. The aim is to assist the patient's native heart and to maintain the circulation in patients not fit to undergo orthotopic heart transplant or heterotopic heart transplant in the chest. So, but still, orthotopic heart transplant remains the standard technique and is preferable whenever the patient meets the current criteria and a suitable organ is available. So, can we keep the heart in the abdomen? So, that is the question. So, in an otherwise unfit patient, he is unfit to undergo the regular orthotopic heart transplant or heterotopic heart transplant. This is a heart from a dog. So, what we do is, we connect the dog's heart, the SVC of the donor heart is anastomosed to the IVC, and the aorta is anastomosed to the abdominal aorta just above the bifurcation. So what happens is, the blood goes from the IVC into the SVC, right ventricle to pulmonary artery into the left atrium, left ventricle, and reaches the aorta. This is a phase 1 study which showed the survival of the dog as well as whether it improves the cardiac output. So the heart is kept inside the abdomen and connected the way I showed you. Here you can see the heart beating in the abdomen. That is the dog which we operated, taken to the post-op ward, and where we showed the contractility and the survival of the dog. This is basically from a pilot study conducted in US, where they did not allow the heart to survive and they euthanized the heart animal, whereas we allowed the heart to survive and we did the post-operative study. It was done with the permission from the central government, and it came in Times of India as a publication. Lifesaver dog plants second heart in the tummy. So a world without research is a world without knowledge. That is me with Kamal Hassan and my boss who postulated this concept, Dr. K.M. Cherian. Thank you for your attention.
We now request Dr. Selvakumaran sir to felicitate Madhushankar sir.
மிக கூர்மையான கவனமே பலத்தின் பின் மறைந்துள்ள ரகசியம். இவ்வரிகளுக்கேற்ப அதீத கவனத்துடன் துல்லியமாக மேற்கொள்ளப்படும் அறுவை சிகிச்சை தான் குழாய்வழி மைட்ரல்வால் தசைப்பிடி அறுவை சிகிச்சை, பெர்குட்டேனியஸ் டிரான்ஸ்வீனஸ் மைட்ரல் கமிஷரோட்டமி. படிப்படியாக இச்சிகிச்சை எவ்வாறு நடைபெறுகிறது என்பதனை புரிந்து கொள்ள மதுரை மருத்துவக் கல்லூரியில் இருந்து இதய நோயியல் துறை தலைவர் மருத்துவர் பாலசுப்ரமணியன் அவர்களை பணிவுடன் மேடைக்கு அழைக்கிறோம்.
தலைமை தாங்குபவர்கள் மருத்துவர் ரவிச்சந்திரன் எட்வின் அவர்கள் மற்றும் மருத்துவர் பாலச்சந்திரன் அவர்கள்.
குட் ஈவினிங். ரவி சார் வந்து என்னுடைய கிளாஸ்மேட்டு, அப்புறம் ஹீஸ் மை ஃப்ரெண்ட். இங்கே உங்கள் அசோசியேட் ப்ரொஃபஸர் பாலச்சந்திரன், திரு மணிகண்டன், 2 பேரும் என்னுடைய 3 பேர் ஸ்டூடெண்ட்ஸு. Now I will talk about the mitral commissurotomy. இது வந்து நான் எங்கள் சென்டரில் நாங்கள் லேர்ன் பண்ணதை வச்சு I will talk. So any patient with symptomatic mitral stenosis, they should be submitted for PTMC if there is no contraindication. So contraindication வந்து if the patient has a LA clot or the Wilkins score by echo is more than 8, then we cannot able to do. And suppose if there are any other contraindications for fluoroscopy, we cannot do that. So these are the indications. Those who are asymptomatic but they have severe MS, they can also be submitted for PTMC. If they have a history of embolism, they can be submitted. Or if the exercise induced pulmonary pressure is high, then we can send the patient for PTMC. So this is if the patient has symptoms but the patient needs PTMC but the valve anatomy is not suitable for PTMC, we send the patient for surgery. So these are the contraindications for PTMC. So a LA clot or moderate MR, or if there is a bicommissural calcium that will not allow the valve to dilate. This is the Manjunath sir has given a criteria depending on the location of the clot. So of that, if the patient has a clot inside the LA appendage, we can attempt PTMC. And if the patient has a clot outside the appendage, and if it is not coming in the plane of our access, so if it is in the roof, not mobile thrombus, again we can try PTMC. Other clots we should not attempt. This is the common Wilkinson score we use during assessment. So this includes the you have 4 criteria. One is the mobility of the valve, another one is the thickness of the valve, then the caudal involvement, then presence or absence of calcification. So simply if the calcium is involving only the tips of the mitral valves, we can send the patient for PTMC. Suppose there is a commissural calcium, we should not send the patient for PTMC. Same way, suppose the valve tips are thicker but the body of the cusp is not thicker, again we can send the patient for PTMC. This thing echo, M mode, all of us know about the picture of mitral valve in M mode. Is the This is the AML, this is the PML. So the thickness is increased both. These are some calculations we make on the echocardiogram. This is the 2D image of the same patient. So this thickened AML, thickened PML, the valve opening is reduced. This is the 4-chamber view. The LA is dilated. The valve is not opening adequately. This is the Doppler flow. This is what we see in 3D echo, transthoracic. So we can see both the leaflets which are thickened. We can exactly measure the size of the valve opening in 3D echo. This is the normal valve, how it looks in 3D. This is the transesophageal echo. Routinely we do TE to assess the valve and also look at the LA appendage. So this patient has this LA appendage is free of clot. And T also gives an idea about the thickness of the IAS. So here it looks a little more thicker IAS. This is the left atrium, sorry. This is the left atrium, this is the right atrium, this is the SVC, this is IVC. This is 3D TE. So we are looking the valve through the left atrium. This is the mitral valve. It is stenotic. So routinely we stop the oral anticoagulant 5 days before the procedure and we put the patient on heparin. And we give endocarditis prophylaxis before the procedure. For PTMC, these are the hardwares which we use. So the regular femoral access sheaths. This is 6 of arterial sheath. This is 11 of femoral venous sheath. This sheath, larger size sheath, is used at the end of the procedure. So this is the pit-tail catheter. This is the multipurpose catheter. This is the PTMC balloon. So this is this is the broken bone needle. This is the mulling sheath with a dilator. This is the septal dilator. The size is 11F. So we dilate the puncture site and also the IAS through this septal dilator. So this is 11F. So when we close after ending the procedure, we close the puncture site through this 11F sheath only. So this is the PTMC balloon. We have different types of balloons. So what we commonly use is the Acura balloon, and the original balloon was Inau balloon. The major difference between the Inau balloon and this Acura balloon is this balloon has this is the balloon. This has 2 layers of balloons, 2 balloons, and this is made of rubber. Inau balloon has 3 layers of balloon, and the outer balloon has a small opening in the center, and the outer balloon is longitudinally corrugated. It is a best balloon to use for a PTMC. It was so designed when the balloon ruptures inside the cavity, the rupture occurs in a longitudinal fashion. So whenever we want to withdraw the balloon, we can easily remove the balloon because it ruptures longitudinally. This Acura balloon may rupture in the short axis. It will be difficult to remove the balloon from the LA. So this has 2 lumens. This is the 1 lumen where it goes through the wire, and this is the one to dilate the balloon, inflate the balloon. So this is the stretching tube. This comes with this balloon set. This goes inside this golden knob. This is to keep the balloon stretched when we insert the balloon inside the femoral vein. So this is the LV entry stillet. This is needed for guiding the balloon once we enter the LA into the LV. This is called a LA wire or a coil wire. So this coil is softer and it is spring-like, and the body is very stiff, and this supports the balloon. So as a standard procedure, we start with instilling local anesthesia in the groin. Usually it's done through the right femoral axis. And unlike PTMC, where we introduce a sheath and we are not going to manipulate the inguinal region much during the procedure, because we are going to do everything through the catheter only. But in PTMC, we are going to manipulate the groin for longer time, so the anesthesia should be adequate. So we give enough dose of local anesthesia. Sometimes we would repeat the dose, the procedure is prolonged. The puncture is we can do under the fluoro guidance or under ultrasound guidance. So nowadays, to avoid complications, many of us prefer puncturing the femoral artery or vein under ultrasound guidance. So this is ultrasound probe. This is the regular glove. The probe is inserted into the glove, and we can use for easier puncture. So we candidate both the femoral artery and the femoral vein. And femoral artery, I prefer to puncture the femoral artery first, so that we can give adequate space below to when we puncture the vein. Because when we do PTMC, you have to manipulate that balloon. It will disturb the femoral arterial sheath and the catheter. So you give enough space below. So first puncture the artery, then do the venous puncture. So this balloon is coming from translumina. This is designed like inaugural balloon, but it has only 2 layers of balloon. But there is another port at the cup for vent of that balloon. So in Acura balloon, when you inject the dye into the balloon, it will come out of the balloon near the cup at near that white knob. So this is there are 2 ports here. So we check the balloon whether it is intact before doing the procedure. So actually we are preparing the balloon. We are removing all the air inside the balloon by injecting saline into the balloon and removing through the another port. because it is going to the LA. Suppose you are dilating the balloon inside, it ruptures with the air, it will produce immediate air embolism, which may develop the acute MI or stroke. The next thing is we have to size the balloon. This is done outside the body. So this is the sizing scale. We measure at the waist of the balloon. So the sizing is done by according to the patient's height. So it is the height in decimeter plus 10. Suppose patient is 1.5 meter, it is 15 decimeter, and add 10, it is 25 millimeter. So the by should be set as 25 millimeter. So by and the balloon comes in 23, 26 or 24, 28 like that. So we can size according to the patient's body weight, height. And this scale is a sliding scale. The volume we take in the syringe is not the same as the balloon size. So each balloon will have a different volume for that given diameter. So we cannot go with a volume of the dye we take in the syringe, and we cannot equate with the size of the balloon. For any balloon, the volume will change. Next. So this is the process of stretching the balloon. So the balloon has two lumen. The central lumen is for passing the stretching tube. So the stretching tube is called a silver tube, and it has a this is the pass panel. The period pass panel. Pinadi pass. So this is the white knob that is present in the balloon. This tightens the golden knob here. So this prevents movement of this golden tube which is inside the balloon. This is called a silver, a part of the stretching tube. What we do is, first we unscrew this white knob so that the yellow portion is free from the main balloon. So it will come out of this white knob, so that will be looser. And the first step is you insert the stretching tube inside this yellow knob and you lock it. So before introducing the whole thing into the balloon. After locking to the gold, then the gold is locked to the white knob. So this will stretch the balloon. Some operators prefer to pass that LA wire through the balloon, the distal end, to prevent damage of the balloon when we stretch the balloon. If we stretch the balloon without, suppose we keep the golden part with the balloon and we put the stretching tube, that will damage the balloon. So always unscrew the golden knob and remove it from the balloon, then put the stretching tube, then stretch it, then introduce the whole thing into the balloon. That will prevent damage to the balloon. So then as a routine, we introduce the pigtail catheter into the aorta and we keep it in the distalmost or the lowermost portion of the aorta, that is the non-coronary cusp of the aorta. And this is a landmark for the PTMC is done under fluoro, but it is all done as an imagination. We don't know where the IAS is and we cannot see the IAS, but we assume it is going to be somewhere here with some landmarks. So the landmarks here is, one is the aorta. So aorta is the anteriormost portion for the IAS, and the IAS lies behind the aorta. And first we record the pulmonary pressure. This is the multipurpose catheter. So this patient's pulmonary pressure is 49/20. The mean pressure is 33. It is elevated. Let's keep on. So after introducing the pigtail, we introduce a multiple purpose catheter. That catheter goes to the RV, pulmonary artery, we record the pulmonary pressure. Then the same catheter is brought to the left subclavian, and we keep a wire in the subclavian. We remove the multiple purpose catheter, and then we take this Mullins sheath with a dilator, and we remove the wire. We keep the Mullins catheter inside the left subclavian. Next. Next. So this is the broken bore needle that is introduced into the Mullins sheath. So this broken bore needle has a distal curvature. So when we introduce this this broken bore needle, it is stiffer and it has to turn in the, whenever the vessel is heavy curve, it should be allowed to go into the curvature its own. Don't force that, otherwise it will pierce the catheter and will come out. So allow it to go freely. So you push it, remove your hand, so it will take its own shape and then slowly introduce. And this, the shape of the distal curvature can be modified according to the patient's IAS structure. If it is a straight IAS, we can make a more bend in the distal curvature. If it is already the IAS bulging, you have to make it straight. You reduce the curvature, then the puncture will be easier. Next. So once you gone to the left subclavian, you bring the Mullins sheath slowly down into the SVC, and once you cross the SVC, it will fall into the IAS, and you slightly pull it down, then it will fall into the fossa ovalis. Sometimes the IAS is very thick, you may not feel the fall. Under fluoro, you can see if it is, it has come down below the aorta, then you stop it. You go to the lateral view and see where it is. So this is the spine. The spine is the landmark, that is the posteriormost portion of the LA. So IAS stops before this spine. So IAS stops here, and IAS starts here at the behind the aorta. So your IAS somewhere from this point to this point. We can assess the length of this IAS or the height of the IAS by the left bronchus is the roof for the left atrium. So you should not go beyond that, and the diaphragm should not come well below near the diaphragm. So it is somewhere here, your fossa ovalis. So you can position this Mullins sheath somewhere here, and we inject some dye. So if it is IAS, it will get stained. So you can see this is already, there is some dye has been given, it is stained, this is the IAS. Then just below that, we are trying to puncture the IAS. So the needle has been punctured. So once you puncture, you introduce the Mullins with the dilator. After that, you remove the dilator and the needle together. So you record the LA pressure there. And after that, you introduce keep it. So introduce the LA wire. This goes through the Mullins sheath, and this shape should assume like this as a round. And if it is not, it has turned to somewhere, you just rotate this Mullins sheath, it will turn to the LA like this. This is the better positioning of the LA wire. The LA wire has a in the tip, it has a small knob. It will not perforate the left atrial wall. After that, we remove the Mullins sheath and we introduce this. This is the dilator, septal dilator. This is the larger one. So you bring down to the right atrium and push it into the left atrium through the IAS, and don't go beyond the left bronchus. That is the upper limit of your poking. So after that we remove the dilator, we introduce the balloon. This is the stretched PTMC balloon, it goes inside. So once you go into the left atrium, you unscrew the white portion of the balloon. That will loosen the balloon, and you unlock the silver and remove the stretching tube and introduce, you push the balloon inside. Next. So once you enter the LA, this the balloon is in the LA, then you introduce the LV entry stillet inside the balloon. So you keep this, check this pigtail whether it is in the aortic root. Sometimes it will slip into the ascending aorta. So you may be falsely thinking that is the root of the aorta. So you always reintroduce the pigtail again into the aorta. So this is by two techniques we can enter the LV. One is sliding technique, another is just pushing. So either you push with the stillet inside the LV, or you just slide it over into the LV. Here they have just slided over the balloon over the wire. It has entered the LV. Next. Hold on. Flip it. I think the one is not running. So once you enter the LV, you inflate the balloon. This balloon is designed such a way that the distal balloon inflates first. After that, the proximal balloon inflates, then the waist inflates. So once you dilate in the distal balloon, you pull the whole thing proximally, so it will get stuck in the mitral valve orifice. After that, you inflate the proximal balloon, then you inflate the waist of the balloon to the full size quickly. And when you dilate the distal balloon, you see whether the balloon is round or irregular. If it is round, that means it is inside the true cavity of the LV. You have entered the LV cavity through the valve, and it is not get stuck with any of the trabeculae or this subvalvular apparatus. So if the balloon is irregular, then you deflate it, remove the balloon from LV, you reintroduce into the LV, you check with the balloon inflates as a globe like that thing. It should be round. And there should not be any air in the balloon during inflation. So after that, again you check, you introduce the pigtail into the LV, and we record the pressure. So this is the simultaneous recording of the LV and LA. So there is no pressure gradient in diastole. So both are touching each other, this line, base line. So that means it has been fully dilated. There is no gradient at all. Next. So the success of PTMC is decided by the reduction of gradient more than 50%, or absolute increase in the size by 1 centimeter, or if the valve area is more than 2 centimeter. That means it is successful PTMC, and there should not be increase of MR by more than grade 1. If it is already grade 1, grade 2 MR is accepted, and we are not going to do PTMC for MR more than grade 1. So there is the problems when we face during this PTMC. One is at the groin. Some people, not all people are thinner with mitral stenosis. So we study that patients with mitral stenosis will be cachectic and they are not obese. We come across patients with obesity and mitral stenosis, and here it is very difficult to push the balloon into the femoral vein and into the iliac vessels during the procedure. Sometimes it will be very difficult. The anatomy of the inguinal canal may not be flat like this. and the femoral artery may be overlaying over the femoral vein. So it is very difficult to puncture the femoral vein. So whenever you puncture the vein, the artery will puncture then only will be able to puncture the vein. So it should not be done. So sometimes we have to put another wire from the right side into the femoral vein of the right side, right side, to keep it as a fluoroscopic marker. And over that we under fluoro we direct our needle towards the wire in the femoral vein. So we have come across 2 patients like that. We were not able to puncture through the right femoral vein. It is very difficult to do a procedure from the left side because the broken needle is designed for doing the procedure through the right femoral vein. So if we go to from the left side, it will make another bend. So it will be very difficult to manipulate the this puncture needle inside the right atrium. Very rarely we do this procedure from jugular also we can do. So we had a case of severe kyphoscoliosis, and his IVC was tortuous, so we were not able to do a procedure from femoral vein. We attempted from doing jugular, but we were not able to puncture the IAS, so we dropped it. And so this one complication we came in our cath lab. So this LA wire, this is the tip, and this coil portion is welded with the straight portion here. So when we introduce the septal dilator will be stiffer, and unless you are very careful, this will cut this portion. So suppose if you find any difficulty in negotiating this dilator into the wire, you just bring it to the right atrium, just pull this wire back, you pull the wire back into the RA, and it will go inside the dilator, and then you push the dilator. Don't force this dilator. This is what happened here. So forceful pushing resulted in this got cut off. So LA were caught inside the LA. We have removed it. So we introduced another sheath with snare. What happened was we think that wire is very stiffer, it won't cut off, but this got broken. When it was brought down, one bit got broken, it went into the iliac vein down, and some portion of the wire got inside the LA. We could remove only part of the coil wire, but there was no any effusion, and patient was stable, so we left that wire inside the LA. It was sealed up with the LA wall, and we were following up the patient. Patient was all right. See, this portion is kept in the LA. It is there in the LA. Then we finished the patient this case after putting another wire. So here what happened was even the LA wire can perforate the LA. So after successful puncture of the IAS and passing the LA wire into the LA, when we introduce the dilator, that LA wire can perforate the free wall of the LA. That has happened. So every time when you do a septal puncture, what I do is once you puncture the septum, I ask the assistant to do an echo to look for any effusion or hemopericardium. And after once you do that, after that once you enter the with a septal dilator, again you check it. Sometimes what happens is suppose the LA is very huge and RA is also enlarged, and in the posterior portion when you puncture this broken needle will puncture the RA free wall, will come out of the RA and go to the pericardial space, and then will enter the LA, will puncture the LA and will come to the LA. So your wire will go and will sit in the LA, but once it will not be seen in the fluoro because the wire will not produce much bleeding. But once you introduce the dilator, now it will damage the RA free wall, LA free wall, patient will die on the table because of large hemopericardium. So always when you do a septal puncture, you do a echocardiogram before dilating the septum. And this patient developed perforation of because of this broken bone needle, it has gone beyond the left bronchus. So it has produced rupture in the perforated the roof, and we put a pictal in the, this is the pictal inside the pericardium. We aspirated, and if it is this broken bone needle induced perforation, that will seal off. So you dilate the left mitral valve, so the pressure will come down in the left atrium, so the bleeding will stop. So after procedure, you give protamine to revert the effect of heparin. That will get sealed. So you keep the pittage for 1 day for observation, and you can remove. Suppose if it is some balloon induced or this dilator induced, we cannot arrest that bleeding. You immediately send the patient for surgery. So the guideline says the procedure should be done where surgical facility who are capable of doing immediate mitral valve repair or replacement. It should be done in that setup. This is the thing which we should not do. So this balloon has a lot of air. So this will, if the balloon ruptures, then produce air embolism. And this is our department statistics over these years. It was started in 2010, and that year was 44, and up to 14 we are doing, 2 years we are doing. So after that some drop, and during this period no cases for 3 years, and after that slowly again we started doing it. And these are the AMC PTMCs for the past 5 years. So last week we did 3 PTMCs. All three patients were pregnant patients, consecutive 3 patients pregnant patients. So we get a lot of rheumatic heart disease in pregnancy, and like PT is increasing in number nowadays, like that we get more number of rheumatic heart disease recently. Every day we get one pregnant lady with a rheumatic heart disease. This 3 years gap, I just want to assist the medical college, I want to stress one thing. So the senior persons has to train their juniors during their tenure to do all the procedures. Then only that will be sustained, that this type of procedures. So this was done during Professor Amudan sir was our HOD. I was a student, and then I was assistant professor at that time. And we were doing only structural intervention we were doing was this PTMC in those days. And once he got retired, and there was a gap of 3 years, nothing was done. Then after that, when I became a chief in 2015, we got a patient of rheumatic myelinosis with the pregnancy complicating this severe MS complicating pregnancy. So at that time we were not doing that. So I asked our dean to arrange one ambulance to send the patient to Chennai MMC, and she shouted at me, "You are 7 people as cardiologists in the department not doing anything. Why can't you do that?" Then okay, madam, we will you try to get these things and we will do it. So we bought that everything. She bought it. Then at that time, all of us were new for that procedure. What I have witnessed was somebody doing procedure. That was by doing. So we asked from cardiacs from outside. There was Sivakumar came to our from Meenakshi Mission to our department, and we recruited 2 technicians from outside. And that was the first index case was a pregnant lady, and that was successful procedure. So after that, routinely we started doing that, and slowly we increased the number of cases. In 2022 we have done 103 PTMC. That means every 3rd day we are doing one PTMC like that. So after we are doing routinely we are doing PTMC. The complications are very less. We lost 2 patients. One is with infected endocarditis after the procedure. You can see she was a pregnant lady. She developed infected endocarditis. She was discharged. She came back after 2 months with infected endocarditis, and we lost that patient. Another patient was PTMC. She developed severe MR. She got severe MR. At that time, she was just delivered. They were not. She was not willing for surgery, so she went home. After 2 months, he came back with a severe pulmonary edema, and we lost that patient. And procedural failure is hardly 2 patients. One patient was very thick septum. We attempted twice. We could not cross the septum, so we sent the patient for surgery. And one more patient, because of the hyposcolia, we could not do it. Otherwise, if it is done carefully, it is a very safe procedure. And everybody should know to puncture the IAS with a broken bar needle, because all your intervention in the left side is going to be after puncturing the septum. So I request all the juniors to concentrate on to learn the technique of puncturing the IAS with a broken needle without any complication. Now we have TE and we have 3D TE. So we can, under the echocardiogram, 3D imaging, we can puncture IAS wherever you want, in the center, posterior, inferior, anterior, posterior, wherever you want, according to your procedure. So nowadays we do paravalvular leaks also. From after this we have done 3 or 4 paravalvular leaks that needs puncturing of the IAS in a correct position for ECA procedure. We do it under TE. For routine PTMC we don't use TE, but under echo guidance we do it. Thank you, sir.
உங்கள் முத்தான கருத்துக்களை கோர்த்து தந்தமைக்கு நன்றி ஐயா.
We now request Dr. Ravi Edwin sir and Balachandran sir to felicitate our speaker Balasubramanian sir.
ரவி சார் பையனும் என்னோட பையனும் கிளாஸ்மேட்ஸ் MBBSல.
Thank Professor Bala for having come all the way from Madurai and gave a wonderful lecture on PTMC, the need of an hour. Because we all know the pregnancy, after PTMC, the outcome is far better and the mortality comes down. And he is the pioneer in doing PTMC, sir. That's why I brought him here, and we were friends from 1982 onwards from Madurai Medicals. Thank you, Bala. Thank you so much.
One case we took as advanced pregnancy. She was about to deliver, severe MS. She was brought in pulmonary edema. We allowed the patient. She was brought somewhere from, I think, from Tanjavur. She came to our college in an ambulance. She was intubated, and with the ventilator, we took the patient to the cath lab. We did emergency PTMC, and the patient survived, and the baby was also there.
மதிப்பிற்கும் மரியாதைக்கும் ஒரு குருவை கௌரவப்படுத்துவதில் எங்கள் துறை மிகுந்த பெருமை அடைகிறது.
I wish Professor Ravi Edwin for a dynamic post-retirement life.
Now, before ending this cardiology summit, we would like to have an audiovisual presentation of the journey of the Department of Cardiology of TIRUNELVELI Medical College from a single room to the big department it is right now in our super specialty hospital. So we will proceed with this video now.
office staff were so cordial and very friendly to all of us, and they made it very lively. Thank Revati and team. Revati and team, thank you so much, Revati. And so really on behalf and all my staff, I thank all my staff. All my staff was sitting here, my cath lab staff, ICCU staff, everyone. They came at 7:30. We had a photo shoot at 7:30. Even I was late. Everyone came at 7:30, and it was a great appreciation. I thank from the bottom of my heart to all my staff, and not the least students. Students were very cordial and friendly to us, and all the students are still there. So really I thank, on behalf of our department, I thank all our students, and all our gold medal winners were also there. And next year also the Cardio Summit 2026 will happen at the same auditorium, or probably my assistants will do it in the better auditorium, because it will be a bigger crowd. Because to start with, we were just thinking of 50, 60 like that. But every day the count was increasing. Today the count was 350. So we couldn't control the crowd. So that was the huge response. We never thought like that, because it was a 5-day holiday. It was a 5-day holiday. Yesterday it was a holiday. Now today is a holiday. Monday is a holiday. So no students were there. So in spite of all those holidays, making such a conference is really God's grace. Thank you one and all. Thank you for this wonderful event. Thank you so much.
reached the end of the Cardiology Summit 2025. Before signing off, I would like to thank Dr. Ravichandran and Edwin sir for providing us with the opportunity for hosting this event. And I would like to give a big thanks to all the professors, faculties, senior residents, and staff of the Cardiology Department who helped us with hosting the event. Thank you all.